on for years, conducted by the Neurological Society of India, precisely the Board of Education, chairman being Professor Manas Panigrahi. And today we have an exciting session on neurocritical care. And to introduce this, I invite Professor Manas Panigrahi, the chairman of the Board of Education, NSI, to take forward and introduce the course to all the delegates.
Thank you, Dr. Suchanda. Good morning. And I'd like to welcome on behalf of Neurological Society of India, all of you to participate in the 6th super specialty webinar of the society. The webinar started 6 years ago with the concept of disseminating knowledge among the young practicing neurosurgeons who have come out of their within 5 to 10 years of their course. Normally, we have it physically where 100 young neurosurgeons come to a particular place, and then all the faculty are there to teach them. But for the past this year and last year, we are doing it online as it is physically not possible. And here, normally we invite participating country, international society outside from other country. And last year we did with US, the previous year it was with UK, and this year we have with the European Association of Neurological Surgeons, and we have 2 faculty from EANS, and 90% of the faculty are from NSI. For the past 3 years, also we have started, 2 years we started publishing update. So this the 3rd time will come with a volume of all the people who speak will come with, they have to write down chapters, and that will come as update 3. So I hope all of you enjoy the program, and the theme of why we decided neurocritical care for this year. This was the idea of Dr. Muthukumar, and so he'll be the right person to tell that why this theme was selected for this year.
Next, I invite upon our President of Neurological Society of India, Professor Lokendra Singh. Sir is the Director of Central Institute of Medical Science at Nagpur. And besides being a neurosurgeon with lots of accolades, he is also a prolific writer, not only in English, but mostly in Hindi, and is a regular columnist on the newspaper dailies, as well as he writes many poems and this one. So he is the current president of Neurological Society of India. And I request you, sir, to say a few words before we start with the academic stuffs.
Thank you very much, Suchanda, for a nice introduction. And I must congratulate the Board of Education. It's doing a wonderful job, and Manas is an amazing team Manas has. I think topic is again extremely important, and obviously Muthu's brainchild, and he will talk in detail about that. But this topic is extremely important. It's very relevant. And ENS and NSI, the joint venture will definitely bring fruits to all of us, to the young neurosurgeons, and exchange of ideas and knowledge will be very fruitful to all of us. I'm very sure, I have a little bit about this, that how many neurosurgeons would like to leave the surgical art, which they learn over years, and they hone their expertise with the hands, and then go back to critical care. So that remains to be seen, but it may be a very fascinating possibility probably. And today's topics will unfold probably these things, and many young neurosurgeons may start thinking about it. I don't know. But all in all, I think it sounds very exciting topic. I wish this whole venture a very good, successful, run. And I think I would not like to really eat a lot of time. So thank you very much for inviting me here and asking me to speak few words. Thank you very much.
Now I ask our dynamic secretary, Professor Muthukumar sir, and he is the secretary of Neurological Society of India. He was previously the head and professor of neurosurgery at Madurai Medical College, and now post-retirement he is pursuing his neurosurgical practice at Devadas Multi-Speciality Hospital in Madurai. And sir has many publications, and he is also a seasoned speaker in all the neurosurgical forums. He has a keen interest in pediatric neurosurgery, and it is sir's idea to have this topic for the neurosurgeon. So over to you, sir, to tell us a few words about this.
Thank you, Suchinda. And good morning, and welcome to this super specialty CME program. Just to give you a brief recap, this super specialty CME program was started in the year 2016, and this was the brainchild of my predecessor, Dr. V.T. Singh. And it was the first CME was on the topic of pediatric neurosurgery. The idea of this CME was to promote subspecialization among younger members of the NSI. And the second CME was conducted in 2017. It was the topic that was covered as glioma. In 2018, it was neurotrauma. In 2019, it was degenerative spine. And last year, in 2020, it was cerebrovascular. This year, we have chosen an important topic of neurocritical care because, as we all know, there are three pillars of good outcome in neurosurgery. One is a meticulous preoperative evaluation. Third is a very good operative technique. Second is a very good operative technique. And finally, last but not the least, a dedicated and postoperative care is necessary. So neurocritical care is emerging as a separate subspecialty with its unique challenges that can no longer be dealt with by a general intensivist. And it is imperative that the neurosurgeons should also know a significant amount of knowledge about neurointensive care, because not all neurosurgeons are fortunate enough to have a neurointensivist in their institution. So in view of the above, the Board of Education led by Manas decided to choose this topic for this year's CME. And as has been the custom for the past 3 years, from 2019, the proceedings of the CME were brought out as a neurosurgery update. And this year's proceedings will be published as Neurosurgery Update 3, and it will be released in the next physical meeting, probably next year. So finally, let me conclude with my congratulations to the Board of Education for an excellent program, and thanks to all the participants and speakers for taking the time to contribute to this program. Thank you.
So we are done with the introduction of the course, and now we will go straight ahead with session 1. And the first speaker of this session is Professor Matthew Joseph from Vellore. He is the professor of neurosurgery of Christian Medical College, Vellore. He is also the president of currently the Neurotrauma Society of India, and is the vice chancellor of College of Neurocritical Care. So over to you, Professor Matthew, sir, for your talk on neurosurgeon and neurointensivist. Is there a need for subspecialization?
Thank you. Can you see my slide?
Yes, sir.
Okay.
Ready to go.
Right. So I'll begin my talk basically in 2 parts. Part 1 is neurointensive care, a separate specialty. Okay. Yes, there is no doubt about it. I have a slight conflict of interest to declare here. The Society of Neurocritical Care has set up a 1-year fellowship in neurocritical care, and there is a college to administer the fellowship, and I'm the vice chancellor of the college. Okay, so there is a conflict of interest here, but I sincerely believe that neurointensive care is not something you can do 1 day a week or 2 days a week. If you're doing it, you have to do it full time, or at least almost full time. Okay. The basic ideas of critical care are the same. Maintain good ABC for your patient. But the nuances are very, very different. All right. So I would say that you have to be almost full-time neurocritical care to do a good job. Okay. You cannot do a small proportion of your time looking after neuro patients. Tomorrow I look after cardiology patients. It's completely different. Neurocritical care patients you want to keep well filled. Cardiology patients you can't give fluids. Unless you're a super brilliant person, your brain is not going to make the switch very easily between the 2 different specialties. Right, so that disposes of question 1. Second thing is, should neurosurgeons have intensive care training? All right. I'll start with an old paper, 2009. The AANS and CNS put out a position paper. I've got 3 excerpts from it, which I will partially read. The one is that perioperative care of the patient, that means pre and post-operative care of the patient, are not independent aspects of care. Okay, they should be part of the overall continuum of care of a neurosurgical patient. The second is, they say that due to the nature of neurosurgical conditions, it is essential that neurosurgeons are proficiently trained and educated in the care of these patients. Third part of the same position paper is that the educational training requirements, okay, in critical care will be evaluated in the American Board of Neurologics. This is the primary certifying body for neurosurgeons in the US, will be evaluated in the written examination and the oral examination. Critical care will be evaluated. Right? Now, if you look at it in India, the condition of neurocritical care in India, in many places, residents, neurosurgical residents and faculty manage neuro ICUs with or without the help of intensivists, anesthetists. Okay, the knowledge is quite poor, because can you see a busy neurosurgical resident in a busy neurosurgical posting, having to do emergencies, having to run to the ER, having to go to theater, spending time reading about, say, ARDS? Yeah, it's very, very, very unlikely. So very often what the person runs on is what his senior colleague told him. My senior told me to do this, I will do this, and I will pass on the same information to my juniors. And therefore the care level is not scientific. What is given to the patient is what I was told, right? And even if you have an intensivist, you know, maybe an anesthetist, maybe an intensivist, hopefully a neurointensivist, and the neurosurgeon is talking to that person, it is from a position of weakness, because you really don't know what they're talking about. Okay, this is your patient. The intensivist says we have to increase the PEEP. Okay, if you are reasonably up to date, you'll know that PEEP stands for positive end-expiratory pressure. You know that much. But increasing the PEEP, what will it do to the brain? What will it do to the blood pressure? What happens to the brain, is it acceptable, not acceptable for that particular patient? You have no idea, because you've never done this. You never thought about this before. This is a patient I got, this is long ago, before I had other people with me, when I was alone looking after the neuro ICU. The huge meningioma who came late one evening. He was 15 by 15, but severe headache, bradycardia, hypertension, etc. So we said, rather than doing it in the middle of the night, we'll do him as first case the next morning. For some reason, the neurosurgical resident who admitted the patient referred the patient to cardiology because the patient's BP was 190, 110. Cardiologist came and saw and said, start GTN infusion to bring down the blood pressure. Can you imagine the disaster it would have happened? The vasodilatation, the drop in blood pressure, the ischemia of the brain, it would have been a disaster. Luckily, because GTN is not a drug we use routinely in the neuro ICU, the nurses didn't know how to dilute GTN. So they called me to find out how to dilute GTN, and I was able to stop it. But this is what happens when somebody with no knowledge of the drugs, the systems, tries to manage a patient. It becomes a rule of thumb, which often doesn't work. Okay, and the sad thing is, because we've always been doing it that way, it's been done that for many years, we don't really realize that things could be much, much better if some science came into the picture. Right? I have learned so much from my colleagues, where things I did before, which I thought were absolutely logical, I found were wrong. Okay. How much are our residents exposed to intensive care? It's not a required posting. In our program, in the first year of the 6-year program, they have spent a month in the ICU. The 3-year program, they spend no time in the ICU. Okay? They also have trauma postings. Our trauma is not tremendously busy. We admit only about 600 patients a year. All right. So they have time to think. So they're supposed to be in the ICU when they're not dealing with a head injury acutely. But unfortunately, I mean, human nature being what it is, They would be in their room, and when called, say they are busy with a head injury. Okay? At least they have to attend rounds. So they pick up some critical care knowledge, but that's about all we do, in spite of me being a convert to neurocritical care. Yeah, in an ideal situation, you'd have good neuroanesthetists, a neurointensivist, frequent, good communication with them. All decisions are made joint. It'll be fantastic. But unfortunately, this almost never happens. So should neurosurgeons also be trained in intensive care separately? The ABNS, again, most of the online data available is unfortunately only American, so I have to keep quoting that. The American Board of Neurological Surgery has a separate module for neurocritical care. The Committee for Advanced Subspecialty Training in the US, again related to the American Board of Medical Sciences and the ABNS, has 3 subspecialty courses, what they call RFPs, Recognition of Focused Practice. There are 3, only 3. They are pediatric, endovascular, and neurocritical care. So obviously these people see the need for a separate neurocritical care training program for neurosurgeons. This ABNS is the American Board of Neurological Surgeons. It is a neurosurgery board administering these 3 subspecialty exams. Next exam is in beginning of December this year. All right. So why is this good? One is, basic training matters. An intensivist and a neurosurgeon will have different areas of comfort. For example, I can read an ECG, but when I read an ECG, it is labor. I have to sit and look at it carefully, count squares, etc. Okay. Whereas an intensivist looks at it casually and says, okay, it shows this. Whereas for me, if somebody shows me a CT scan, I can go, okay, got it. Whereas the intensivist has to look at it square by square by square, making sure that they look at everything. Okay. It's just different areas. What you've done for most of your life, you're more comfortable with than something you're trying to acquire later. All right. So you are bringing complementary skills into the program. I'm not saying the neurosurgeon should be able to do everything the intensivist can do, or that the intensivist should be able to make all the decisions the neurosurgeons can make, including when to operate. I'm not saying that. But when you bring your complement, each of you has your own area of specialty, and then you have an area of overlap. Your patient care becomes better because each of you understands to a certain extent what you're suggesting will do to the other person's specialty. And overall, your patient's care becomes much, much better. And that is what we're all here for, to improve our patient care. So what I would recommend, should there be separate neurointensive care for intensivists? Definitely, yes. Should neurointensive care be training as part of an MCH program? I think it is underemphasized. It should be brought in officially, that they need to have neurocritical care postings where they will learn neurocritical care. Because if they are in that posting, they are more likely to read critical care. If you're in a busy neurosurgical posting, you're not going to read critical care. You don't have the time. Okay. Should there be additional fellowships programs for training of neurosurgeons? That I will leave as a plus minus, because I really don't know how many of our neurosurgeons will have the time. Maybe in the big institutes, yes, but otherwise to spend a year or 2 years training only in critical care is probably unrealistic at this period in time. Right? In the US, they have recommended critical care training 1 year before they become a chief resident. The year before becoming a chief resident, do 1 year of critical care training. Unfortunately, we cannot do things like that. We don't have the flexibility to do things like that. So the last point I will leave as a not a yes. It would be nice, but not essential. Thank you.
Thank you, Dr. Matthew. It was a wonderful lecture. Actually, this was a topic which I had just casually suggested to Manas. I never thought he'll put it up as a separate topic and make it the first in the list. And there are 2 points I'd like to just highlight in your lecture. One is the communication you mentioned. I think it's extremely important that the intensivist acts as the keystone who tries to interact with various specialists who walk into the ICU, including the neurosurgeons, the other pulmonologists, cardiologists, whomsoever it is. So he should be there should be a good communication among the various consultants. It's not sufficient, especially for the young surgeons. It's not sufficient to just write it in the case sheet and walk away. You have to. There are occasions when you have to just talk to the concerned specialist and convey your concerns. It's extremely important. Second thing is, I think time has come that we should emphasize the national board and probably the NMC and change the curriculum that like 15 days, when I was a resident, 15 days in neuropathology was a compulsory posting. So like that, there should be at least 2 or 3 months posting for MCH and DNB residents during their training program. There is no doubt in my mind because it makes a big difference. But at this point of time, I do agree that, as you rightly said, not many surgeons will be willing to take it up as a separate specialty. But maybe in future, when the number of neurosurgeons increase, some might opt for this. If there are any more questions from the panel or I don't see there is something in the chat box.
So no questions are there.
So what is the eligibility for fellowship for neurocritical care? So Matthew, can you enlighten that?
Any basic degree.
Yeah.
Any basic degree. MD, MS,
Okay.
neurology, neurosurgery.
Okay. Fine.
My only problem, Dr. Muthukumar, is how I'm going to write this as a chapter. It's an easy thing to speak on, but as a chapter, it's going to be very, very small. So I'm a little concerned about that.
Yeah, I think, but you can quote all these recommendations from the American board and those. I think this will make a big difference because it's important. It's very important. It may not happen in the future, but then in the foreseeable future, somewhere in the future, it is bound to become a separate specialty, even in a country like India. So now the next question is Deepak Gupta has asked whether neuro ICU should be managed by neurosurgeon or neurointensivist.
I've been already answered.
Yeah, so Dr. Chaudhary has answered one who is trained better. That is a very subjective thing. Okay, fine.
Yeah. Now with intervention, a lot of neurosurgeons means coming intervention as a subspecialty, and then a lot of mechanical thrombectomy has been a SOP for all the strokes. Means if you confine the specialty just for as like what intensivists do, no neurosurgeons will be interested. But if the scope of work includes intervention also, a lot of neurosurgeons are needed actually. We do not have a 24 hours backup in our hospital for stroke care. And so then you'll have the need, there will be a lot of gap. The demand supply will increase. So I feel in future, if the intervention is included as a part of neurocritical care fellowship, a lot of neurosurgeons will be interested. Dr. Bhaskar, you want to ask something?
What are our thoughts on separate pediatric neurocritical care? I'm sure there's a lot of difference between adult and pediatric critical care, Dr. Matthew. I think you guess the answer.
I was just typing an answer to that.
Okay.
I mean, it would be nice, but given the fact that there are so few neurointensivists, now trying to break them up into adult and pediatric, I think is a little overambitious. I think it probably, let's get neurointensive care established first before subspecializing that. I agree, your pediatric and adult is very different. But right now, we are managing both.
Okay, fine.
Okay, probably not optimal, but better than putting them in a pediatric ICU which has no neurointensive inclinations.
Or do you think pediatricians should have some training in pediatric neurocritical care? Let me put it the other way. Pediatricians should have some training in pediatric neurocritical care.
Pediatric intensivists, again, should. They should. I think it's very, very important because, like I said, the approach is different. The approach to neurointensive care is different from general intensive care. I didn't realize how much till I started doing it. Yeah, and how much our general intensivists were not familiar with the neurointensive care part of it. There are very competent people, but neurointensive care is different.
Sir, can I ask something?
Please.
Yeah, please.
Yeah.
All speakers are free to ask.
Yeah, Matthew sir, the thing is that you are having a course for 1 year post MCH. I think in
No.
places
Not post MCH, post MD also.
post MD also, yes. So the thing is that as many of the institutes like ours as well, we don't have a dedicated neurointensive is always posted in our ICUs. It's the neurosurgical resident and we manage. And we know that as days are evolving, techniques are really way behind in neurocritical care. Many things we don't understand. I mean, if you can make, or I just suggest that a module of neurocritical care learning, like case-based learning, which are nowadays everything is online, and that this can be done. There is nothing much which, as you grow up senior, we need to do hands-on. We need to do that. We can do in our place, but if you have case-based module prepared for 3 months or something, I think many people who are in practice as well as in managing ICUs as well, it will be very beneficial because, I mean, I think that can be done, isn't it? We have
Yeah, it's a good idea. The only problem is I'm a very lazy person. So I'm extremely lazy. So I think something's a good idea and then take years to get around to doing it, unfortunately.
I think Sushanta's suggestion is very good because it makes a lot of difference to the residents, but also to the practicing neurosurgeons who don't have the luxury of a neurointensivist. And I am sure it is not only Matthew Joseph. You have a big society of neurocritical care in India. I am aware of that. Some of the office bearers and members are going to speak today. And all of you can contribute and create a small module, which we can use as a ready reference in our day-to-day practice. I think it is doable, Dr. Matthew. I think what Sushanta suggests is a very good idea.
Yeah, actually, the Society of Neurocritical Care, we are in the process of making a manual, a ready reference manual, short, just seizures, do this. Bradycardia, do this, whatever. We're in the process of making a manual. But we've got different contributions now. Trying to make it uniform is a huge job.
Yeah.
Each person writes in a different way. You need uniformity when you make something.
Dr. Anirban has to comment something on the module.
Okay.
Dr. Vishal has asked, what book are you suggesting for young neurosurgeons? So means that is what you are publishing a book on this, or what you are doing it today. But what is existing?
We are publishing a manual now and a book later. We are publishing a manual now, hopefully in the next 2 or 3 months. And the textbook we are working on, that will come later. An Indian textbook of neurocritical care will come later, probably another year or 2. But the manual, hopefully within the next 2 or 3 months.
Yeah,
manual will be ready reference, no theory. The manual will be only ready reference, no theory.
Okay. Dr. Anirban, you are here. You said some book is already there.
No, it is not book. They're working. We are working on a module. The Indian Society of Critical Care Medicine and the Society of Neurocritical Care on creating modules which will be useful for the intensive care trained, because in DM intensive care also, in DM critical care also, they have majority of them have exposure to neuro, but not many. And those who are exclusive neurocritical care, they also sometimes lack exposure to the general intensive care. For instance, I have to cite a simple example. I started getting a lot of requests from the Eans. They started cardiac surgical intensive care DM course, and there were no candidates. And then I realized that who will employ someone who is having a DM but unable to treat a viral pneumonia or an atypical pneumonia. So there are some aspects of general intensive care also which are important to all subspecialties of critical care, whether be it cardiac, be it neuro. So therefore, this module which ISCCM and SNCC is working upon, it probably will be useful for both ends. For the general intensivists, it will help them in incorporating those aspects of neurocritical care, and for neurocritical care intensivists, it will help them grasp those concepts of general critical care.
Yeah. So now it's time for the next program, next speaker. Thank you, Dr. Matthew.
Yeah. So we'll go to the next talk, and it is the very important thing. It's which we face every day. All neurosurgeons deal with it every day: mechanical ventilation and weaning in the brain injured patient. And this will be by Dr. Anne from Hyderabad. She is, but she's not there, I believe, Dr. Manas, sir. Dr. Ann is not here, right? So.
No, Dr. Ann and Dr. Harshal are the main authors of the presentation. Dr. Harshal is there. You'll have a recorded presentation. Dr. Harshal will answer the queries.
So we have the recorded presentation of Dr. Ann, and Dr. Harshal will take up all the discussion. And Dr. Ann is neuroanesthetist at KIMS Hospital, and she manages the neurosurgical patient and the neurointensivist there. So over to the recorded presentation of Dr. Ann and Dr. Harshal.
Good morning. I'm Dr. Ann Campos, consultant in intensive care at KIMS Hospital, Hyderabad, India. I would like to thank Dr. Manas and the NSI team for giving me this opportunity to speak on mechanical ventilation and weaning in the brain injured patient. This is quite a controversial topic, as there have been no guidelines in the past many years. This is mainly because brain injured patients have always been left out of trials on mechanical ventilation and ARDS. In 2020, the European Society of Critical Care formulated clinical practice recommendations based on the findings of an international consensus panel, but there are still many lacunae to be filled. An ongoing VentiBrain study is trying to address this issue, and it is expected to finish sometime at the end of the year. So hopefully we should have some good guidelines in the near future. In acute brain injury, there is a catecholamine surge and release of inflammatory mediators, which makes the lung susceptible to mechanical and non-mechanical injury. The resultant hypoxia and hypercarbia, together with release of neuroinflammatory mediators from the lung, can cause secondary brain damage. Now, although mechanical ventilation helps in oxygenation as well as in control of the carbon dioxide levels, it can have some unwanted effects on the brain. Mechanical ventilation is basically applying a positive pressure ventilation to the lung and during inspiration. This leads to increase in the thoracic pressure, which causes a fall in venous return to the heart. This in turn causes a drop in cardiac output and a reduction in mean arterial pressure and cerebral perfusion pressure. Obstruction to venous return from the brain via the jugular veins results in increase in ICP and reduction in cerebral perfusion. On the lung too, use of large tidal volumes and high pressures, as was being done earlier, has been shown to cause ventilator-induced lung injury as well as increased mortality in these patients. Hence, the need for lung protective ventilation. However, the hypercapnia that is permitted in lung protective ventilation can cause cerebral vasodilatation and an increase in ICP. And the high peak that is sometimes used can impact cerebral perfusion. Therefore, this is something that we do not want. So what is the ventilatory strategy that we need to use in the acutely brain injured patient? The main aims are to maintain oxygen levels, control carbon dioxide levels to avoid hypercarbia, maintain cerebral perfusion, and avoid or minimize lung injury. So how can we do this? When the patient is first put on the ventilator, we need to set the oxygen at 100% and then reduce it to less than 60% as soon as feasible. Our aim is to use the minimum oxygen concentration to target a PaO2 of 80 to 120 millimeter mercury or a saturation of 94 to 98%. Too much oxygen or hyperoxemia not only impacts all the organs badly, but is also known to increase mortality. Carbon dioxide levels can be manipulated using minute ventilation or targeting the minute ventilation. The recommendation here is to use low tidal volumes, low to intermediate, between 6 to 8 ml per kg, and adjust the respiratory rate to achieve a target PaCO2 of 35 to 45 millimeters of mercury. Hypoventilation with hypocapnia is to be used only as a rescue measure, that is, and that too for a very short period of time when there is impending brain herniation. Hypocapnia for a prolonged period of time can cause cerebral ischemia because of cerebral vasoconstriction, and this too is to be avoided. Positive end expiratory pressure is now considered safe. However, PEEP can decrease cerebral perfusion only if we fail to maintain mean arterial pressure because of hypovolemia. Zero end expiratory pressure, which was previously being used, is no longer recommended, and physiological PEEP of 3 to 5 millimeters actually prevents atelectasis and improves oxygenation. The usual levels of PEEP can be used in acute brain injury with or without ARDS if ICP is not elevated, or where ICP is PEEP insensitive, that is usually when the lung compliance is low. When ICP is elevated, PEEP needs to be carefully titrated according to pulmonary mechanics and with close monitoring of intracranial pressure. Whether to use a pressure mode or volume mode in the ventilator depends on individual preference. Usually to start with, a volume mode is indicated and then later on get converted to a pressure mode. But keep in mind that all the targets that we have just spoken about should be met. In the injured brain, there is often loss of cerebrovascular autoregulation. Hence, adequate hydration and vasopressors may be needed to target a mean arterial pressure of about 80 to 85 millimeters mercury in order to maintain a cerebral perfusion of more than 60 in the face of increased intracranial pressure. As far as special maneuvers like recruitment maneuvers are concerned, there is no clear consensus. These maneuvers can not only cause increase in intracranial pressure, but also cause barotrauma. However, they may be of benefit in refractory hypoxemia in patients having both lung and brain injury, but need to be done under close neuromonitoring. Now, COVID-19 has generated a renewed interest in proning, especially in patients with ARDS. Although the prone position in acute brain injury can be challenging and associated with increased intracranial pressure, it remains an option when we consider the negative effects of hypoxemia on the brain. Pauline Bernon, in a small retrospective study, showed that patients who had an ICP of less than 17.5 and who did not develop an increase in ICP in the first hour following proning were safely able to tolerate the next 16 hours of prone positioning without developing intracranial hypertension. So they recommended assessing brain compliance before proning and monitoring of intracranial pressure before and within 1 hour of proning to assess safety of this position. However, we would need to do more trials of this. As I said before, if it is a question of brain injury due to hypoxemia, it is better to prone and carefully monitor ICP. Now, weaning is the act of separating the patient from the ventilator. This should be done gradually and continuously over a period of days. This is started once the patient is hemodynamically stable, has spontaneous respiration, requires little or no sedation, and does not require high ventilatory support. Such patients should first be put on an assisted or support mode of ventilation. The FiO2, respiratory rate, and pressure support should be slowly reduced over time, ensuring that oxygen and carbon dioxide levels are maintained and there are no signs of respiratory distress. Once the patient is able to tolerate minimal ventilatory supports, a spontaneous breathing trial for 30 minutes can be instituted. If the patient fails the trial, ventilator support can be increased. A low GCS is not a contraindication to weaning. The next step after intubation, after a successful spontaneous breathing trial is extubation. This, however, can present a dilemma in these patients as the ability to protect the airway and the neurological status are impaired. Since all the usual extubation criteria may not be applicable in this subset of patients, other scores have been developed. The Visage score has been shown as one of them, and Karim et al. In an analysis showed that a total of 3 out of 4 on the Visage score based on age less than 40, a Glasgow coma score on the day of extubation more than 10, swallowing attempts and visual pursuit would result in an extubation success in 90% of the patients. The airway care score, which focuses on the presence of cough and gag reflex, as well as the amount and quality of tracheal secretions, predicted successful extubation in those patients who had a score of less than 7. A cough leak test is done prior to extubation to let us know whether the patients who are at risk of laryngeal edema and post-extubation stridor. In such cases, extubation should be deferred and maybe steroids would have to be used. Now, early tracheostomy, which is done in less than 7 days in severely brain-injured patients, has been shown to reduce the time spent on the ventilator, as well as adverse nosocomial events, and helps in early discharge to a rehab center. So the take-home points here would be: maintain normoxia and normocarbia, use low to intermediate tidal volumes and enough PEEP to avoid lung inflammation while maintaining adequate mean arterial pressure. Keep a watch on ICP and CPP. Hyperventilation only to be used as a rescue measure. Weaning and spontaneous breathing trials to be initiated as early as feasible. Extubation is not contraindicated in low GCS, and the Visage score can predict extubation failure. Early tracheostomy could be associated with better outcomes in the brain-injured patients. These are the references that I have used. And I would like to thank the audience and Dr. Harsh especially for kindly agreeing to field questions in my absence. Thank you.
Yeah, thank you, ma'am.
Thank you, Dr. Ann and Dr. Harsh. I think there's a very clear, lucid presentation with plenty of take-home messages. I think every neurosurgery resident should see this recorded presentation of Dr. Ann because it has a lot of messages. I just have 2 questions before we take any questions from the chat box to Dr. Harsh. Can you elaborate on permissive hypercapnia, which you briefly mentioned? What is permissive hypercapnia and what are the implications for neurosurgical critical care?
Yeah, permissive hypercapnia is a strategy in which a patient who are hypoxic, say a patient with severe ARDS, we permit some amount of carbon dioxide in lieu of buying some amount of oxygen. So permissive hypercapnia is allowing carbon dioxide to allowing carbon dioxide to rise somewhere around 60 to 65 in lieu of maintaining a proper oxygenation of around 60 to 70. So that is known as permissive hypercapnia. We generally apply these in patients with severe hypoxia, say a patient coming with severe ARDS. When we are applying high PEEP, then there is a tendency of carbon dioxide to rise. So we don't care too much about the carbon dioxide till it reaches 60, 65, so that we can concentrate our efforts on maintaining a proper oxygenation. So that is known as permissive hypercapnia that we do in normal patients. But in neurosurgical patients, that permissive hypercapnia, definition of permissive hypercapnia is vague, because we cannot allow carbon dioxide to get beyond a point, because it has deleterious effects on the neurosurgical patients.
So that's my question. So is it applicable in neurosurgical practice? Is hypercapnia applicable in neurosurgical practice?
Yeah. So as we know, for a short rises of carbon dioxide, okay, yes. But prolonged hypercapnia and permissive hypercapnia, as we allow in normal patients, normally ventilated patients, non-neurosurgical patients, no. Permissive hypercapnia definitely will be deleterious to the patients in the long run. It causes cerebral vasoconstriction, and it will lead to ICP rise in the prolonged phase. So permissive hypercapnia in neurosurgical patients, definitely we don't allow it.
The next thing is about, can you just elaborate on prone positioning and during ventilation in neurosurgical? This is not frequently being discussed. Prone positioning in neurosurgical intensive care.
Yes, prone positioning during neurosurgical, we generally, all the trials that we have, the proning trials that we get, the proning trials generally exclude neurosurgical and acute brain injury patients. Definitely, they don't fall into the trials. So it's an area in which not much work has been done. So if you don't get anything in the guidelines. If you go through the European guidelines as well, there is no consensus statement on proning, basically. But because of the COVID epidemic, we had a lot of neurosurgical patients getting into COVID and getting into severe ARDS. That was the time when these dilemmas were always there with us, whether to prone these patients or not. There are few studies, one that was mentioned in the presentation as well, in which they have seen the effect of proning, prolonged proning, and its effect on the ICP. So definitely, as we prone the patients, definitely there is a direct correlation with the rise in ICP. But we have to also find a sweet spot between oxygenation and the rise in ICP. So if the patient is having severe ARDS, and we have failed our recruitment maneuvers, and proning is necessary, then we can do proning, but under the close watch of sign and symptoms of rising ICPs. So it can be clinical signs and definite non-invasive. Ideal will be to put an invasive ICP monitor, but we can also go monitor the ICP through non-invasive methods, like seeing the optic nerve sheet diameter or going for a TCD. So these can be a surrogate markers of rising ICPs in these patients. So given a situation, if nothing is working and we are failing to maintain the oxygenation, proning can be done under the supervision, under the close monitoring of ICP.
Thank you.
Dr. Harsh.
Yes,
Dr. Harsh,
yes, sir.
I understand proning is definitely not really possible in many neurosurgical cases, but is it, if we take patients, in the lateral decubitus, on the sides, alternately, does it have any benefit over supine ventilation?
Yeah, see, change of position every second hourly, change of positions is part of the ICU protocol in many of the ICUs, including ours, in which we do change the positions, making the patient left lateral, supine, right lateral, considering what kind of surgery definitely the patient has been on. But you can, if we are not able to, definitely what we saw, what my experience have been in the COVID, managing COVID patients as well, in which there were patients in which we were not able to do prone, even side proning, or what we call as semi-proning or a 2/3 proning will also help in recruiting the lungs. So if we are not able to do that, definitely we can go for a semi-proning and 2/3 proning, but we have to keep in mind the ICP, the rising ICP. Definitely, we have to keep a watch on the hemodynamics. So when given a situation in which we are not able to maintain the oxygenation with all the things that we have tried, these methods can be tried in individuals, because nothing is a bigger killer for the brain like hypoxia. So to find a sweet spot between the two, definitely we can try. And I have seen semi-proning or 2/3 proning also helps the patients in increasing the oxygenation.
One more question just related to this. These all, yes, logically, the ICP should rise in prone position.
Yes.
And in lateral also, it should be helpful. But all these things are documented or not? Question is, this is just a logical thinking, or these are documented facts?
Yeah. So if you have a connect between proning and ICP, definitely if you have a non-invasive, or if I connect invasive ICP monitor, and if I prone the patient, it has been seen that a significant amount of as we increase the duration of proning, okay, then there is a consequent rise in ICP in these patients. Number one. Second is, if the patient is already having a raised ICP, definitely these maneuvers will be more dangerous. Definitely, we might strictly say no to begin with proning, basically. But many patients in which the ICP is acceptable and we are proning, and we see no rise in the ICP in 2 to 3 hours. Generally, they tolerate 8 to 12 hours of proning without any problems. These are just, there are no guidelines, there are no cutoffs. These are just based on few studies and few literature that we have right now. So in which duration of proning has a direct correlation, and initial hours of proning and the relation of ICP has a direct correlation.
One study Dr. Ann quoted as 16 hours, still 16 hours, the ICP didn't increase something.
Yes, sir. Yes, sir. So that is not true for all the patients, sir. Patients who are tolerating generally initial 2 to 3 hours, if they are tolerating well, then we have seen that they can tolerate the whole 16 hours. But
no, but that study was in neurosurgery patients or general, no, other patients.
Yeah, I think that was in like brain injury, acute brain injury. That was a neurosurgical patient. That's what I remember. Okay. Yeah.
So I think we should move on now, sir, because we have just, we would like to maintain the time. And the next we have another interesting topic which we face every day, and that is weaning from a tracheostomy, how to do. And here we have Dr. Lata Sharma. She is the head of the Department of Pulmonology and a consultant pulmonologist at Krishna Institute of Medical Sciences, Hyderabad. She's also the executive committee member of TB Association of Telangana. So over to you, ma'am, for your presentation of how to wean from a tracheostomy.
Thank you so much. I hope you can see the screen.
Yes, yes.
Yeah. Good morning, everyone.
Yeah, to change the slides. So
can you see
slideshow, ma'am?
It's already in slideshow mode only.
It's already in the slideshow.
yes.
I hope it's okay.
Yes.
Yeah. Good morning, everyone. Thank you, Dr. Manas sir and the Neurosurgical Society of India for giving me this opportunity and making me a part of this prestigious event. The topic that is given to me is how to do weaning from tracheostomy. So the purpose of weaning is to gradually return airflow to the upper airway and restore the normal physiological process. The whole process of weaning includes a manipulation of the tracheostomy tube, and this may further increase the work of breathing. So whenever we start a weaning process, close observation is needed for any early signs of clinical deterioration to ensure patient safety and prevent any distress for the patient. Many a times people ask us, can we remove the tracheostomy on an OPD basis? Just come and get it removed in the ER and then go home. Or can we send a healthcare professional home so that it can be removed at home? There are some changes that can occur, and there are some complications that can occur when we do the tracheostomy removal, that is decannulation, without weaning. So there will be change in the airflow from breathing via tracheostomy tube to utilizing the upper airways, and it can be distressing for a few patients. So let us see some problems that can occur when we do decannulation without proper weaning of the patient. You can see here, there is absolute edema. There is edema of the supraglottic area. This is the first one is during inspiration and the second one is during expiration. Due to dynamic airway compression, you can hardly see any slit-like opening during expiration. So when you remove the tracheostomy in such patients, they can hardly breathe. So this is supraglottic edema, and due to its nature and due to its appearance, it is a medical emergency. It can progress to fatal cardiopulmonary arrest. There is epiglottic fold and arytenoid edema. And the most common cause for such a presentation would be difficult or prolonged intubation. This is another case where there is a chunk of sputum or any or the upper airway secretions, which is causing mechanical obstruction of the glottic area. And this obstruction can also enter into the trachea. So when you do tracheostomy in these patients, again, there is a very high chance that there will be a weaning failure. So this is mucus aggregation over the vocal cords. The reason for this is patient cannot protect the airways. There is difficulty in clearing the airway mucus. The reason for this could be a poor cough reflex. Another patient where the upper airways are normal, there is no supraglottic edema, the vocal cords are normal, but the patient can have severe respiratory distress on removal of the tracheostomy tube. This is subglottic stenosis. You can see the slit-like opening in the trachea, hardly 3 to 4 millimeters. This is above the tracheostomy tube. So subglottic edema, this is due to trauma in the laryngeal area during intubation. Other important reason is cuff pressure necrosis over the tracheal mucosal area. Multiple intubations and prolonged intubations are the reason for this, leading to exuberant granulation tissue. Stenosis can occur even as a late complication. So patient can be decannulated, but usually after a few weeks or months, the patient can come back with stridor, and always we should be on the lookout for this problem. There are some patients where there is no supraglottic edema, even the cord is normal, there is no subglottic edema, but still the patient has failed extubation, failed weaning of tracheostomy. This could be due to oropharyngeal dysphagia. It causes abnormalities affecting the pharynx, larynx, tongue, and upper esophageal sphincter. The main problem here is the patient is unable to clear the secretions, and over a period of time after the decannulation, patient develops severe respiratory distress. It could be an end result of any cardiovascular accident, usually seen in elderly population, and there is difficulty in clearing the throat, difficulty in swallowing, leading to pooling of secretions. So now we know what are the contraindications for tracheostomy weaning. Upper airway edema, reduced ability to clear the secretions, patients requiring more than 40% oxygenation. Further surgery is indicated in the next week or 10 days. So you would definitely like to have an airway protection in these patients. Patients who have cardiovascular instability, initial reason for tracheostomy still exists, presence of a tumor, and most important, and our topic of discussion for today, any patient who has not completed a proper weaning process. So let us see what are the indications for weaning of tracheostomy. Patient not requiring more than 40% FiO2, hemodynamically stable. Patient has a good cough reflex, can maintain upright position for at least 15 minutes, can stay alert for at least 15 minutes, needs only occasional suctioning, fairly able to clear the secretions, and somebody who is not needing positive pressure ventilation. So the process of weaning is not about just a removal of the tube. It also involves the nutrition, the speech, and the deglutition. All these have to be taken into consideration before considering removal of the tube. So the stages of weaning, it can be 5 stages, and this order can be followed meticulously so that there are no problems in the weaning, and patient can be easily weaned off. So the first one is the cuff deflation. Next is the gloved finger occlusion, one-way speaking valve, fenestrated tubes, and decannulation cap. So this is the cuff deflation. Patient is not on ventilatory support, not needing much oxygenation. The first thing is just deflate the cuff. So patient needs to be in the upright position, explain the procedure and warn that there might be some change in the sensation in the throat area when we are deflating the cuff. Suction the oropharynx gently, or you can allow the patient to cough so that the upper secretions can come out through the throat and the lower secretions can come out through the tracheostomy. A synchronized suction and cuff deflection can also be done, explaining the procedure carefully to the patient. If there is no clinical compromise and if there is no airway obstruction, there is no stridor, then the patient has passed the cuff deflation test. So once the cuff deflation is done and the patient is fine, you can leave it deflated in stretches of 15 minutes each and then extend it over a longer period. And ideally, inflate it overnight so that there are no complications at night. So this is the second stage, which is the gloved finger occlusion. So you can see that the cuff is deflated. A finger is kept on the tracheostomy tube, and on the other hand is kept over the nose and mouth to see for any the airflow, whether the patient is able to breathe properly or not. So gloved finger occlusion should be done once the patient can tolerate the cuff deflation. So occlude the tracheostomy with a gloved finger, feel for air through the mouth and the nose. Monitor for any sort of respiratory distress. In case of any breathing issues in tachypnea or stridor, stop the procedure immediately. So what could be the reason why the patient has any respiratory distress? It could be reduced airflow around the tube. Again, there are two reasons for it. One is the cuff is too large. There is no space between the cuff and the trachea. Another is there is some obstruction either in the trachea or in the upper airways. So the solution for this would be change to a smaller size tube or a fenestrated tube, which we'll be discussing later, and consider other options for optimizing the weaning process. The third one is the speaking. This is very important. One-way speaking valve has to be used. Place the valve over the tube. And again, before we do any of such procedures, it is very important for us to see that the cuff is deflated. The one-way speaking valve allows air on inspiration and closes on expiration. So instead of keeping the finger, you are allowing the speaking valve so that the patient can just vocalize. And during this period, you have to watch out for any oral secretions. So build up the tolerance, use it for at least 4 hours in one block. With the speaking valve and on, sometimes the work of breathing increases. So always monitor for any sort of respiratory distress or fatigue and stop the procedure if the patient is not ready for the weaning. Very important again to not leave it overnight because the secretions or the sleeping position may occlude the one-way valve. Also remove the valve during nebulization as moisture and the drugs can make the valve sticky and it may cause damage to the movement. So this is the fenestrated tube that I'm talking about. So if the tracheostomy tube is large and the patient is unable to breathe when you are closed with a gloved finger, you can go for this fenestrated tube. There is a hole on the upper surface which allows the air to go through the mouth and the nose. This is useful for patients who are more difficult to wean or where reducing the size of the tube may be undesirable, probably changing the tube every time and the cost issues. So you can go for this fenestrated tube. The weaning and the decannulation process is essentially the same as with the normal tracheostomy. And the last procedure, the last step for weaning is the decannulation cap. The red cap is put over the white cap, and that is the last step. So after 4 hours of cuff deflation and speaking valve decannulation trial can be attempted. This is the final stage. Once you keep the decannulation cap, it is effectively the patient is breathing through the side of the tracheostomy and the expired air comes out through the trachea and into the upper airways. And cuff should always be deflated while we are doing this. Again, the aim is build up to 4 hours with the decannulation cap on. Always monitor for signs of fatigue. And because it is also called the red cap, the nurses have to be alerted regarding this. Wherever the patient is, even the patient is at a little distance, anybody who has a red cap, it is always a good thing to keep a watch on the patient every 15 minutes. So that is the red cap. You can see the cuff is deflated, the red cap, patient is able to breathe, and then the glove arm, the glove hand is able to feel the air through the mouth and the nose. Now, the most important thing is communication. Many patients get depressed when they're unable to communicate with the staff or with their relatives. So there are two ways in which the patient can be made to communicate. One is the finger occlusion occlusion that we have already seen. Whenever the patient needs to talk, he can just keep the finger on that. Take a deep breath initially, keep the finger, and then speak. During exhalation, the patient attempts to speak. Another is instead of the finger occlusion, you can keep a speaking valve. The advantage is you don't have to keep the finger all the time whenever you want to breathe, want to talk. It can be kept over 2 to 3 hours at a stretch. Now the deglutition. The presence of tracheostomy can adversely affect the swallowing in patients with no previous dysphagia also. That is because the sensation in that area is disturbed in these patients. Due to the shared functions of the hypopharynx and the larynx, dysphagia can cause severe impact on the patient's respiratory compromise also. So prolonged artificial feeding also can cause disruption in the complex interrelation between deglutition and respiration. Now, how do we evaluate the bedside swallowing? So after the patient has passed the cough deflation test, we do what is called water swallow test. 2 to 3 drops of dye is added in a little glass of water, and sips of water are given orally to the patient. Return of the dye from the tracheostomy is an indicator either of aspiration or the patient is unable to swallow properly, and the water swallow test should be discontinued. And speech and language therapy specialists can also always be consulted in such patients. The nutrition for these patients, a tracheostomy tube may impair swallowing and it all compromises the nutritional status. Very important to assess the nutrition status because the weaning process is not only about removal of the tube, but also the neurological and the muscular function has to be taken care of. The dietitian for nutritional assessment has to be consulted, and nasogastric feeding to be continued until swallow and dietetic assessments are completed to ensure adequate nutritional intake. Now, troubleshooting. Whenever the gloved finger occlusion is attempted, there is poor flow through the tracheostomy or the nose, the patient gets distressed immediately. So consider changing to a smaller tracheostomy tube or a fenestrated tube, and consider investigating for airway obstruction prior to proceeding to weaning. So this is the time when we might have to do either a laryngoscopy or a bronchoscopy to see if any of the complications that we have seen earlier are present in these patients. Now, troubleshooting when the patient is on decannulation cap or one-way valve. It could be due to increased work of breathing. Again, the same problem of large tracheostomy tube or airway obstruction. And another most important thing is the poor ventilatory reserve, prolonged intubation, prolonged ventilatory support, sepsis, patient in ICU for long, poor nutritional support, excessive secretions or difficulty swallowing, and many patients' anxiety. All these can increase the work of breathing. So each patient has to be checked very meticulously. So whenever there is a problem during decannulation cap, just remove the cap, remove the valve, and repeat the trial if there is no issue. Change to a smaller tube or a fenestrated tube again. Encourage to cough, clear the mouth, and swallow, and give a lot of reassurance, and the trial can be done again. Again, this is a scenario where you would like to see whether there is any mechanical obstruction, either in the form of bronchoscopy or a laryngoscopy. Now, this is the D-day, when the day of decannulation arrives and the patient has passed through successfully all the stages of weaning. So inform the appropriate staff, the nurses, the doctors, the speech therapist, and ideally it should not be an emergency procedure. Plan it accordingly, either from Monday to Friday. Standard infection control procedures have to be followed. Keep the patient upright and visible to the staff, and especially when the patient is in the red cap, we have to be very careful. Encourage to cough and do gentle suctioning, and ensure cuff is fully deflated, and slowly remove the T-tube upward and outward direction. Clean, dry, and airtight dressing should be applied, which needs to be checked intermittently, and it has to be changed accordingly, either daily or once in 2 days. And keep all the emergency equipment standby. And ideally, the patient has to be observed for 24 hours. So once this is done, the patient is successfully decannulated. But it is very important to know that all the complications do not occur immediately. There are some people who have stridor and increasing breathlessness. It may not be sudden, it may develop over a period of time. And even after 2 to 3 weeks or few weeks or months, we have seen patients come back with obstruction or stridor. So it is very important to find out these complications and keep a watch. Any person who comes to you with respiratory distress and has a tracheostomy scar, it is very important to find out whether this is the reason for that and has to be evaluated accordingly. So thank you so much for giving me this opportunity again. So any questions, I'll be happy to.
Thank you, Dr. Lata. That was a very lucid presentation, very informative. And there are plenty of take-home messages in your presentation. I just have a couple of questions. You said that there are 3 reasons for a patient failing tracheostomy weaning. One is supraglottic edema, second is subglottic stenosis, third is oropharyngeal dysphagia. Are there some risk factors which, if present, will warn the intensivists or the neurosurgeon that this patient is not likely to tolerate weaning, tracheostomy weaning? Like there's risk factors for identifying supraglottic edema, subglottic stenosis, etc.
Risk factors for all these, sir, all are conditions which develop during emergency intubations, multiple intubations, intubation, extubation, and then re-intubation. These are the conditions which predispose to development of exuberant granulation tissue. Patients who have poor nutrition, diabetic patients usually, because they have tendency to have infections, and basically it is the prolonged intubation. Anybody who is intubated for more than a week or 10 days, these are the patients who have increased risk of developing edema and of course future subglottic stenosis.
Okay, very nice of you to mention about the relationship between deglutition and the respiratory system. It's very, very important because that's an important concept which we neurosurgeons should remember. And one of the practical things which I noted in your slide is that you don't encourage decannulation during weekends, which many of us do, because even though we're supposed to have same care 24/7, 365 days, weekend is a very risky period to either wean or decannulate a patient. So can you just elaborate on the use of a fenestrated tube, which you mentioned briefly?
Fenestrated tube is usually kept when when you want to change the size of the tube from the bigger one to the smaller one. Many patients, some patients, the tracheostomy tube doesn't fit properly, and this is the time when a fenestrated tube would be helpful. A smaller tube sometimes is risky because it may just drop out, and when the patient coughs, it can just come out. A fenestrated tube would be little larger than the smaller tube, and it would be somewhere between the bigger size and the smaller size. It is in between, but as it has a nice hole, whatever the patient takes through the sides of the tracheostomy, the air goes directly through the fenestration into the trachea and through the mouth and nose. So that would be ideal for some patients, and where you don't want to change the tube from size to gradient size, when you don't want to change, you can go for the fenestrated tubes.
There's a question, chat box. Somebody wants to know about the role of tracheostomy in patient. Vishal Vyas, he wants to know about the role of early tracheostomy in neurosurgical patient.
Early tracheostomy is early tracheostomy in neurosurgical patients when the duration of recovery, it may not be due to only respiratory issues. If anticipating prolonged recovery due to the neurological conditions, early tracheostomy is ideal, because we have seen a lot of patients who have recurrent laryngeal nerve palsy also because of the mechanical irritation over the cords, and there is always a problem with the swallowing when there is a tube, the endotracheal tube. So ideally, anybody who is needing intubation for more than 1 week to 10 days, and if we anticipate a longer period, better to go for an early tracheostomy. Mobilizing the patient and doing suctioning is much easier when the patient is on tracheostomy than on an endotracheotomy.
Thank you.
Thank you, sir.
There are no.
Thank you, ma'am.
Thank you,
And
sir.
we have the fourth talk of the first session, and that is managing sepsis in neurosurgery by understanding the PK and PD of antibiotics, which is very important. We all are quite irrational at times and gone dumping antibiotics, and I think that is a very wrong way. And Dr. Anirban Home Chaudhary will be there from GB Pant Hospital, who is a director, professor, and critical care expert at GB Pant Hospital, New Delhi. And he's also a dynamic executive functionary of the Indian Society of Critical Care Medicine. So over to you, Dr. Anirban.
Thank you, Dr. Suchanda. At the very onset, I wish to thank Dr. Manas Panigrahi, Dr. Suchanda Bhattacharjee, and the entire team of NSI for inviting me and giving me this opportunity. And I have no disclosures to make except that I am a general intensivist. So if in order to reach this important aspect of understanding the PKPD and either instituting or amending the antibiotic based on that, so I will go through a case, and as I walk along this case, I will try to impinge upon those areas where we need to decide upon based on this particular characteristic. Now, my case is a 55-year-old male, a case of meningioma, who had been a smoker for the past 20 years and had mild obstructive airway disease, who undergoes uneventful craniotomy, is extubated in the OT itself. On day 4, the patient develops fever, is having mild tachypnea with altered sensorium. The sensorium had earlier become normal. He shows mild tachycardia. The blood pressure is borderline. The saturation is probably not that much as expected. And on chest, the patient is having a diminished vesicular breath sounds with occasional creps. The drains, however, are clear. The urine is normal. Sugar is mildly raised, not that much, but still it is borderline, we can say. The urea, creatinine, electrolytes are normal. The CT head is normal. The chest X-ray shows right-sided consolidation with rising TLC, predominantly polymorphs. The CRP is raised. We do a ball, but it takes 24 hours. And the blood culture is apparently negative so far. Patient is currently on the antibiotics, levoflox and linezolid for the past 4 days. Now the question is, how should the antibiotics be upgraded? Now, in order to answer this question, we know that there is no denying fact, and most of the landmark papers, including Marim Kolev and all, they have spelled out in no uncertain terms that antibiotics are the mainstay therapy for sepsis. And unless we give the right antibiotic in the right dose, through the right route, and for the right duration, the outcome cannot be the best. It may be good, but it will certainly not be the best. So this understanding begins with understanding the class of antibiotics that we are using. Now, certain antibiotics are lipophilic. So these lipophilic antibiotics can easily enter the cells and the tissues because the cell wall contains lipopolysaccharide. So these lipophilic agents, they have a large volume of distribution. They spread along mainly to the peripheral compartments, the tissues, etc. They are metabolized in the liver, and the antibiotics of this class include the fluoroquinolones, the macrolides, linezolid, etc. The other group of antibiotics, which are hydrophilic, or in other words, we can also say them as lipophobic, they are actually repelled by this polysaccharide layer which is present in the cell wall. So they cannot enter the tissues. So they remain mainly within the blood and in the extracellular compartment. So they have a smaller volume of distribution. So this is likely, they are not metabolized in the liver. They are likely to be eliminated either unchanged through the kidneys or some amount of degradation in the kidneys. And they have increased clearance in severe sepsis because in severe sepsis, the renal perfusion increases. So all the higher antibiotics that we use among the beta-lactams like the cephalosporins, the penims, etc., the aminoglycosides, the glycopeptides, that is the teicoplanin and all, they fall under this category. So if we just try to recapitulate our knowledge of our physiology days, we remember that the body water total has a particular way of distribution. the entire body, the water that is present in the body, 2/3 of it remains within the cell, that is the intracellular, and 1/3 is only extracellular. And out of that extracellular, only 1/4 is intravascular and 3/4 is extravascular. So as I told, that the drugs which have a high volume of distribution, that which can pass along this lipophilic, the lipopolysaccharide layer, which are lipophilic. So they have a volume of distribution as the cholesterol, the fluoroquinolones, etc. And the ones that remain totally inside the blood, like the aminoglycosides, cephalosporins, carbapenems, beta-lactams, etc. And there are some antibiotics which are between the two, because they get distributed along the distribution pattern of the total body water. So a part of them stays inside the blood and a part of them enters into the cell. So these are also the ones to be considered during change. Now, what happens during sepsis? In sepsis, we all know that there is an endothelial damage. So we get leaky capillaries. Through this leaky capillaries, there is extravasation of fluid outside the vascular compartment into the extracellular. So even though the patient is volume depleted, the patient is bloated up. So basically the entire fluid that is there, it goes into the extracellular spaces. So the volume of distribution becomes high. That is, more and more water goes outside the central compartment into the peripheral compartment. Secondly, in septic shock, during the initial phase, there is an increase in the cardiac output. This is because of the falling output, so that there is a compensatory sympathetic drive. Then there is use of resuscitation fluid, there is use of vasopressors. So all of this increases the renal perfusion. So once the renal perfusion increases, the clearance of the drugs increases. So the drugs which are staying, which were entering into the extracellular, they're not retaining. So they're coming out. And third important thing is that there is increased vascular permeability. So there is transcapillary loss of albumin. So those drugs which are bound to albumin, which enters the cells by getting bound to albumin, so their free form increases because of lack of albumin, because all this albumin is exclaiming. So there is risk of toxicity for such drugs. So if we understand this, so we can understand this effect on the PK also. So those hydrophilic drugs, that is, which are mainly remain in the central compartment, they need a loading dose. Because why? Because the blood is not remaining inside the blood vessels. Blood is coming out through the leaky capillaries. So along with blood, they are also escaping because of the leaky capillaries. So we need a loading dose, and we need changes in the maintenance dose. Because why? Because the renal perfusion is increased, so the clearance has increased. So the maintenance. On the contrary, the lipophilic drugs, that is, which are primarily distributed inside the cells, they do not require any change. However, if the patient has gone into renal failure, if the patient is sepsis-induced AKI, then the maintenance dose of these hydrophilic drugs is reduced, because then the drugs will tend to accumulate, so producing toxicity. So unless the patient is in renal failure, their maintenance dose will be increased. If the patient goes into AKI, their maintenance dose will be reduced. If the patient is undergoing some form of RRT, whether SLED or RRT, anything, then we require extra dose, because the RRT will also remove those, because they are comparatively large molecules, and we know that the large and medium-sized molecules will be removed. So all this, the drugs, aminoglycosides, beta-lactams, glycopeptides, all this entire list, these will require a reduced maintenance dose in the event of a renal failure. And after the patient undergoes RRT, they will require an extra dose during and post-RRT. So if we sum up those three, know that there is one, fluid overload in sepsis, whose implications include increases in the volume of distribution for hydrophilic antibiotics. There is hypoalbuminemia, which raises the unbound fraction of the protein-bound antibiotics, very important for ceftriaxone, artemisinin, daptomycin, etc. There is microvascular failure, which impairs the tissue penetration of antibiotics. So the serum concentration becomes an imperfect guide. Even if the serum concentration appears normal during therapeutic drug monitoring, actual penetration of the drug inside the tissues may be less. Augmented renal clearance, acute kidney injury, I have already discussed, and also hepatic dysfunction, because the elimination of certain antibiotics which are dependent on the liver, like the TG cycline, that gets affected. So their dose gets reduced in sepsis. The next, coming to the pharmacodynamic part. Pharmacodynamic means what the drug does to the body. So here we are considering the effect of the drug on the pathogens or the microbes. So we all know that we know something that is called MIC, that is the minimum inhibitory concentration of an antibiotic that prevents visible growth in 50% of the individuals. That is fine. In sepsis, in an ICU, this may not be adequate. We may need to something which is known as the MBC, or the minimum bactericidal concentration. What is this minimum bactericidal? We know that if there is a particular antibiotic present, then in increasing dilution, and we inoculate here with the specimen containing with the microorganisms at a certain concentration, this growth gets inhibited. So this is how we know the MIC. But once this effect of antibiotic is removed or eliminated, then they will again start growing unless the antibiotic has been killed. So the lowest concentration at which that, and they show no such growth even after re-inoculation in an antibiotic-free medium, gives you the MBC, or the minimum bactericidal concentration. Earlier, it was the terminology was maximum inhibitory concentration, but anyways, now it is minimum bactericidal concentration. So this may be important critically ill patients, particularly those who are on steroids, those who are having hypoalbuminemia or other distractions, where the mere discontinuation of the antibiotic and within 2 days, again the organism start flaring. And we also know that their antibiotic killing action or the serial action may be of 3 kinds. One is the concentration dependent, which means that certain antibiotics like the aminoglycosides, the fluoroquinolones, we administer once a day or twice a day. Here, their killing action is dependent on the Cmax over MIC. That is, what is the maximum concentration above the MIC. So this height gives the indicator of their negative. There are certain where the time for which the concentration is above MIC, that depends the killing action. So these are the time dependent antibiotics. And there are certain antibiotics where we depends upon the area under curve. That is this MIC, this is the concentration against time. So this curve gives their efficacy against the organisms. So these are the concentration dependent. So as I told you, aminoglycosides, fluoroquinolones, they are all concentration dependent. So there is no point giving this drug multiple times. Once a day or twice a day is fine. Number 2 is time greater than MIC. In these drugs, we require an infusion because we need to continue their concentration above the level of the MIC for the maximum duration. And the third group is this AUC over MIC, where you need both a loading dose as well as you need an infusion, so that this size of this curve is maximum. So that determines on the usage of bolus, infusion, and loading. Now let us go back to our case, which we started, that how should the antibiotics be updated? First, choosing the antibiotic. So as we know that in our patient is probably falling prey to some hospital-acquired pneumonia in the ICU post neurosurgery. So we should know what are the commonly caused aerobic gram-negative bacilli. That is the most common in India, followed by some gram-positive cocci. The frequency of specific MDR pathogens is variable depending from ICU location, etc. But we have to know that there are certain risk factors due for MDR, like age more than 60 years. Our patient was 55, so it is almost similar. The duration of mechanical ventilation more than 7 days, which doesn't fit for our patient. Prior antibiotic use less than 3 months, we don't know. The presence of severe sepsis or septic shock at the time of the patient is definitely not on septic shock, but yes, severe sepsis, ARDS preceding VAP. So all of these are the risk factors for VAP. So of MDR in VAP. So first of all, we have to know whether this patient is having any risk factor or not. So in India, most commonly the gram-negative organisms are the most common cause of infection. So in what should be the empiric antibiotic for HAP or VAP in the ICU? So commonly we use piptaz, cefepime, levofloxacin, imipenem, meropenem. All depends upon our local knowledge of the kind of bugs that are grown in our ICU and their sensitivity pattern. There is nothing much, but this is something which we were worked upon by the Indian Society of Critical Care Medicine, and we had a guidelines published into 2018, and subsequently ICMR has accepted it. So we have certain knowledge that patients who are not at high risk of MDR pathogens in ICUs, which have a low prevalence of MRSA and resistant gram-negative organisms, then a single antibiotic against both MSSA and Pseudomonas may be preferred. So quinolones may be there. It may work in those cases. Although quinolones have limited value in ICU, more so in non-neurosurgical ICU, but they may be of value at times. But whenever there is patients of high risk of MDR, as I told you with those reasons, or in ICU which have high prevalence of MRSA or high prevalence of resistant gram-negative organisms, then at least 2 active agents against gram-negative organisms, including Pseudomonas, is recommended. So this is something one can do, but always use that in our country where tuberculosis is high. Fluoroquinolones and aminoglycosides should be cautiously used as monotherapy for VAP. Now, if you see that when are you using the BL-BLI combinations, particularly piperacillin, tazobactam or so, whenever the meta-analysis have proven that when they're used as an infusion, the result is much better. And the same also goes for meropenem, because if you see that if you have to, this is the probability of attaining the MIC. So if you don't target a very high MIC, probably it is fine. Your infusion over 0.5 or 30 minutes or 1 hour is not going to make a difference. But when you are targeting a higher MIC, that is in case you suspect that this organism is a difficult to treat or maybe a resistant bug, then probably prolonging the duration at least to 2 hours, if not 3 hours, would create difference, because then that MIC is attained and this difference is widened and this MIC is maintained for a wider period of time. So meropenem infusion, you try to at least give for 2 hours, if not 3, whenever it is possible. Now, when to give anti-pseudomonal and atypical? Anti-pseudomonal, that is whenever you have patient has history of prior use of antibiotics, prolonged duration of MV and COPD, like our patient at COPD. So probably some amount of anti-pseudomonal coverage is required. In ICUs where gram-negative isolate is very high, that is more than 10%. So in that case, the patient has risk for MDR, 2 anti-pseudomonal antibiotics of different class. So this is something which can make a difference by reducing the duration of antibiotic therapy on an average. So if there are other causes like atypical or then Legionella colonization, then probably it has to be dealt separately. But you know that's the role of azithromycin and clarithromycin is very important in such cases, as well as use of moxifloxacin. Now, what should be the duration of antibiotic treatment for HAP or VAP? Short courses for antibiotic if the response of the VAP has a good clinical response, but longer duration if the VAP is caused by non-fermenting gram-negative bacilli or the patient is having severe immunodeficiency. As I told you at the time of showing MBC and MIC, that once if you use in MIC, again the bacteria starts growing once the antibiotic stops. And a good way would be to monitor the PCT, the procalcitonin, before de-escalation of antibiotic once VAC is cured. Now moving on to another case. Now this is a 50-year-old male aneurysm who was undergone craniotomy and clipping 10 days back. Now the patient is having 101 degree Fahrenheit fever and altered sensorium for past 2 days. So this is again a post-operative period. He was uneventful during the operation. The EVD has a CSF leak. The TLC is high, mostly with 90% is neutrophils. The CRP is also raised. The chest X-ray normal. The CT head is showing mild cerebral edema. The current antibiotics are piptaz, amikacin, and linezolid. Now, again, how should we choose the appropriate antibiotic route and dose in this patient? So, whenever the patient, there are certain recommendations for nosocomial meningitis, we have to remember that these recommendations are largely based upon expert opinion, because we have not done all the high fidelity or the extremely level of randomized control trials or meta-analysis. So, but we follow the IRSA guidelines, which are fairly give a good variety or good different indications of these new drugs. And based on that, in our country, staph epidermidis is the most common. There is followed by gram-negative bacilli and staph aureus. So in all these cases, vancomycin plus third-generation cephalosporin are indicated for post-basilar skull fracture meningitis. Again, vancomycin plus either cefepime, ceftazidime, or meropenem for post-neurosurgery nosocomial meningitis or meningitis occurring after CSF shunt or penetrating trauma. In cases of ventriculitis or meningitis associated with healthcare, so if it is totally hospital acquired, then anti-pseudomonal beta-lactam can be considered. Again, the duration of antibiotic will vary. If it is 10 days, if it is coagulase negative staph aureus or Propionobacter actis with or no minimal CSF fluocytosis, normal CSF glucose, then 10 days may be adequate. But in cases of CSF fluocytosis or glycohypoglycemia or clinical symptom, then sometimes it may increase. For gram-negative bacilli and naturally for staph aureus, it is high. So we have to remember that there are certain general principles, because vancomycin is often used in these patients, that in vancomycin, the loading dose is high, 25 to 30. So in our patients, we use normally 20 to 5 is the milligram per kg. And the indication, that is POEMS, pneumonia, osteomyelitis, endocarditis, meningitis, and sepsis, and in bacteremia, the loading dose should be used. Loading dose does not indicate it in purely non-POEMS or non-bacteremic patients. And if the patient is having renal insufficiency, we try to reduce it. Maintenance dose is again 15 milligram per kg. You check it by doing a creatinine clearance in the backdrop formula, and maintain a target trough of 15 to 20, and the check trough 30 minutes before and after the fourth dose. So this vancomycin loading dose increases the achievement of therapeutic concentration without bringing extra risk of nephrotoxicity. This is a very important, and this has been documented in plenty of studies, including this one. If you see the administration of high doses, even in continuous infusion versus intermittent infusion, continuous infusion makes it possible to achieve faster and larger levels, but they do not have any effect on the penetration. So if we look into what antibiotic we should choose, most common empiric treatment is third generation cephalosporin with metronidazole. Sometimes vancomycin is required. 4 to 6 weeks of therapy is required in surgically treated abscess, and 6 to 8 weeks for solely medically treated or multiple surgical abscesses. So these are some of the indications where the duration of treatment needs to be prolonged. Now, metronidazole, if it's a brain abscess, we know that in almost all cases, 15 milligram per kg of IV loading dose has been recommended. We never use it, but it's if it is to be followed by 7.5 milligram per kg. So sometimes the requirement of this may increase. So from 7.5, it may go to up to 10 milligram per kg IV if we are not using the loading dose. So currently we are also coming up with the autokinetic software. This software will help us that once it is fitted in the ICU to check the drug concentration in the body of the patient. Now this software is created by accumulating a huge amount of data. And on the basis of that data, the personalized antibiotic dosing can be done. And the dose and the loading dose as well as the maintenance dose, intermittent or confusion, can be determined based upon this software. It is still not validated, but it is certainly work is going on in full swing. So to summarize, I would say that whenever there is an infected patient following sepsis in a neurosurgery ICU, first of all, pharmacokinetic considerations are important. These are about the relative solubility, protein binding, clearance that I've mentioned. Then the clinical consideration, that what might be the site of infection, what is the severity of illness, what is the body composition of the patient, the likely pathogens and the local pattern of sensitivity and resistance of the bugs, and the pharmacodynamics, of course, that is what is the time course of bacterial killing, what might be the post-antibiotic effect, preclinical. So all our optical dose regimens are based on clinical data and modeling. Modeling in the common one is the Monte Carlo model simulation. So all this data is incorporated safe. So based upon that, we have to choose the optical antibiotic dosing regime. Thank you very much for giving me this opportunity, and once again, wish you a very happy meet for this CME. Thank you.
Thank you, Dr. Chaudhary. It is a very informative lecture. So as neurosurgeons, most of us are familiar only with MIC. Today, you taught us about MBC, AUC, PK, PD ratio, and so on. So if my understanding is correct, most of the microbiology reports, they mention only about MIC. You said that it is MBC is also important, minimum bactericidal concentration. So should we insist on the?
So you insist on even if they don't give, they give something called the breakpoint MIC. Okay. So if you check on that breakpoint MIC, you will give. For example, I give you a very simple example. For example, if you see that your patient is growing the Klebsiella, suppose, and the Klebsiella is showing sensitivity to both TG-cycline as well as to colistin. And the MIC is 0.5 and the 0.5. Now, which one to use? Whether to use colistin or TG-cycline? Now, if you know this, if you know the PK, you will immediately recognize that the distribution of colistin has a very low volume of distribution. It mostly stays in the blood, so it's not getting inside the tissue. TG-cycline has a very high volume of distribution. So if your blood culture has grown, if it is a blood culture positive for colistin, then definitely for Klebsiella, then definitely you should go for cholesterol. But if it is suppose a drain has grown, if it is gone into the urosepsis, in that case, you know that the penetration of tetracycline would be better. So even at the same MIC, you can choose the other antibiotic, knowing that it's penetration. Similarly, if that concentration is not enough in that particular organ, suppose if you choose that MIC of 0.5 is not enough to achieve that concentration in the brain, then there is no point in giving that antibiotic. So we need a breakpoint MIC. Breakpoint MIC is the MIC at which the killing effect is predominant and the chances of toxicity is minimal. So you have to take a chance by giving the maximum possible dose based upon that MIC.
So as you mentioned in your concluding slide, it is not.
I think we are overshooting quite a bit.
Thank you. Thank you.
Thank you, Dr. Anirban. And can you just stop sharing your slides so that Dr. Girish can start? And over to you, Manas sir, for the next session.
Thank you, Dr. Suchanda. Dr. Girish will be chairing the session, but I'll invite him for the first lecture. Dr. Girish is the professor in Head Department at Department of Neurosurgery, Manipal Hospital, Karnataka. And he has a special interest in ethics and consenting. He has done a course, as you see here, he has done a PG diploma course from National Law College. And so he'll be the right person to speak on this topic of consent and documentation in ICU. As we know, in the last couple of years, the violence has significantly increased in the ICUs. So having how to do a proper consent, how to document, and how to counsel has become very important to reduce all these untoward incidences in our practice. I request Dr. Girish to speak on consent and documentation in an neurosurgical ICU.
Thank you, Dr. Manas, and thank you, NSI, for this opportunity. We have an assorted platter for this second session. Two topics, essentially patient-centric, one on nutrition, one on sedation and analgesia in the ICU, and two topics relatively doctor-centric, I should say. The one which I am going to deliver on consent and documentation, and the second by Dr. Sandeep on breaking bad news in neurosurgery ICU. Both equally important topics, and without ado, let us go into that. So, as Dr. Manas said, I'm a neurosurgeon primarily, but recent acquisition of this degree is what gives me limited competence to talk on this topic. I must confess that I'm not an expert though. So my topic has two components. One is on documentation and one is on consent. I would be concentrating more on consent primarily because documentation with this evolution of all artificial intelligence and so forth and so many applications coming forth, I'm sure in the next 4 or 5 years, we'll have a facility wherein all the events in the ICU gets captured on the monitor and the monitor can be recorded and can be saved for each patient. So I hope shortly this paper documentation might come down fast, and with electronic documentation, things are going to be much more easier for us. So the paper documentation is important right now, but it's cumbersome, as all of us agree. I'll be briefly touching on that, but primarily on consent. And as the Oxford Dictionary describes, consent is a voluntary agreement to perform an act on a patient's body for diagnostic or therapeutic purpose. We all know that, and such an important topic, but neglected. We all like to discuss about it, but when somebody speaks, it's so boring to hear. And I'm sure I would say the average duration, attention span would be less than 15 minutes for such topics. And I promise that I wouldn't exceed that. It's easy to preach. We all know what is to be done. We can advise others, but we seldom practice. Everyone has a view as to how we should do, who should give consent, how consent should be taken, but yet consensus is lacking, and we do not have clear-cut guidelines, I must say. And in fact, the same applies to the court judgments also. It's a lot of ambiguity in court judgments, as I would be highlighting shortly. So why take consent at all? There's two aspects of one is ethical and moral. We need to respect the patient's individual autonomy over his person take his consent before we do anything on his body. And of course, there is a legal and administrative obligation. And to be honest, I must confess that all of us, the second objective, that the legal or the administrative obligation, which helps us to protect ourselves, has taken precedence of late. And we are more concerned about the rising violence, as Dr. Manas pointed out. So it has become so very important for us to protect ourselves. And that's why consent has become more of a legal obligation than an ethical obligation of now. And what happens if you do not take a consent? Now, patient walks into your OPD, there's an implied consent, you can examine the patient, but for some, so the consent is there. You examine a patient, but for some reason, if you do a pinprick test and the patient complains of pain, you're liable under the law of torts for causing bodily injury. You operate on a patient, is not happy, you're a breach of contract, you end up with the law of there's a law of contracts, or the Consumer Protection Can Act. But essentially, it can be tried under the civil law, the criminal law. Civil law might be just damages or compensation. It could be imprisonment in case of criminal law. Yeah, the medical council might act on you, have penal erasure, just to highlight the consequences of not taking law, the legal aspects of not taking consent. You're likely to be prosecuted under one of the so many provisions which are available under Indian law. Now, before I go into the topic primarily, how does the court decide? This is something which is very important. What the court expects us is whether the mistake was one which is a reasonable, careful, and skillful practitioner would not have made. So there's where something called the Bolam's test is applied, and that if the doctor has reached a standard of a responsible body of medical opinion, he is not negligent. So primarily what it tells, and what has been highlighted in this particular judgment way back in 1969, is that neither the very highest nor a very low degree of care and competency is what the law requires. Practitioner just needs to bring to his task a reasonable degree of skill and competence. So skill and knowledge and care. So we need not aim to strive for what is the best. We need to strive for what is generally done, what a reasonable doctor would do. This is called the reasonable doctor test. So this is very, very important, because quite often in our desire to achieve the best, we can sometimes overshoot or exceed our limits. And that also results in bad consequences. So with this background, let us go to consent. And I'm not talking about consent in surgery, for surgery in general. That is a totally different topic as such. But consent in ICU, why is it different and challenging? Now, as I said earlier, when a patient comes to you, walks into your OPD, there's an implied consent. No issues with that. We are not talking about that. When he agrees for an intimate examination, maybe per rectal or per vaginal, there is a verbal consent. We don't take a written consent for such instances. That is also fine. Express consent when we want to do a surgery. But in an ICU, none of these apply, because we are assuming, for this discussion at least, I'm assuming that a patient in the ICU is not and does not have the mental capacity or the physical capacity to give consent. So the consent is neither implied nor expressed. So what do we do in such scenarios? So that is the prime concern for this topic. And this is textbook. If you look by textbook, this is the 5 necessary elements of a consent. It should be voluntary. It should be the patient who gives the consent should have the capacity to give consent. He should have he should understand what we are telling. We should disclose everything, and it should be an informed decision. So these are some primary essential components of a consent. Now, by definition, in this particular context, when the patient is in an ICU on a ventilator, sedated, drowsy, whatever it is, or paraplegic, quadriplegic, none of these apply. The patient does not choose the doctor in case of an emergency. He's just brought to the triage following a traumatic. His personal choice of personal doctor might be somebody else, but he might land up in your ICU. So you're not his first choice of a doctor. And once inside the ICU, there's a rapid turn of events, and there's little time for deliberations. The patient goes into stridor, you intubate the patient, you end up doing a tracheostomy, and you can't wait to take consent for each and everything that you do in the ICU. So these are the challenges when you talk about consent in an ICU. There's a rapid turn of events. The patient is vulnerable and captive. He cannot run away. He might want to go to some other hospital, but no, it's an emergency situation. Who gives consent? He cannot, obviously. Who takes consent? That is again an important issue, because as was highlighted earlier, although we are talking about neurosurgery in this particular CME, very few centers have intensive care or critical care specialists in our country. So does the primary treating neurosurgeon take consent, or the critical care or the intensivist who runs ICU take consent? Do we take consent for each procedure? Are we entitled to do any procedure without emergency consent? So this would be the topics which I would be discussing, and let's see if we can arrive at some possible solutions for this rather contentious topics. So do you need to take all of us, we know all of hospitals at the time of admission, we take a general consent and whether the patient is in the ward or so forth. And again, we need to take an ICU consent. When the patient is shifted to the ICU, we take a general consent. No, it's not, at least in my hospital, I would say it's not a very specific consent. And I'm sure if some issue were to happen, the court of law would shred it into pieces. And what does our regulation say? At this point, I would like to say that code, as I said, there are no regulations, no strict guidelines. So what happens is the court decides on precedences, earlier precedent judgments. So that is how they make judgments. So far, I would say we do not have any landmark judgments regarding ICU care or problems in the ICU, like putting a central venous catheter without consent, or putting a trachea, or doing a tracheostomy, or intubating a patient without consent. So far, fortunately, we do not have any landmark verdicts which are precedents. So we need to go by the available guidelines as of now. What does medical council say? It does not mention anything about ICU admission guidelines, consent about ICU. It just talks about before performing an operation, the patient, it's all about operation. You need to take consent before taking an operation. But we all know by broad consensus that admission inside the ICU requires a general consent. Now, how does one define an invasive procedure? How do you decide that procedure is invasive or not? And this is one of the interesting articles published way back in 2003. The physicians or the critical care specialist perspective of which are the procedures which require consent. Interestingly, none of them felt that nasogastric tube insertion requires consent, whereas bronchoscopy or thoracocentesis, of course, they require consent. Catheterization, I'm sure none of us have ever taken consent for putting a urinary Foley's catheter for any patient. CVP and arterial, you see this is a mixed. So do these procedures take consent? Can a patient sue you for putting in a catheter without taking your consent, putting a nasogastric tube without consent? So but there's a broad agreement that at least a verbal consent for a nasogastric tube is required. We need to inform the patient and the relative. Now, the biggest challenge in an ICU, consent in an ICU, is the capacity to consent. Who decides? We know the patient is incapacitated for whatever reason. And this point, I want to bring in this concept of substituted judgment. So this is an ideal scenario, and this is something which we all ought to work out. We need to talk to the patient's close relatives. And the clinician, if he is our own doctor, suppose there's a neurosurgery patient who lands and we have been treating him for some time, he lands on a ventilator, we know his background. So the clinician and the surrogate to the proxy consent person who gives the consent, we need to arrive at a judgment based on the patient's prior statements and beliefs. Like, it all depends whether the patient needs to be ventilated, how long to continue treatment, and so forth. So it's a substituted judgment. This is the concept of substituted judgment, which would broadly resemble what the patient would have taken had he be conscious and alert. The next question is, how much do we inform the patient? So now here there are two schools of thought. The American approach, which says that everything needs to be informed. There's an English approach which says patient autonomy. More than autonomy, it is the doctor who decides. We have to be judicious in what we tell. Unfortunately, in India, we do not have that kind of concept, but patient autonomy is supreme. But then, of course, all of us are aware of the scenario when the relatives come to the ICU and say, doctor, you do whatever is possible, please save the patient, do everything possible. Now, does that give us a blanket consent to do whatever we want? So at this point, there's this concept called the reasonable person standard. There are different other topics like professional community, what an ideal community, like what the Neurological Society of India guidelines would say. We do not have one right now, but generally the concerns, the society guidelines, the subjective guideline, depending on the patient's knowledge or literacy status, a reasonable person. So this is a reasonable, the middle path regime where we take decision based on what a reasonable person would know and understand about that particular topic. So that much of information we need to give the patient. And who can give consent? Now, this is a tricky situation. Ideally, the patient, parent, spouse, and this is the hierarchy in which, and the child, either the parent or lawful guardian. Most important aspect which we ought to know is any one of the above, but it should be a reliable, responsible, and a competent person. Now, who should obtain consent? Now, here comes the dilemma, as I mentioned earlier. This is the treating. If I have operated a patient, the patient lands in the critical care ICU managed by an intensivist. So, who takes the consent for each procedure that is done? Is it me or the ICU intensive care? And in ICU, the problem is, unlike one particular person, they work in shifts, and every shift is a different person. So there's no continuity generally. There will be a chief person, but unfortunately, there is not a single person whom the patient relative can relate to, unlike a scenario when unlike a surgeon-patient relationship. And does a trainee who is attending the patient in terms of emergency, does he take consent? It's a relatively vague topic, not much of consensus or clarity on that. But broad outline is that a person qualified or experienced or competent. But I would say more important than that would be continuity, the person who is available at least daily, once in a day to maintain continuity. This is well explained in this article again. Now, this comes the question of specific consent versus a blanket consent. So when we do in central line, do we go and take a consent? After some time, we need to put an arterial line. Do we again take a consent? We have done we have intubated the patient. Do we take consent for each procedure, or we take an anticipatory bundle? The second option is to take a bundled anticipatory consent. That is for specific procedures, like in neurosurgery. I would say take a consent for an external ventricular drain, probably, or an intubation or a tracheostomy. Other option or a better option would be to take a blanket consent for all routine ICU interventions. So, for example, if it is traumatic brain injury, you never know, we might have to do an emergency chest tube insertion if the patient develops a pneumothorax. We can't be running around and getting a consent for a chest tube at that particular moment of time. So that these are three options: specific consent, anticipatory bundle consent, or a blanket consent. And more and more publications favoring this blanket consent. Again, it has its own drawback, but I would say that serves a purpose. Now, are we entitled to do any procedures without consent in an ICU, especially emergency procedures? Now, I would say the court verdicts in this aspect are a little contradictory. I would just narrate one or two instances, which is landmark judgments, which as students in law, we are all taught and we need to discuss. So this is T.T. Thomas versus Elisa case, where this Elisa's husband was admitted with acute abdomen, probably a ruptured appendix, and the surgery was delayed for whatever reason. And the doctor's argument was that the patient refused consent, and the patient developed sepsis and peritonitis and died the next day. So this is how the court found the doctor guilty, and this is what the court judgment was. There are certain circumstances in which a doctor may be entitled to proceed without this consent. Firstly, when the patient's balance of mind is disturbed. Secondly, when the patient is incapable of giving consent by reason of unconsciousness. And finally, when the patient is a minor. And the court goes on to say that if you take a rescue in the argument that the patient refused to give consent, it's the doctor's responsibility. The burden is on him to prove that the non-performance of the surgery or the non-administration of the treatment was on account of the refusal of the patient. Now, this becomes a little difficult in practical scenario. So there's this instance where the court verdict clearly said that in case of emergency, you can go ahead and do procedure without a consent. But then there are some verdicts which are UK verdicts. I will relate to two Indian verdicts. One is again Samira Kohli versus Prabha Manchanda. To cut the story short, in this case, this lady underwent a laparoscopic examination for infertility. She was around 40 years of age. And on a laparoscopy, the doctor found that she had grade 4 or 5 of endometriosis, which required the ideal treatment for which was hysterectomy. So she goes outside, talks to the patient's mother, gets consent, and does an hysterectomy, thinking that that is the solution for the problem, not for the infertility part, but that she would have required a hysterectomy later on. Consent from the proxy mother, and then that became the doctor lost the case in that scenario. And in this other instance here, we find this case between where the patient, again, a doctor admitted the patient, put a consent for an appendicectomy, found that the gallbladder was inflamed, remove the gallbladder because there was a case of required cholecystectomy. And again, the court found the doctor guilty of performing a procedure without consent. So in case of emergency doing life-saving procedure, I'm afraid the court verdicts are contradictory, and we need to assume the reasonable patient-doctor test here. We need to assume what the the reasonable person would do under such scenario and proceed. As far as documentation, as I said, the more the better. I think I'm running out of sorts. I'll just run through this document. So there are two documentation, one for admission and the second for each day-to-day progress, which is important. But most important, as I would like to highlight here, is communication of documentation and documentation of communication, which I'm sure all of us are. There are certain additional concerns in the ICU, which I'm afraid shortage of time we can't discuss. That is end-of-life care. This all come in when you take consent in an ICU. Teleconsultation, can we take telephonic consent? Is there a role for recording all your consent in the ICU? And sometimes there'll be requests for all inappropriate therapy. Do we oblige the patient and the relatives? That's again is a topic for a webinar. So I would just conclude by taking this messages. In case of consent, take a substituted judgment, put yourself in the patient and including the relatives, think what the patient would have loved to do and take a decision based on that. Responsible proxy, who takes the consent, who gives the consent? Is a responsible close relative or surrogate. How much? A reasonable person standard, which I mentioned earlier. A blanket consent so that you don't have to run around for each procedure, taking consent for each procedure. Documentation, more the better. For all this, I would still say that there's a litigation. Your consent, whatever, however good, may not hold good. Thank you.
Yeah, thank you, Dr. Girish. And it was very lucid and lecture on the consenting. I have one question.
Yeah.
Yeah. If a patient in the ICU doesn't want to continue treatment, like whatever you have suggested, then they want to either they want to take home, or how do you discharge? Do you discharge them as leave against medical advice, or sometimes they'll tell that they'll take to another hospital, but actually they'll not take to another hospital, or they want to change the hospital against your advice. So what is the documentation one needs to do?
This documentation is against advice. And there are now guidelines have come out about withdrawal of life support care guidelines come out. So we can follow those guidelines. And but essentially to cover ourselves, it's best to document that the patient is leaving the hospital against advice. That kind
even if it's a brain dead patient.
Yeah, whatever it is, because it is safe from our side to document everything and discharge the patient at request against advice is the safest alternative to do. Unless there's if you want to withdraw in the ICU, if you want to withdraw life support, ventilatory care and all, there are some guidelines have come as to who is to do. And in fact, in India, this is also now after that euthanasia case, there is provision where we can give an anticipation. Again, that provision is there. But as of now, if a patient wants to leave the ICU, you feel the patient is brain dead, patient might not survive outside, they want to take the patient out of the hospital for whatever reason, it is best from our side to document that the patient is going at request against advice.
What do you do if the patient asks that you remove from a ventilator, like withdraw from life support? Can we do it? Take out from the ventilator? No. Because we have told brain death. No, you take out from the ventilator.
There we have to use that. That's again, that's a different topic, total huge topic on it. End of life care and support. That's a topic by itself. So there are provisions for that now. So for that, but that has to involve the entire family and other doctors, and the entire system has to get involved. Not an individual doctor cannot take a decision. So the entire system has to get involved.
But the legally means who all are supposed to get involved? How many minimum persons have to get involved so that we can do that?
I need to check on that, Manas, the exact who all are involved with the hospital administration, other specialties. Multiple doctors have to count, verify the fact, and then take a decision. If it is within the hospital, if it is just patient is taking out of your care, then it is fine. You can give that. But if you're taking the patient out of ventilator and this, I think it's called the blue document, blue document. I'm not too familiar with that. Blue line or something like that. Is that?
Yeah. Can I have the next lecture loaded? It's a recorded one, Dr. Sandeep, and he will be speaking on another important topic as like a doctor-centric on how to counsel, how to break the bad news. If a patient has a post-op, immediately post-op complications come to the ICU, or a patient has a sudden unexpected cardiac arrest in the ICU, or sudden unexpected complication in any intervention procedure, either surgical or in the ICU, how one has to counsel the patient and effectively. Professor Sandeep is the head of the Department of Neurosurgery at Vivekananda Institute of Medical Science, and he is the chairman of Educational Committee of International Society of Pediatric Neurosurgery, and also co-chair of Asian Australasian Pediatric Neurosurgery Society. And we have a recorded version, and Dr. Girish only has to take his questions at the end of his, because he's not there. So I'll request Dr. Girish to take his questions. So Mr. Vishal, can you please play his
Yes, sir.
video?
Yes, sir.
Yeah.
I'd like to thank Dr. Manas Panigrahi for this opportunity to speak in this meeting today. I think one of the big problems of communication in the neurointensive care is the fact that we are often at a loss as to how we communicate with the relatives of the patient. And this is just a very, very personal approach to how I have learned one is best in breaking the bad news in the neuro-ITU. And I call it the modified spikes protocol, because as you probably know, spikes was a protocol designed by oncologists, meant to convey bad news about a neoplastic disease to the patient or his relatives. And SPIKE stands for, the acronym SPIKE stands for S for setting up the interview, P for assessing the patient's or the relative's perception, I for obtaining the patient or his relative's invitation, K for giving knowledge and information to the patient or his relatives. Step 5 is addressing the patient or the relative's emotions with empathic response. And step 6 is the strategy and the summary. Of course, when the patient is in intensive care, you deal not with the patient, but with the patient's relatives. Let's try, and this is the original article which described this so-called SPIKES protocol, a 6-step protocol for delivering bad news. So let's take them one by one, setting up the interview. So what, where, and who of the interview? What implies what's the total information as a neurosurgeon I want to convey to the relatives? This must be very clear in my mind, and I must know the details. Where do I set up the interview? Well, often consultants like to bring them to their own office. When you bring them to your office, it is actually not an ideal location, as I'll talk about in a minute, because you are starting from a position of superiority, as it were, and you really want to be in a secluded room, preferably not separated from the relatives by a huge desk, so that they feel you are a part of their suffering. And definitely this interview should not be conducted in the corridor outside the neuro-ITU. Who should be there? The consultant should be there with at least 2 relatives. And if you have the good fortune of having the family doctor or the referring doctor there, he should be definitely included. So what do we say? Here's an example. A 14-year-old came with a trauma with this sort of CT scans, GCS5, intracranial pressure recorded as 68, acute subdural. He had an aspiration, hemoperitoneum, a subcapsular hematoma of the spleen, which required a laparotomy because of hemoperitoneum. And he had a decompressive craniectomy. His GCS went down to 3. The intracranial pressure shot up to about 100 millimeters of mercury. And clearly, when the postoperative CT scan showed a picture like this, you know you are on a losing wicket. So what do you tell them? I think a very important clue is not to tell them immediately, only after the patient has died, but to tell them when the situation is very bad. I always like to quote it as the almost irreversibility of the situation, so that there is still a faint glimmer of hope. I think it's very important to tell them the details, the damage, the intracranial pressure in spite of the maximum we could do, which is a decompressive craniectomy, and perhaps even show the CT scans. I think it's important at this stage to get at least a relative to have a glimpse at the patient, to see that the ECG is still recording, to see that the pulse oximeter is still showing a trace on the monitor. So they know the patient is not dead. And yet you're telling them that their situation is virtually irreversible. I think particularly in trauma, it is very important at this stage to talk about the vegetative state and mention, as I often do, that this is a stage worse than death because the patient would be in coma, bedridden, without recognizing any of his dear ones for God knows how long. And the idea is to make the relatives almost choose that death would be better than this permanent vegetative disability. And I think it's very, very important to develop the skill to be able to make them feel, oh no, we don't want that as an outcome. The where and who, as I said before, it's better in a secluded room. A consultant's office is of second choice because then they feel you're not talking as equals. Who should be there? I feel it's best that there are two relatives. One who is a close one and one who is a little distant. The idea being, if the close relative has an emotional breakdown, the slightly distant relative has a better chance of comforting him or her. A nursing staff should always be there because they have the ability to put a hand on the shoulder of the relatives while you're speaking to them. And the ITU doctor, either the registrar or the consultant, should be there because this is the man who's still struggling to try and keep the patient alive. And in my practice, I always ensure in this situation that I speak to the same relatives I spoke to before. That means if I have this patient of a polytrauma, and when he's admitted, I call the relatives and I tell them how grim the situation is and how we're going to try, and the general surgeons are going to try, but we don't know where we're going to go. I make sure that at this stage, you talk to the same two relatives so that there is no issue of saying, but why did you operate? Or why was the laparotomy done? The third thing is to assess the relative's perception. Did they have realistic expectations? And it's always good to say, I'm sure you knew that this was a very complicated problem that we were dealing with. And when you speak, study the verbal, study the body language response, note its emotional content, and then tailor your statement to adapt to their perception and emotional state. So the way you would speak to a high court judge whose relative you have operated on and who's pretty close to being terminal is not the same way as you would speak to the man who was riding a bicycle, selling newspapers on the road, whose colleague has been admitted with a head injury. You have to tailor your statement to their ability to perceive. And finally, what's called invitation. How much do they want to know? It's very important to ask them, would you like to see his injuries? Would you like to see the state of his spine on that MR film or the extent of brain damage on the scan? Would you like to talk to the general surgeon who did the laparotomy so that you know a little more about how devastating his injury was? And do you want to know how much blood loss he had? I think it's important to ask this because sometimes giving them this information or showing them the patient or giving them information about the scans may be far too traumatic. So it's very important to understand how much they want to know. And it is very important that the information is commiserate with the educational standard and the understanding ability of the relatives. And finally, giving knowledge. And I say there are two parts of giving knowledge. One is aligning and one is educating. What does align mean? It means, and the pun is not intended, but did they see, do they understand the relationship between this motorcyclist who at 160 kilometers per hour went and hit a bus on the dual carriageway? Do they see the relationship between his injury and his ability to breathe? That's the alignment. You need to tell them that while you show them this horrific X-ray, which of course is not commensurate with survival. And then you need to educate. You need to tell them the nerve supply to the muscles of respiration. You need to tell them how the diaphragm needs to work for them to breathe, for a patient to breathe. And that this the nerve to the diaphragm comes from a part of the spinal cord which is completely damaged in this X-ray. You need to show them this X-ray, tell them how much the damage is, and then with you, they should draw the same conclusion, how impossible it is that this patient will breathe ever again on his own. That's aligning and educating. And finally, empathy with emotions. Assess the emotional response. And there are, in my experience, the following types of emotional response. The first is breaking down. If they break down because their father, or even worse, their child, is now unlikely to survive, wait. A pause often is much more eloquent than speaking. Show in your facial expression your own emotion, how you are suffering with them. Let the news sink in before you proceed. If there is aggression, don't tell them they're wrong. Don't shout at them. Tell them they're right. Tell them, as I often do, that I know how you feel. That's not the cause. There wasn't any mistake that caused this problem. But in your situation, I know I would feel the same. And explain, unfortunately, the patient belongs to that 20% or 30% or 40% who I told you in the beginning cannot be saved in spite of the best. And end by saying, we're still trying, the struggle is still on, but I'm not sure we'll win. Give them time for the aggression to come down. And if there's disbelief, and they say, no, this couldn't happen to my father, this could not happen. I brought him here, he was talking. He had this big, you told me he had an aneurysm that needed surgery, but he was talking. Be firm. Reiterate, this is the real situation, unfortunately. And if they're questioning everything, why did you do this? Why was this done? Why was he turned? Why did he have the thing strapped to his legs? Tell them I will be happy to answer any query. Let them ask. Answer truthfully without emotion. And a very important clue, don't be defensive. If you're defensive, then it will make them think something's gone wrong. And if you don't want to answer questions, it will make them think even more that you're avoiding the issue. And most importantly, in the presence of questioning relatives, don't argue. And as I said, sometimes silence is more eloquent than words. And finally, the strategy and the summary. Ensure you summarize the condition on arrival or pre-op. The effort everybody in the ITU has made and is still making, and then tell them how unlikely there is a chance of having light at the end of the tunnel. And a very useful strategy at this point is to narrate a personal friend or a relative who succumbed in a similar situation and make them understand that you too have relatives or friends who had the same sort of disease or injury and who couldn't be saved, and make the relatives feel that you feel the pain of their suffering before you close the interview. So let's look at some quick scenarios. Let's look at the following 5. Death after the patient has been brought in a serious condition. Remember that the stage of reaction of relatives to bad news, in my opinion, is 4. The stage 1 is disbelief. It can't be my relative who's had this. Stage 2 is anger. Why me? Why my father? Why my son? Stage 3, unfortunately, is the human psychology of assigning blame. Who is to blame? Some people will say, am I at fault that I missed something? Others will say the hospital is at fault, the doctor is at fault. Surely somebody is responsible for this happening to my relative. And finally, there is the stage of acceptance. So your job in this situation is to try and accelerate the progression from stage 1 to stage 4. And once they've reached stage 4, your job in breaking the bad news has been done. Remember, if you have death after a serious condition, talk to the same relatives who you explained the prognosis to before the surgery. Don't be abrupt. Even if the patient is brain dead, say in stages, say very serious. Go back a few minutes later, see he doesn't look likely to make it. Go back a few minutes later and say, I'm afraid we are losing our battle and our hopes, before you finally declare the death. And after breaking the news of death, if it is appropriate, I think it's worthwhile saying, I'm really sorry that we couldn't save him, but you could keep parts of him alive in another human being who may be saved if you can think of organ transplant. Very, very important clue in neuro-ITU. Never say brain dead. If you say brain dead, they will say, but the heart is working. So why don't we carry on? I never use the word brain dead. I always say he's dead. In a sudden, unexpected death, the problem is even more complex. You've done a routine procedure. Middle of the night, the patient has a myocardial infarction or a pulmonary embolism. How do you talk to the relatives? First thing, be in the ITU before the relatives arrive, so they know that you've been there and trying before they've come. Appear to be distressed yourself. Explain how it is a rare complication, but unfortunately this has occurred to his relative. If it's a cardiac issue, ensure the appropriate specialist is seen. For example, the cardiologist, and is available to talk. If cardiopulmonary resuscitation is going on, let them have a peep. Let them feel there's everybody trying. Speak about possible etiology and tell them how we're still in the dark about preventing such an adverse event. Then finally announce the death. If you've done a procedure and there's need for re-exploration, you've done a cervical fixation and the patient develops a esophageal fistula, that's much more difficult. But explain why it happened. Explain this needs to be done immediately. Explain the consequences of surgery versus not surgery. Explain the risks. And I think very important, don't give them too much time for taking a decision. Say the best chance is to re-explore immediately. Explain everything, be firm, get on with it. Remember, the more opinions they take, the more difficult it gets to achieve anything at all in this situation. And I always feel if you're going to have to re-explore after an operation where you didn't expect to have to do so, get a second opinion yourself. Get another neurosurgeon to see the patient so they can see, they can have a second opinion without asking for it. And finally, if there's a bad prognosis, bad histology, be blunt about the diagnosis. Remind them of what you stated was the prognosis of that particular diagnosis. Give them the truth about survival. And explain the need for improving quality of life, even the quantity may not be changed. And I think always it is better to end with an anecdotal example of a survivor you had who survived long, long beyond the median predicted survival. Give them a hope, but tell them, hope for the best, be prepared for the worst. The most difficult bad news to convey is infection and sepsis. And I think you should start by explaining the vulnerability of the patient and reiterating that the source is the patient, not doctors, not nurses, nor environment. Say how antibiotics have been escalated in spite of the culture reports, they're not working. I teach in a program in the National University of Judicial Sciences about medico-legal practice. And there, the lawyers love the word sepsis, because the moment there is sepsis, they teach the students immediately say it's the fault of the doctor or the hospital. So while you tell them about sepsis, at the terminal stage, use the word multi-organ failure because of the medico-legal consequences. And I can tell you this because I lecture in this course and I've written a book for this course on medico-legal medicine, and I have spent a lot of time in the company of lawyers. And finally, record in writing every time you speak. Record in 2 languages, record audio-visual if possible. And every time write down that the relatives say, I have understood what the doctor has said, and obtain a signature every time. And that's the summary of breaking the bad news. So it requires preparation, mental and scientific. It requires improvisation, tailor the interview to the audience. Most important, record everything, get them to sign saying, I understand. And in this whole process, express your own distress and your own suffering. Thank you very much. If you want to read more, here's a book you could try and read.
Thank you, Dr. Sandeep. I can't imagine of a better person who could convey this rather difficult topic in a better, more eloquent manner than Dr. Sandeep has done. And considering his background in law, he has made it much more interesting and concise. I don't see any questions in the chat box, but a couple of comments which I mean, he hasn't left anything, I should say. It's touched upon all the difficult scenarios that we come across in our routine practice. There are 2 aspects. One is conveying bad news directly to the patient, and one is conveying it to the relative. Relative, I felt, is at times both are equally difficult and equally challenging. But conveying bad news to the patient, that especially happens when you do a surgery for a preoperatively considered benign lesion and surprisingly turns out to be a really malignant one. And you would have given him some false hopes before the surgery, saying that it looks benign, and then you have to break this bad news of a malignant lesion with a very poor survival. And that is one area where I guess what Dr. Sandeep told is the best solution for that, where you give him an anecdotal experience of when you know very well that the overall survival is likely to be a couple of years. But the best example is to give him, best way forward is to give him an example of a person who is, I'm sure all of us would have experience where the patient has survived for long. Give an example so that he has a hope of continuing treatment and hope for better. The second aspect is how honest should we be in such scenario. Dr. Sandeep told that to be blunt. That's the best way, definitely, but it is quite challenging when you have to be very blunt and speak on the face to a patient that is survival as say 6 months or less than 2 years, as you would expect in a case of glioblastoma multiforme. So there we need to mask and our opinion and the way we convey our prognosis. As they rightly mentioned, it needs to be a customized approach. You can't have a one-size-fit-all approach for all patients, and it needs to be customized based on the scenario and depending on the intellectual and capability of the patient or the relative. this, I guess we'll move on to the next talk on this session. As I said, it is now the latter two talks are more patient-centric. And we have with us Dr. Ponnaya Vanamurthy from the MGH Healthcare. He's a senior consultant and head there. More importantly, he is also the secretary of the SNAC, as well as the secretary of the Neurocritical Society of India. And he would be talking on a very important aspect of sedation and analgesia. Over to you, Dr. Ponnaya.
Thank you, sir.
Dr. Pune, just 1 minute.
Yes, sir.
I'd like to introduce Professor Markland from Sweden. He's the chairman of Neurotrauma Committee of EANS. And we have collaborated, NSI has collaborated with him to have this webinar. Good morning, Professor Markland.
Thank you. Happy to be here.
Okay, thank you. And then we'll listen to you in the next session. Dr. Over to Dr. Pune, please.
Thank you, sir. Thank you, Dr. Manas and NSI for giving me this opportunity. So, as said, it's an important topic, sedation and analgesia in the neuro ICU, which we use daily, day in and day out. So there are practice guidelines to manage pain, agitation, and delirium, which was initially published in 2013, and later on, when in 2018, most important topic like immobility and sleep disturbance in the ICU were also included in these guidelines, and that made sense. So when we talk about sedation and analgesia, then the next question is why sedation and analgesia in the ICU? So we go in terms of this PATIS. So what is that? Management of pain, agitation, sedation, delirium management, assessment and management, immobility, active exercise in the ICU, thereby liberating the patient from the ICU, and managing the sleep disturbance in such a noisy environment. So when you want to talk about sedation and analgesia, it's not about one aspect of sedation or pain control. It's about all the aspects of the ICU liberation, which is pain, agitation, delirium, immobility, and sleep disturbance. So what happens in a wheel of pain misfortune is after a critical illness or surgery, an inadequate assessment and management of pain leads to inappropriate and increased sedative use, increased coma days, delirium, impairment in rehabilitation processes and mobilization. Thereby, we are compromising the ICU recovery. The rehabilitation gets prolonged, and thereby we land up in poor outcomes in terms of morbidity and mortality. So with respect to neuro ICU, apart from the same questions that we ask while we deal with sedation and analgesia in critical care, there is an element of neurological illness also, namely the brain injury. And the sedatives and analgesics, what we use, have its own effect on the cerebral metabolism as well, including ICP and cerebral perfusion pressure and the cerebral metabolism. So we need to slightly tweak our questions, and we need to slightly modify the protocol as per our patient's needs. So what are the questions we need to ask? So what are the factors influencing the pain in my patient? How do I assess the pain in my patient? How do I provide optimal sedation, weighing the benefits and risks of sedation? And how do I go by a protocolized approach, namely the A, B, C, D, E, F bundle, and derive a protocol on a patient-to-patient basis, depends on the patient need, a patient-centric protocol. So severe brain injury, do they need analgesia and sedation? A patient in coma doesn't mean that he doesn't need any analgesia or sedation. In the past, we have seen, especially in the emergency room, patient getting intubated after traumatic brain injury without administration of an analgesic, sedative, or a muscle relaxant. That should not be the case. Pain can happen at rest, which has to be managed. It depends upon the psychological factors, anxiety, depression, and the demographic factors like age, younger age are more prone for rest pain, comorbidities, the past history of surgery, all those things prone the patient for pain at rest. And there are procedures, various procedures which we do in the ICU, arterial line, central line, Ryle's tube insertion, Ryle's tube repositioning, positioning the patient for chest X-ray with tubes in situ. So all these have different kinds of intensities which has to be managed. And again, it all depends on the type of procedure, underlying illness, trauma, pre-procedural pain intensity, and the demographics. And remember, in neuro ICU, sometimes sedation can be therapeutic. We can alleviate intracranial pressure. We can use for refractory status epilepticus. And the benefits in neuro patients are basically it alleviates pain, anxiety, and distress. It facilitates mechanical ventilation, maintains synchrony with the ventilator. It provides an opportunity for invasive monitoring, and the performance of bedside procedures can control ICP, protect against cerebral ischemia, control of seizures, status epilepticus, in targeted temperature management, and in managing paroxysmal sympathetic hyperactivity. However, there are also risks, like it impairs neurological examination, but a carefully titrated analgesic sedation should not impair a regularly performed neurological examination. Yes, prolonged sedations and prolonged use of hypnotics is associated with delirium, increased length of mechanically ventilated patients in the ICU, and increased length of hospital stay, impaired cognitive and functional outcomes after discharge with prolonged sedative use, some cases of long-term opioid dependency. Maybe it predisposes the patient to sepsis, a heavy sedation, and thereby influence the mortality. So having known all these things, how do we assess the pain in our patients? Well, if a patient is fully conscious, awake, and he can report as a simple post-operative case, then they can self-report their pain in a scale, either a visual scale or they self-report. It's very valid. We can use that. But in a patient who cannot communicate, then we have to go for tools like behavioral pain scale in intubated and non-intubated patients, and the critical care pain observation tool. Any one of these scale has to be used in our ICUs. Proxy reporters, yes, especially in younger kids, adults, by their loved ones, if they say that the patient is suffering from pain, they know very well about their patient. Physiological measures, remember the heart rate, BP, saturations are not valid indicators. Yes, they can be used as cues to initiate further assessment and management, but as such, they don't denote pain. We can go for additional brain functional monitors like processed EEG, like BIS and other monitors. However, they have their own limitations, and in certain cases, they are certainly helpful as well. So we need to go goal-directed whenever we apply our therapy for sedation or analgesia. Either we have to use clinical scales. Most of the cases we have to use clinical scales, and as an adjuvant, we can use brain function monitoring as well if we have the facility for that. Not in all the cases, but in certain selected cases. So this is the behavioral pain scale which I was talking about. Every ICU should have a chart, and the nurse should be documenting it. And this is the critical care pain observation tool which I was talking about. But studies in brain injury are very small. I cannot say that this is very reliable, but it is feasible, and we can use it with ease in our ICUs. If you want to monitor the agitation and sedation, we have to use a Richmond agitation sedation scale. And when we administer sedatives and analgesics, then we titrate the sedatives and analgesics using the Richmond agitation sedation scale with from a score of 0 to -1. That's what we usually titrate. We usually aim for light sedation, not moderate or a very heavy sedation. Alternatively, we can use this Riker sedation agitation scale as well. Processed EEGs. There are studies, although in a small pool of patients who received neuromuscular blocking agents, relaxants, it might be beneficial, but there will be excessive artifacts in ICU environment, electrical interferences, all those things are there, patient mobility, and a lot of artifacts we can see with these monitors. There are multiple studies which attempted to prove those monitors. However, in some studies, it showed that there is a total sedative use and faster awakening despite similar clinical sedation with the help of processed EEGs. So this, in our practice, we use for deep sedation or if a patient is receiving neuromuscular blocking agents like a patient with severe ARDS, and in some cases, it will be helpful to titrate our sedation, especially when we want to sedate him very deep immediately after an AVM excision or after a status epilepticus. So we all know sedatives has an effect on cerebral physiology in terms of cerebral blood flow, the cerebral metabolic rate of oxygen, mean arterial pressure, thereby influencing the cerebral perfusion pressure and ICP. And we should know all these things because at the end of the thing, it's not about the drug which I'm going to talk. It's also about the art of practicing sedation. So for optimal sedation, we have to delicately balance the benefits and risk of the sedation and provide the sedation. And whenever sedation comes, it's the analgesedation, means analgesics first. So the first weapon is our opioid. We don't use benzodiazepines regularly or routinely, or hypnotics regularly or routinely, which has to be avoided because it has its own side effects. And sedation has to be goal directed on what you want depending upon the patient or disease targeted. Titration, very key, and a daily interruption of sedation. So when we talk about daily interruption of sedation, the ABCDF bundle comes in handy, which is assess, prevent, and manage pain, daily awakening and breathing trials, carefully choose the analgesia and sedation, assess, prevent, and manage delirium, early mobility and exercise, involve family and empower them in decision making. So in this case of an RTA, the GCS was poor, he was intubated and ventilated, chest injury with multiple fractures, hemodynamic stable and high ICP. So how do I sedate this patient? Opioids first, add a non-opioid adjuvant to reduce the opioid dose, and propofol that will do to take care of his ICP and targeted ICP management, including surgery if required later on. Doesn't need relaxant all the time. A status epilepticus patient, so what do you do? Opioids, propofol infusion as a therapeutic armamentarium of controlling the status under EEG guidance. So this is the way to go with this patient. A polytrauma patient with a normal ICP, so what do you do? Opioid and the non-opioid adjuvant alone is sufficient. He doesn't need any hypnotic as well. And if a patient has an associated severe lung injury or ARDS, then sometimes we might have to use also neuromuscular blocking agents along with the regular use of opioids and non-opioid adjuvants. And in these cases where neuromuscular blocking agents is used, ABIS may come in handy. A simple craniotomy patient, who's extubated on table, non-opioid analgesics will do. Always supplement with local anesthetic infiltrations or a scalp block that will give that will reduce the opioid use for breakthrough pain. So daily awakening trials are beneficial. Daily interruption of sedation is a must in our ICUs. And there are risks of daily sedation interruptions, namely self-extubation or pulling out of the lines, raised ICP, a transient increase in ICP or excessive movements, which has to be attended to. What are the choice of drugs? So what do you use? Opioids always comes first. If the patient is intubated, and opioids alone is enough in most of the patients. Add non-opioid analgesics, NSAIDs, paracetamol to reduce the opioid usage. Dexmet, propofol, and midazolam. The patient need hypnosis. Most of our cases doesn't need that. If the patient has raised ICP, then use it. Ketamine is coming in a big way. Volatile anesthetics are not used regularly, and non-pharmacological measures can be practiced. So opioids, as I told, is a first choice. It has own side effects. Use non-opioid adjuvant, acetaminophen, NSAIDs, low-dose ketamine. Neuropathic pain, add gabapentin or pregabalin. Regional nerve blocks in trauma. Multimodal analgesia, that's what we call, employ in all aspects and target differently with the different analgesic agents. IV lidocaine is not routinely recommended. Ketamine doesn't appear to increase the ICP both in patients with raised ICP and both in patients with non-traumatic neurological illness. So the choice of sedation is always mild sedation or light sedation, daily spontaneous awakening trial, nursing practitioner titrated infusions. Midazolam is not preferred nowadays, and this will improve the short-term outcome of the patients. Inhalation anesthetics are reserved for very refractory status epilepticus, not used regularly in the ICUs. And the non-pharmacological measures like hypnosis, massage therapy, and music therapy have their own role in reducing the opioids, especially. Physical restraints, very commonly used in spite of most of the people not recommending it, but always we need to be careful that there are ways to not to very tie the patient really to the beds, so that it gives a very anxiety look. We can use things like boxer bandages and other things which will reduce the agitation of the patients. Delirium screening, an important thing. For delirium screening, we can either use CAM ICU or the delirium screening checklist. And prophylactic use of haloperidol, dexmedetomidine, ketamine is not recommended for the prevention of delirium. So this patient, an RTA, came with a GCS of E3, V3, M5. So he was agitated in the CT room. He was administered sedatives. He was restless and agitated in the ICU. So how do you go about in such cases? So in our cases, ICP also comes in when we try to monitor and apply sedation. So when there is a high ICP, there is no indication of high ICP and the pain assessment is minimal, then we can even manage some patients with no sedation at all. But usually that situation will arise when we are in the weaning period. But if there is a high ICP, then we should go, as I told you in the beginning, with the case examples, with opioids first, then applying a hypnotics. That alone will do in most of the cases. If there is any clinical deterioration, obviously we do brain imaging and we take decisions accordingly. And pain, always opioids. To decrease the dose of opioids, give non-opioid adjuvants. Hypnosis, very rarely used. We don't use regularly midazolam for these purposes. Agitation and delirium has to be carefully monitored and treated. Ventilation synchrony has to be maintained at all the times. And while we are weaning, in most of the cases, they will not need any sedation at all, apart from some non-opioid analgesics. So every ICU should develop a protocol for their sedative and analgesic usage. Thereby, by implementing the ABCDEF bundle, we can liberate the patient quickly from the ICU, thereby provide them better outcomes. With this, I'll conclude my talk, and thank you, sir. I can answer any questions if any.
So thank you, Dr. Ponnaya, for a very lucid and concise presentation on a very important topic. I guess Dr. Markland has a question to ask. Dr. Markland, please.
Sure, thank you for a very nice presentation. I actually had two questions. Well, I'm going to start with the first. It's quite controversial to do wake-up test, interrupt sedation in severe TBI patients. In my previous department, we did it all the time. In my present department, we rarely do it. What's your take on that? How often should we do it to assess the status of the patient?
The general recommendation is we need to do daily sedation interruption. So at least for a few minutes, at least for half an hour or 1 hour. So even in severe traumatic brain injury, when you're closely monitoring the patient, especially when you employ additional neuromonitorings like ICP or the cerebral brain metabolism is NARS and things like that, I think that should not be a problem. That the concept of completely sedating and keeping the patient intubated, ventilated, and paralyzed has already gone, and we are not practicing it regularly. Yes, daily we need to interrupt the sedation. Yes, there is a risk of transient increase in intracranial pressure or patient agitation at that time. I think a nurse practitioner, a good nurse practitioner, a protocol-based approach will alleviate that situation. So when that is the case, they can always resume the sedation.
Thanks. Also, some centers use neuromuscular block a lot. We rarely use it. What's your take on that? Should that be added as well, or should we avoid it?
We should completely avoid it whenever it's not required. So initially in the previous era, we used to think that we need to completely paralyze the patient and keep it. But now that we have evolved, we have understood the risks of completely paralysis, the prolonged paralysis, prolonged neuromuscular blockade, which results in a lot of cardiopulmonary complications as well as the critical illness, neuropathy and myopathy. So except for severe ARDS cases, we hardly use neuromuscular blockade in this patient. And in the initial period, of management of the core brain situation, that till the time the patient get optimized either medically or surgically, beyond which we don't use regular neuromuscular blockade infusions.
Thank you. Agree. Yeah.
Thank you, Dr. Panay. I mean, a couple of questions from my side, if you don't mind. One is you talked about objective ways of assessing pain and sedation. So during the weaning time, do you have any cutoff parameters when you decide, okay, like when you take a patient off ventilator, blood gas, we have parameters, so sedation and pain. Do you have any objective? You said you need to have the COPT and behavioral pain scores. We maintain that, and do we have an objective way to say, okay, this patient can be stopped off sedation if the score is beyond this or below this? Are there any parameters like that?
The BPS and CPOT scale, they're very good scores. And also we can employ this, the Ramsay agitation sedation score to control the agitation sedation. The patient remains calm and quiet. And most of the times, as we see in our ICU also during the weaning periods, most of our patients doesn't need any sedation at all. They will not need, at least opioids they would not need. They would be just managed with simple non-opioid analgesics.
Yeah, thanks. And the other one is, I mean, quite often in traumatic brain injury, we see these patients with under the influence of alcohol or alcohol withdrawal. How do we titrate our sedation analgesia in such patients where we're not sure what exactly is it, pain or some other factor which is causing the disturbance?
So the initial period, it's always opioid first, then non-opioid adjuncts. But later on, this problem mainly when we are trying to wean the patient from the ventilator, or the next day after 24, 48 hours, when you try to get the patient out of the ventilator, do a CT scan, you are satisfied there's some contusions, patient is excessively agitated, then there we use haloperidol, there we use drugs like Librium, there we supplement the patients with thiamine. So all those things comes inside. Later on, for prolonged duration of agitations and things like that, then we can switch over the patient to oral quetiapine or things like that. So that's how we manage. So in alcohol withdrawal, you suspect, then supplement with some kind of benzos like Librium and drugs.
And one more short question about parasympathetic sympathetic hyperactivity, which is again a very frequent problem. Now the role of amantadine and gabapentin and so forth for these, because they also patients have this kind of hyperactive episodes, hypersympathetic activity episodes. So what is your recommendation?
So usually we see once the patient is getting weaned off from the sedation, we see this paroxysmal sympathetic hyperactivity. Not only in traumatic brain injury or SAH, it's seen in more cases of stroke, and any case we have case data on that. So usually I prefer non-selective beta propranolol as the first choice. Sometimes we need to give it a very higher dose because that works very well. And initially we are using clonidine a lot, but now we are using predominantly propranolol with low doses of clonidine as well. Like you said, in some cases with excessive sweating may respond well to a low dose of bromocriptine. And like you said, gabapentin and things like that also added. So we need to titrate to the patient's response. We have the paroxysmal sympathetic severity scale, which will say that it is a probable or possible PSH. Then accordingly, we need to titrate it.
Thanks, Dr. Pannaya. We'll move on to the last talk of this session by Dr. Suparna, whom I know from her post-graduation days in Sri Chitra doing a day in neuroanesthesia. Welcome, Suparna. And she's a faculty in the National Institute of Mental Health and Neurosciences at Bangalore. And she will be speaking to us on nutrition and neurocritical care. Again, and often I would say neglected, but very important and a crucial topic. Over to you, Suparna.
Thank you, sir. Before I begin, warm greetings to all of you from Nimans, Bangalore. I would also like to thank Dr. Manas and NSI for giving me this opportunity. We all know that we are what we eat, and we are made up of what we have eaten, when we have eaten, and how much we have eaten. So in the context of critically ill patients, if you consider, they are all at risk of malnutrition. The incidence of malnutrition is about 30 to 50% in any given hospitalized population. And it's way high in patients who are critically ill, and that in turn leads to a lot of complications and increases the hospital cost. Let me deal with some of the numbers in the neurocritical care patients. About 60% of them have difficulty with swallowing. About 40% of them are at risk for pulmonary aspiration. And any given patient of acute brain injury may have a risk of weight loss by about 13 kilos. And feeding intolerance is seen in about 55% of the patient. And if you take any patient of head injury, that is severe head injury, he is at risk of increase in metabolic rate by up to 240% as compared to any other patient who doesn't have neurotrauma. And it's very essential to feed this patient and initiate feeding within 24 hours of sustaining acute insult. And if you don't feed them up to 5 days, then the mortality rate increases substantially. The objective of this study is to answer some of these questions which are asked commonly with regards to nutrition of a critically ill patient. The first question is, how do we recognize patients at nutritional risk? So to do that, we need to find out first if he is at nutritional risk prior to the insult at all. If he is already malnourished when he is admitted to my critical care unit. And next step is to understand or calculate what is his energy expenditure per day at rest and under stress. And you can do that using feeding equations or using some gadgets, or you can simply calculate the energy expenditure using prefixed formula just by plugging in his weight to that formula. The one of the most commonly used score is Nutric score. It involves age, Apache score, SOFA score, number of comorbidities, and days in between his hospital admission to ICU admission, and if at all we have interleukin 6 values. The higher the Nutric score it is, higher is my patient at risk for malnutrition. So I should be very aggressive in treating his malnutrition on. I need to start the nutrition as early as possible. The other score that is most commonly used is subjective global assessment rating. It involves additionally the gastrointestinal symptoms as well. This tells me if my patient is fit for enteral feeding or if I need to give him parenteral feeding. It also takes into account functional capacity as well. So the larger the score is, higher is my patient at risk of malnutrition. The second question I need to answer is, what is occurring in these patients metabolically? As soon as a patient sustains an acute insult, there is a slight dip in the metabolic activity. But during the recovery phase, there is a very high increase in the metabolic activity and patient goes into catabolic state. And if the patient slips into chronic phase of illness, then this catabolic state never returns to baseline. So as a result, lot of inflammatory markers are released, and you may measure them, and you see that majority of them will be increased. The next question what you need to answer is, how much to feed my patient who is critically ill? The gold standard method is indirect calorimetry. However, this requires a device, and it tells you what is the maximum oxygen consumed by the patient and what is the CO2 released. You plug these values into this Weir's equation, and that will give you the basal metabolic rate. And if you don't want to use this, you simply calculate the caloric requirement by multiplying the weight of your patient with the 25 or 30, and that gives you the total caloric need for that patient. And this is how the indirect calorimetry is used. It's a small device which is attached to the patient's ventilatory circuit, and it gives you the total oxygen consumed and the carbon dioxide released by the patient. If the patient is not on ventilator, you can use a mixing chamber, and Again, that will tell you the total oxygen consumed and the carbon dioxide released by the patient. There are hundreds of formulae that have been validated. The most commonly used ones are Harris-Benedict equation or Penn State equation, and all of these are available as calculators online. You just have to plug in patient's demographics, and that gives you the basal energy requirement for that patient. If you had any pulmonary artery catheter, which is very, very rare in the neurocritical care unit, you can also use the reverse Fick method. The next question what you need to answer is, should patients within the ICU be fed enterally or parenterally? What is the current evidence? Yeah, as far as routes of nutrition, most common are enteral, parenteral, or combination of both. So when you do the enteral nutrition, you have the choice of using nasogastric tube or nasojejunal tube. The advantage of nasogastric tube is it's more physiological and easy to insert, but the disadvantage being patients are at risk of pulmonary aspiration, GERD, and delayed gastric emptying. But if you use nasojejunal tube, the risk of pulmonary aspiration is low. However, it is technically difficult to insert. So this is how the correctly positioned nasogastric tube looks like. You may also position it in the lungs and cause problems, or if there is any skull base defect, you can find it in the cranial cavity or even in the spinal canal. How about parenteral nutrition? To do the parenteral nutrition, you need a PICC line and or you need a central venous catheter. The disadvantage is that it's not physiological, so you can have breakdown of the GI mucosa and hence translocation of bacteria and then release of endotoxins, and patients are at risk of sepsis. However, the evidence says that if you fed your patients enterally or parenterally, there is no difference in the outcome, but do it early. Don't wait for days together before you start the parenteral nutrition. The next question is, what are the risks of enteral nutrition? The foremost what you need to take care of in your patients who are sedated, hypotensive, or who are at shock or sepsis are at higher risk of aspiration. So to avoid that, you give a propped up position to your patient. You start your patients on prokinetics like erythromycin or metoclopramide. You initiate early mobilization of your patients, and at the same time gastric aspirate could be a risk for pulmonary aspiration. That is, when you aspirate the Ryle's tube, a lot of feed comes back. So however, you tolerate up to 250 ml to 500 ml of gastric aspirate, and you continue to feed the patient enterally. That is what is recommended. The other complication what you expect is refeeding syndrome. So your patient is already in catabolic state, so you may end up feeding your patient over enthusiastically, ignoring some of the nutrients which are essential when the anabolic phase sets in. So if you ignore the nutrients like phosphate, magnesium, vitamins, potassium, thiamine, then the patient may slip into refeeding syndrome, and he may show up with symptoms of deficiencies of these micronutrients. So it is better to feed these patients with the phosphate, magnesium, vitamins, and minerals. Then if you overfeed your patients, then in that case you may see uremia, hyperglycemia, hyperlipidemia, fatty liver, hypercapnia, and even fluid overload. So if you are giving your patient propofol infusion, take into account the calories provided by propofol as well. 1 ml of propofol provides about 1.1 kilocalories of energy. So you need to take into account that as well. The last question is, are there anti-inflammatory enteral immune cocktails? So these are arginine and glutamine. However, substituting them may help in patients with trauma. They help in the growth and function of immune cells. However, there is no clear-cut evidence if you want to use them or not. Now just I'll tell you how to calculate energy requirement for a patient. This is a case scenario where we have a 25-year-old patient weighing about 50 kilos on ventilator after head injury. He's on ventilation, so you need to feed him. You have the choice of enteral and parenteral. So 99.9% of the patients in the neurocritical care can be fed with the enteral or nasogastric tubes. So in this patient, if you need to use simple calculation, he weighs 50 kilos, so I will give him 25 kilocalories per kg of body weight. So that comes to 1250 kilocalories. That will be the need for the day. And you also have to supplement protein about 1.5 to 2 gram per kg. So his requirement will be 75 grams of protein. If you want, you can also identify his nutrition risk using Nutric score. These are all calculators available online. You can use Harris-Benedict equation. Again, online calculators are available. But when you use the Harris-Benedict equation, then what comes is the basal metabolic rate. You need to multiply it with a factor of 1.2 to 1.9, which is the stress factor. And the energy requirement is either 1500 or 2500 kilocalories. So it's slightly higher than what you calculate as per kg body weight. But something is better than nothing. So if you don't want to use this, please use per kg body weight kilocalories. Now we need to find out how much volume you can give the patient. So one of the simplest formula used is 4 to 1 rule. It is for the first 10 kgs you give 4 ml, next 10 kgs you give 2 ml, and the rest of the body weight you give 1 ml per kg. That comes to 90 ml per hour, and in 24 hours you can give up to 2 liters of fluid to this patient. So this is the drug chart of one of our patient who is very poor. He has no money. He is with us since 5 years at Niemann's on ventilator, and all that he can afford is just the Horlicks. Still we are able to give him the energy required. That is, we use about 4 eggs per day, ragi ganji and milk, which are provided by the hospital. And this is the drug chart, and in 2 liters of fluid we are able to give him 1500 kilocalories and about 90 grams of protein. We feed him thrice in the forenoon, thrice in the afternoon, and one feed at 10 p.m. and hardly we feed him overnight. Other mixes what we use in Niemann's is Hyderabad mix and Davangere mix. They are very economical and very good in nutrients, so our patients don't have any kind of malnutrition issues. Other commercially available ones are Protein X and Horlicks. Patients who can afford get these, and we give them as enteral nutrition. And one more thing is, if the patient is already on a nasogastric tube, you encourage that patient to take orally as well if the swallowing is intact, and you give him soft diet. And if the oral intake is insufficient, you supplement with nasogastric tube, nasogastric feeds. The other one is total parenteral nutrition. We hardly practice it in the neurocritical care. If there is any abdominal issue, patients goes out of the neurocritical care. However, there are again calculators available, and you can supplement dextrose, protein and lipid separately to these patients. To conclude, whatever I have told is exactly from bundle, that is American Society of Parenteral and Enteral Nutrition. First step is to identify if the patient is at risk of malnutrition, then calculate his energy need and determine what kind of feed you are going to give him. If it is enteral feed, give the feeds in the propped up position, start him on prokinetics, and also ignore these gastric residual volume, that is RT aspirate up to 250 to 500 ml, and your patient can continue to receive that. If the patient has any issues of feed tolerance, you can start him even on continuous infusion through the Ryle's tube. So with that, I conclude. Thank you.
Thank you, Suparna. Exhaustive coverage of the topic. Again, I don't see any questions in the chat box. I'll just start the ball rolling. I just wanted to know, what are the early signs of malnutrition in the ICU that you would be looking for? And I mean, do you say that, okay, you're giving your feeds according to your calculation, but still for some reason patient is not doing well. So what are the early signs, objective ways to assess that your diet is not sufficient and you want to hike it up?
So mostly we do the muscle thickness. That is an objective way of identifying, because for most of the patients we do not have any baseline. So we use the ultrasound and we measure the thickness of the rectus femoris about 20% of the distance from the anterior iliac spine to the tibial tuberosity. So that's where we measure the thickness of the rectus femoris in every individual, and that would be our baseline, and accordingly we titrate our nutrition.
Any
There's a question
biochemical
by Dr.
Oh, sorry.
There's a question by Dr. Markland in the chat box.
Okay, let's see.
Okay, yes, I think he's written to me. Professor Markland, you can ask the question. It's okay.
Sure. Yeah, so you mentioned the metoclopramide. Is that used sort of routinely, or what's the indications to use it? We are a little not skeptical, but we use it rather infrequently. What's your status on that?
We don't use that frequently, only if we suspect that there is gastric aspirate coming out. We tolerate up to 250 ml of gastric aspirate, and if more than that comes out, and after ruling out sepsis or if the patient is on shock, then only we start these patients on metoclopramide. However, we don't have reservations to start the patient on erythromycin.
Thank you. At what point do you suggest or recommend PEG or jejunostomy, percutaneous endoscopic jejunostomy? At what point do you say we'll switch over from nasogastric to a PEG?
So once the patient goes out of the intensive care unit, the provision to maintain the nasogastric tube and keep feeding the patient propped up and taking care of him, the ability of the nursing care goes down. So that's when we recommend PEG in our hospital. However, we refer these patients to step down hospitals, and we don't do PEG in Eans.
Okay. Thank you, Dr. Suparna.
Thank you.
This month we are 10 minutes behind schedule, I guess.
Yeah. And thank you, Dr. Girish, for at least completing in time. And thank you, Dr. Suparna, for giving an excellent lecture on nutrition. At the end of this session, I realized that not only we spend 1 month of neurocritical care, as Dr. Joseph said, we have to spend 1 month with a legal team, as Dr. Girish said, 1 week, and 1 week of acting, as Dr. Sandeep said. He's a good actor also, the way he presented. One needs to have 1 week of acting to sympathize and empathize with the patients, and 1 week of nutrition also in the nutrition department to understand how to manage patient nutrition, and 1 week with the pain specialist, as Dr. Pune said, to manage pain in unconscious patient. With these few words, we'll conclude this session, and I'll hand over to Dr. Suchanda and Professor Matthew Joseph to conduct the next session.
Thank you, Manas.
Thank you, sir. So the next session is like issue-specific factors in neuro ICU, and we have Dr. Matthew Joseph as the chairperson of this session, and I invite you, sir. And the first speaker is Dr. Anand Balasubramaniam, and he is the head of neurosurgery of Yashoda Hospital, Secunderabad. Sir, your slides are not yet up, Dr. Anand. Okay, fine, thank you. So we have Dr. Anand here, who is the head of neurosurgery at Yashoda Hospital, Secunderabad. And over to you, sir.
you, Dr. Suchenda. I'm going to speak on management of patients with oral anticoagulation-induced ICH. Rather, according to the pathophysiology, it should be management of oral anticoagulant-related ICH, because anticoagulants by themselves don't induce ICH by large studies, which have shown that pre-existing bleed can get worse with use of anticoagulants. However, we do know that anticoagulation induced or related ICH is much more common than in general population. It's 7 to 10 times more common in patients with oral anticoagulation treatment. And among all intracranial bleeds, the intracerebral hemorrhage is almost 50 to 80% in various studies. The only good factor is we were with our old friend warfarin for a long time, which are vitamin K antagonists. The direct oral anticoagulants are about 50% less hematomas than the vitamin K antagonists. If you see the damage that the hematoma causes, so we are all aware of the spontaneous intracerebral hematoma pathophysiology and basis, the role of surgeon has been to reduce the acute mass effect that arises. We can hardly do anything for the primary brain injury. We can only prevent or correct the cerebral herniation as it happens, and probably help out in those patients who are gradually deteriorating because of hematoma expansion. So today we are not going to discuss anything about surgery because that remains the same, whether with or without anticoagulation. But the main reason with anticoagulation-induced ICHs have to be dealt with differently is because they tend to worsen clinically. Even if there is a small bleed, we do know that all intracranial hematomas can increase in size. About 1/3 of them increase over a 24-hour period, as described in some studies. With anticoagulation in the picture, it may be as high as 50%. And due to hematoma enlargement, there could be issues. So we need to see that the BP is under good control and rapid reversal of anticoagulation is achieved as early as possible to prevent this becoming more serious in nature. Now, hematoma expansion, there are a lot of indicators in the radiology. In a CT scan, there is described a spot sign, swirl sign, or a black hole area of non-clotted blood, which may be indicator of rapid or non-coagulated bleeding with the fluid level, which may be seen. This is seen in a patient with oral anticoagulated ICH, which has worsened in less than 6 hours time. And this intraventricular extension also is considered to be more common with this group of patients, and which of course is associated with more poorer prognosis. So if you overall look at the risk factors for oral anticoagulation associated ICH, age probably is the most non-modifiable risk factor. Then we do have hypertension, which is a main modifiable risk factor, which needs to be attended to. Here, I would give you a caution. As most of the people admitted with neurophysicians, they tend to treat them with not lowering the blood pressure because they are used to treating ischemic strokes, wherein the threshold for BP, the systolic BP, is kept higher to prevent the penumbral ischemia, whereas hypertension-induced intracerebral bleeds and those with oral anticoagulated assisted bleeds, it's better to bring down the BP to normal as possible for that age, maybe 140 or 160. The intensity of anticoagulation being higher is another risk factor. Generally, it happens between 2 to 3 INR. If it is more than 4, it is definitely increased risk of intracranial bleed. Other risk factors are previous ischemic and hemorrhagic strokes, markers of small vessel disease such as microbleeds or white matter changes, concurrent antiplatelet increases the risk in these patients, and genetic predisposition with upper lipoprotein E alleles. So we come down to the agents. Thankfully, there are not very many of them, though a lot of them have been launched. The commonest we all need to be aware of is warfarin. The INR is a good, reliable indicator. It is cheap and widely available, and it's fairly routine. But the threshold for reversal of treatment with INR in these patients is little controversial, but a cutoff of between 1.2 to 1.5 has been given as various guidelines. But suffice to say that if the INR is less than 1.3 And if the systolic BP is kept definitely below 160, it definitely reduces the risk of increase in the hemorrhage in these patients. Now, once there is a patient with ICH with vitamin K anticoagulation, one has to immediately discontinue the vitamin K anticoagulant, warfarin, obtain a baseline INR, start with vitamin K loading and slow infusion, and if available, the prothrombin complex concentrate, 4-factor would be the ideal agent of choice, and the dosage varies according to the INR. And if that is not available, you can go for a 3-factor PCC or an activated PCC. If the PCC itself is not available, fresh frozen plasma is good, and it needs to be administered at 10 to 20 ml per kg, which is a large volume. And keep checking the INR periodically and ensure that it comes down below 1.3 so that it's considered safe and will not lead to further increase in size of the clot. Coming to the direct acting agents, these are dabigatran, which is the first group and the most popular, which is a direct thrombin inhibitor. And then the newer agents which have come, the rivaroxaban, the apixaban, and the edoxaban. The important things to note here are the dosage, which is once a day in the last two, and say twice a day in dabigatran and apixaban, because of the difference in half-life, which is generally between 6 to 12 hours. And the plasma peak is usually achieved around 2 hours time. This gives you a window to act on them if you know that they have taken the drug within the last 2 hours. And they all have hepatic and renal variable percentage of metabolism. So hepatic and renal dysfunction tends to change our approach in these patients clinically. It's important to understand them as there are no definite tests that could indicate their dysfunction easily as the newer agents are getting released. Dabigatran probably is the simplest. APTT is a good test to assess, but if it is normal, it's not reliable because it's only a qualitative assessment. It's not a quantitative assessment. And if it is elevated, yes, it is definitely indicates presence of dabigatran activity in blood. Still, INR has no role in monitoring, and diluted thrombin time and recurrent clotting time are two tests that can directly indicate the level of activity of dabigatran, which could be read in a graphic form and can be correlated to 30 nanogram per ml threshold for correction of dabigatran-induced oral anticoagulation. However, these are not available in most hospital and centers, so sometimes you have to go purely by clinical, time of last dose, and renal and hepatic dysfunction. How do you manage? So thankfully, dabigatran has got a direct monoclonal antibody inhibitor, which binds more specifically to dabigatran than dabigatran's affinity with thrombin. So it has to be given in divided doses, and it is pretty expensive and again not easily available. One does not have dabigatran, you can raise the substrate of thrombin by giving prothrombin complex concentrate or activated PCC. If these are also not available, and if your patient has taken the medicine within 2 hours, you can use activated charcoal to chelate the drug in the gut, so preventing it from absorption, reaching peak levels. And if it is beyond 2 hours, you can even try emergent hemodialysis to take away the effect of dabigatran. Now coming to the other inhibitors, which are the factor 10 inhibitors, we have 3 of them, the rivaroxaban, edoxaban, and apixaban. Now, what are the tests that are to monitor them? Well, the gold standard will be anti-factor 10A activity so that you can have a quantification of the factor 10A. APTT, PT, INR, unfortunately, do not have much of a meaning in assessing the effect of these inhibitors in blood. The correlation of 10A activity has been direct to hematoma expansion. So again, this is not easy to get done in most hospitals. So the clinical factors, again, time of the dose, renal and hepatic dysfunction come to the fore. Now, the good thing about these factor 10A inhibitors is you have a recombinant factor 10A readily available, which is andexanet, but it's hugely expensive. It's one reversal itself may cost somewhere around $25,000 US. It's not easily available. I don't think it's available in the country, and it has to be given as an infusion. There could be thrombotic complications too. So one has to consider giving this drug. If not available, it's cost effective to give PCC, which again is not easy by Indian standard. This is so would cost about $1,000 to $2,000 US. So activated PCC or 4-factor PCC are difficult modes to obtain to correct the anticoagulation. So what would one do? These are off-label indications. You can use Novo-7, which is relatively cheaper, or FFP. No specific recommendation is available or studies. The good thing is if a patient is hypotensive and requires rapid volume replenishment, then FFP may be a worthwhile applicant here. And adnexanet is approved only for rivaroxaban and apixaban. It's not yet approved for edoxaban, though it can be used as an off-label indicator if available. So in general, the most important factor is going to be maintain your blood pressure to as normal as possible, reverse anticoagulation as quickly as you can, watch for the risk factors to prevent the hematoma from expanding further, INR APTT where it is applicable, dilute thrombin time and the occurrent clotting time and factor 10A assays if they are available. Otherwise, the time-tested clinical details of the patient, time of dose taken, and the hepatic and renal function parameters would dictate how to practically manage the patient. Specific antidotes, vitamin K and andexanet are available. We should be aware of them. So there could be a patient who can afford getting them or sourcing it. So we should not be found wanting and not knowing that these are available and these can be used. And prothrombin complex concentrate is easy to source. It is expensive. Factor 7 and FFP are easily available too. And of course, charcoal and dialysis options should always be kept in mind. And I think in this, interacting with the hematologist and with the nephrologist in association will take a long way in treating these patients in intensive care very well. So in conclusion, I would say all these patients, even if they have a small bleed, if they have a history of anticoagulation intake, they should be admitted and managed in neuro ICU, however well preserved they are. Conservative management does not mean no role. It's aggressive medical management. So we have to keep a close watch on them, monitor the parameters, try to normalize the blood pressure and the coagulation parameters to as early to normal as possible, stop the anticoagulants, beware of the thrombotic complications then it can lead. We have had cases in which we have been over-enthusiastic in treating with the FFPs and platelets in a patient who had both antiplatelet and anticoagulation. And post-operatively, he landed up with severe thrombotic complications, pulmonary thromboembolism and morbid outcomes. Surgical intervention as fit, it's nothing special here, whether evacuation, decompressive craniectomy, minimal invasive procedures as and when patient is worsening can all be considered as deemed fit by the surgeon at that point in time. And restarting anticoagulation for primary indication should be done as early as possible to prevent the complication and morbidity of the primary disease. But one has to know whether the scan is stable or if the ICH which has been managed conservatively is stable. There is no given time when to restart. We would do it after a 12-hour and a 24-hour scan to see that it is not progressing any further and then start doing the same and use maybe agents which are easy to control like heparin to do with initial stages so that you can switch over to oral anticoagulant agents at a later time when things are more stable and would not need any acute intervention in future. So with this, I end my presentation and open for discussion and questions. Thank you for all your attention.
Thank you, Anand. That was a nice summarization. I thoroughly enjoyed your tables. They were very informative without being excessive. Anybody have any questions?
Yeah, can I ask one question?
Yeah, Manas.
Means when do especially patients who have valve replacements who are on anticoagulants and they come with bleed, and so when do you restart the post-operatively back to the anticoagulant? Where it's a double-edged sword. If you stop it, there can be valve get stuck. And if you don't, if you start it early, you may have ICH. What are the recommendations for that?
Matthew, should I answer the question?
Yes, please.
Yeah, thanks. So when these patients do come, we discuss with the cardiologist, and going by the risk of progression of the clot versus risk of developing a thrombotic complication because of the cardiac event, we discuss and start the patients on standard unfractionated heparin as a gap, so that we can keep the anticoagulation going, but reverse it as early as possible if required, if there is a hematoma expansion. But of course, the first 12 to 24 hours, we would explain to the relatives and stop all forms of anticoagulation till the clot is stabilized. After which, when we restart, after the clot is stable, confirm that it is stable, we usually do it with unfractionated heparin, then switch over to maybe low molecular weight, and take our own time, maybe a week or 2 or even 3 before we switch over to the oral anticoagulant again.
Yeah, so if you have a 24-hour, 12-hour, 24-hour no progression, you would start at 24 hours?
Yeah, see, it's, I tell the cardiologist, I allow the cardiologist to tell me how long is it safe for me to stop. So the cardiologists have their indication. They go by the duration of how long back the patient had a surgery, whether the valve is biological or mechanical, and what is the risk of thrombus there, and what is the risk of this progressing and being fatal. So if they give me a window of at least 2 or 3 days, I push it to 2-3 days. If they say, no, we cannot stop it at all, it's an acute case, even 1 day will cause a thromboembotic episode, then I would take 24 as a value. It's not a hard and strong 24-hour value. Yeah.
How about somebody who had to intervene surgically?
The first post-op scan we do at 24 hours. We make sure that that has not shown a rebleed or a worse scan than what we started with. If that is stable, and if the cardiologists are jumping behind our back to restart anticoagulation, then we give them a signal at 24 hours, but only unfractionated heparin.
Is there a publication, or it's that's what you practice? Means how do you tell that this scan is stable? Means what are the criteria to tell the scan is a stable scan?
Manas, this is highly controversial, and there are no publications. You have to go by personal. You have to go by personal experience and by anecdotal, or there are papers of observational studies where they have shown that use of anticoagulation after 12 or 24 hours after a surgery has been safe enough. And there are papers in venous prophylaxis for thromboembolism in pulmonary embolism patient and DVT patients, when to start anticoagulation and when to stop your mechanical thromboprophylaxis. So all of them uniformly at least say, the guidelines wise, that beyond 12 to 24 hours of surgery, it is safe to start anticoagulation. So we are just, I'm clinically extrapolating them to ICH situation.
Yeah, I mean, the other common thing what we get is subdurals following aspirin or clopidogrel. So when it is safer to restart after surgery?
But we want to take that.
That's even worse. Even more complicated.
Most often what I have seen is that at least 50% of them, they are not indicated.
Yeah.
Their primary prophylaxis started by somebody, they don't know what is the reason for which it has been started. And so we safely stop in all of them. So again, I leave it to the cardiologist. We discuss with the cardiologist in close detail and tell them, look, which is your window period wherein you think. It is usually the stent patients who have had a cardiac stent, where the cardiologists are worried about having a thrombus or blockage of their stent. And the ones which are drug-coated are even more dangerous if it is within the first 3 to 6 months. So there is a no. They say, no, you cannot stop. So there we have to weigh which is worse of a risk, whether developing a rebleed is a risk or having a thrombus is a risk. But going by most of pathophysiology, if we consider that these agents by themselves don't cause the bleed. If there is a small trauma or there is a bleed, they prevent them from stopping. So I don't think we should be too worried. Probably we have to weigh the balance and individualize it to the patient and do it accordingly.
Yeah, thank you, Dr. I don't think there is any definite answers to any of these questions. Yeah. Thank you.
Thank you. Thank you, Manan.
Suchanda?
Yeah. I think we go to the next talk again at a specific entity of status epilepticus, and we have Sita Madam. Dr. Sita Jayalakshmi Madam is the consultant neurologist at Krishna Institute of Medical Science, Hyderabad. She's a noted epileptologist. And here, Madam, over to you for the management of status epilepticus.
Thank you, Sujanda. I thank Dr. Manas and NSI for giving me this opportunity. So I'll talking mainly about the principles of management of status epilepticus, both convulsive and non-convulsive in the neurosurgical intensive care unit. It's very important because nowadays we are seeing more number of patients with refractory and so-called super refractory status epilepticus. Similarly, in neurosurgical ICU, as we see in the neurological ICUs, which needs immediate and prompt treatment because lack of early identification and treatment is associated with permanent neurological damage, and not only that, poor long-term neurological outcomes. But however, there is paucity of high quality evidence available to make a guide the decision making in the neurosurgical ICUs. So most of the time we extrapolate the same from the neurological ICUs. So I briefly will discuss about the definitions, causes of status epilepticus in the neurosurgical ICUs. What is the role of so many anti-epileptic drugs which have come in the past 2 decades? Role of IV anesthetic drugs. And what is the summary of evidence for the treatment of status epilepticus at present, and any guidelines and controversies? So the causes of status epilepticus in the neurosurgical ICU, all of us will know. Most of the times it is traumatic brain injury, which is either with or without the skull injuries, and also with or without intracerebral hemorrhages. And others are neurovascular events, especially following a stroke, post-decompressive craniotomy, subarachnoid hemorrhage, ICH, AV malformations, even CSVTs, and also hyperperfusion syndromes, that is following thrombolysis, and also tumors, especially the gliomas, and also metastatic tumors. In addition to this, one should always remember the patients who are on antibiotics like meropenem and other drugs are also at SFE-PIME. They are all at risk of developing non-convulsive status, which goes unnoticed. And also, so many patients might be on comorbidities and using antidepressants, antipsychotics, which are either suddenly stopped or the drugs themselves can cause status epilepticus. The other causes include following surgery, or the patient comes with either an abscess, meningitis, encephalitis, which can cause status. And also metabolic abnormalities is a very important entity. The commonest being hyponatremia, hypoglycemia, renal and hepatic issues, and rarely hypophosphatemia and even hypocalcemias can present with the refractory status epilepticus. So before going that, it's important to know the 3 definitions of status epilepticus, mainly for the residents. Status epilepticus is a seizure lasting for more than 5 minutes or recurrent epileptiform activity over a period of more than 5 minutes without regaining of the consciousness in between, even if the person gets 2 or more seizures in the 5 minutes. And once it is resistant to one first line, that is midazolam, and one second line AED, that is one of the anti-epileptic drugs, is coined as refractory status epilepticus. However, the most important is the super refractory status epilepticus, where even after giving the one first line, one second line, and continuation of these drugs for 24 hours or more, along with anesthetic drugs, that is either midazolam or other drugs, if the patient continues to have seizures after 24 hours of first line, second line, as well as IV anesthetic drug, it's called super refractory status epilepticus. So the neurosurgical teams and intensive care unit staff should be adequately sensitized to identify early and also the start treatment very early, because the later the treatment started, the higher the mortality. In addition, another important entity is the prolonged state of impaired consciousness or altered sensorium due to non-convulsive status epilepticus, which on EEG is associated with a paroxysmal activity or electrographic discharges. So it responds to anticonvulsants. So it's very important that the criteria should include clinical as EEG improvement after giving the IV midazolam for an improvement in both clinical status as well as the EEG status. So most of the times when we look at the status epilepticus, it is convulsive, very easy to identify and act immediately, which can be tonic-clonic, myoclonic, or even sometimes epilepsia partialis continua, with or without secondary generalization. The most challenging one is the non-convulsive status, where most of the times in the neurosurgical ICUs, it is in the form of complex partial status, where the patient will have continuous staring, along with some automatisms. So this is one of the important studies which looked at the non-convulsive status in the neurosurgical ICUs, where they found that the traumatic brain injury is the leading cause both for convulsive as well as for non-convulsive status, followed by tumoral lesions, intracerebral hemorrhage, subarachnoid hemorrhage, and hydrocephalus. So this is just an example to show how a non-convulsive status continues in a child who is totally schizophrenic after treatment. But if you look at the tongue, he is continuously having twitching movements of the tongue and also at the face, and also mild movements of the eyes. Sometimes it can be in the form of nystagmus or subtle movements of the limbs. And this is the corresponding EEG, which shows continuous spike discharges and a background which is very low amplitude. And this is the another epoch of the same EEG. Sometimes the non-convulsive status can be in the form of a complex partial status, where the person is confused, looking around with clouding of the consciousness. And sometimes you can have sweating, automatic behaviors, as seen in this girl, who is continuously staring with some eye blinking, looking towards the left, head jerking, but totally unresponsive. So this is a case of a complex partial status. The corresponding EEG shows continuous high amplitude epileptiform activity, which is predominantly posterior, but spreading to bilateral cerebral hemispheres. So it's important to identify both clinically and EEG wise. And the outcomes of status epilepticus depend mainly on etiology rather than only on the treatment. Traumatic brain injury is associated with both convulsive and non-convulsive status. Metabolic causes are associated with poor outcomes. Stroke is also an important cause of status epilepticus. And there is a study whether the tumoral associated status is worse than the non-tumoral associated, but the answer is no. Both are associated with similar to those who do not have any tumoral lesions, and also the long-term mortality and morbidity is similar to that of the other patients with status epilepticus, even in patients with tumoral lesions. So the clinical consequences of status epilepticus is based mainly on the etiology of status, duration of the status, whether there is an acute brain insult, associated systemic disorders. But however, the 30-day mortality after a convulsive status is 20%. It is suggesting that we need to be very careful. And the management is based on the pathophysiology, because in status epilepticus, though initially there is the GABA becomes excitatory after some time. That is the problem of status epilepticus. And also there is increase in the NMDA receptor density, both causing high epileptiform discharges because of the activation of the NMDA by the increased intracellular calcium. So what causes the RSE, SRSE over the time is increased ineffectiveness of GABAergic drugs happens. So even the benzodiazepines, barbiturates do not help, and GABA becomes excitatory, increase in the glutamatergic receptors, mitochondrial failure, and opening of the blood-brain barrier leading to inflammation. That's why the stages of status epilepticus are divided into, if somebody attends the patient within 2 minutes, the mortality is less than 1%. And most of the time, within half an hour, if you attend, the mortality is up to 20%, suggesting that within half an hour, one should identify and treat most of the patients as far as possible. And if status goes beyond 2 hours, the mortality is 40%. If it goes beyond 2 days, the mortality is said to be very high, nearly 60%. Hence, the management includes hit early and hit hard. Most important being giving the optimum doses of anti-epileptic drugs to terminate the seizures, establishing and treat the etiology, prevent the recurrence of seizures as well as complications. If you look at the status epilepticus algorithm management, the first line drug of can be lorazepam, diazepam, clonazepam, or even midazolam, most of the times what we use in our settings. After that, the first line anti-epileptic drug can be either phenytoin, sodium valproate, levetiracetam, lacosamide. Now we have even brivaracetam in our use. If this fails, one can go for propofol or midazolam or thiopental or even pentobarbital. So these are classified as first and second line anti-epileptic drugs. Regarding the IV anti-seizure drugs in status epilepticus, one can use phenytoin or phenobarbital or sodium valproate, but most important is use the drug according to the body weight with a maximum possible dose per kg body weight, so that you are hitting well the epileptiform activity. With phenobarbital and phenytoin, one should be careful for respiratory depression and arrhythmias, whereas valproate is safe. But however, most of the ICUs, all of us use levetiracetam because it is very rapidly given and you can just inject in no time. The dose should be always optimum 40 to 60 milligrams per kg, the first dose. And even lacosamide is another important drug. The dose is 200 to 400 milligrams stat IV, followed by 200 milligrams twice a day. The other drugs are brivaracetam, perampanel, which are also useful nowadays, especially in focal status epilepticus. But however, in most of the trials, it has been shown very clearly if a person does not respond to one first line and one second line AED, there is no point in pumping more and more number of anti-seizure drugs, and one should directly go to anesthetic drugs. The anesthetic drugs which are being used are thiopental, midazolam, propofol, and ketamine. Most of the times, midazolam is the first line drug in most of the cases compared to thiopental. The doses are given here, and I will not go into the details. I will talk mainly about midazolam and ketamine, which you use in practice. Midazolam, one of the problems of midazolam is hypotension, and it can cause metabolic acidosis. But however, we go up to even 25 milligrams per hour. That is, the dose is around up to 2 milligrams per kg per hour in most of the patients. Thiopental, the problem is it is immunosuppression if you have used for more than 1 week, and it can cause bone marrow suppression and propensity for nosocomial infection. The patient becomes more susceptible, along with hypotension, cardiac arrhythmias in up to 20% of the cases. Propofol is also another drug, but it should be avoided in children because it can cause severe metabolic acidosis. And also the propofol infusion syndrome secondary to profound hypotension, hyperlipidemia, and metabolic acidosis should be kept in mind. Whenever we use these anesthetic drugs, the patient needs to be intubated. Hypotension is common with these drugs. These drugs can cause severe ileus with pseudo obstruction and also renal failure and sometimes life-threatening complications. But however, it has been shown very well in most of the trials that safest drug is midazolam because its efficacy is about 78%. And after using midazolam, the mortality is less than 2% when compared to 19% with thiopental and 8% with propofol, suggesting that midazolam is the most effective and least side effect profile compared to the other anesthetic drugs. It's very important to know about ketamine, which is an NMDA antagonist, which controls both the clinical as well as electrographic seizures. Combining ketamine with midazolam is very good because ketamine raises the BP, whereas midazolam causes hypotension. Both together work in a good synergistic combination with different mechanisms of action. But however, ketamine can cause rise in the intracranial pressure. Especially it should be avoided in patients who have raised ICT and also in traumatic brain injuries. The next one is the role of immunomodulation. Most of the time, if there is no evidence of infection, we go for methylprednisolone in the initial stages within 1 or 2 days if seizures are not controlled, followed by IVIG. And based on the etiology, if it is autoimmune association, then only the plasma exchange is tried. Non-pharmacological treatments like ketogenic diet is useful in children with status epilepticus. We have done few cases with status going for resective surgery during the status. Hypothermia is also useful, and VNS is one of the options in patients who have super refractory status epilepticus. And continuous EEG monitoring is very important during the management of continuous status, which identifies non-convulsive as seizures as well as in convulsive, how long in between the seizures if there is non-convulsive status epilepticus. One should be careful in the management of complications of status epilepticus, especially hypothermia, hypotension, hypoglycemia. Rhabdomyolysis leading to renal failure is not uncommon. Pulmonary edema, even on patients who are on ventilators due to status epilepticus, and cerebral edema because of the central nervous system effects. And one should monitor when do we really take off them from medication. Anesthesia is usually used for weeks to months. We have patients who stayed even for 3 months or more on continuous infusions. So one should titrate the medication to reach a burst suppression pattern on the EEG and slowly wean off once the patient is seizure-free as well as EEG doesn't show anything for at least 24 hours. If seizures recur, again repeat the process, and longer duration of status epilepticus is associated with higher mortality in addition to underlying etiology. So to conclude, the underlying etiology of status epilepticus is the major determinant of mortality in addition to prolonged status epilepticus, that is SRSE. Lack of aggressive treatment contributes substantially to mortality, especially in patients who have refractory status epilepticus. Thank you.
Thank you, Dr. Sita. Are there any questions from the audience? There are none in the chat box. Okay, I would like to ask you two totally separate things. One is I have a head injury with a fairly benign scan. He came say 7/15. I ventilated him, ICP was normal, I took out the ICP. Patient not waking up. Patient staying, M3, M4 in that region. Should I do an EEG?
If the patient is conscious, if the GCS is good, not required, sir, but here the GCS is 4. So definitely we should do an EEG to rule out a non-convulsive status with a GCS of 7.
I should do.
Yes.
Okay. The other question in a post-op patient. Okay, patient was fine. And I get a call at 11 p.m. from today's post-op patient saying, patient has drop score. So first reaction is do CT scan. CT scan, no hematoma. What is my diagnosis there?
So if we ruled out agreed. If you have ruled out a metabolic associated as well as other post-operative complications, definitely one should rule out non-convulsive seizures. Sometimes they can be intermittent. The drop of the score and again the sensorium improves and again drops. So unless we have continuous EEG for a period of more than 1 hour, one may not be able to identify it.
So, I mean, but at that point in the night, 11 p.m., I'm not going to get EEG. What do I do?
Then, yeah, if you are suspecting, you should load him with levetiracetam, which doesn't harm the patient. Most of the times, they are loaded even prophylactically.
Thank you.
Can I ask one question?
Yes, Manas.
Yeah. Is non-convulsive status a clinical diagnosis, or it has to be supported with electrophysiology?
The criteria for diagnosis is clinical as well as EEG abnormality. Along with clinically, you should be seeing something in addition to unconsciousness, like subtle twitching. Along with EEG should be abnormal, and when you give the EEG should become normal after giving the intravenous midazolam.
Okay, but if the EEG is normal and clinical suspicion is high, do you diagnose? Means that is excluded. Diagnosis is excluded.
No, EEG is a must to diagnose non-convulsive status. It's a clinical and EEG diagnosis.
It's not like normal epilepsy.
No.
Okay.
There is one question in the chat box. What is the?
That's okay. I was just checking whether the questions are getting posted or not.
Drug of.
I only asked. But super refractory.
Fine.
Yeah, the definition of super refractory status is already patient has failed the first and second line anti-epileptic drugs. So the patient has to be given intravenous anesthetic drugs, that is midazolam along with ketamine. That should be, we start that within 24 hours. So that by adding ketamine, you prevent going for a longer duration of status epilepticus, decrease in the morbidity and mortality.
Sure. Okay, thank you.
Ma'am, one question, like we all are giving levetiracetam only, but there's too much of buzz around levetiracetam. So what do you say? Like, should we use that or we continue with levetiracetam?
Once 2 anti-epileptic drugs fail, it can be phenytoin with even levetiracetam. We should go to IV anesthetic drugs. We should not be wasting time in intubate the patient, put him on midazolam infusion. That is better rather than trying multiple AEDs, one way, another, waiting for the response. But outcomes are better with that.
Okay, thank you, ma'am.
Thank you.
Yeah, so the next we have is another specific situation, that is vasospasm. And we have Professor Shalini Nair, and she is heading the critical care ICU at the Christian Medical College, Vellore, and she had done her fellowship in critical care medicine as well as in neurotrauma and critical care. And we have here Professor Shalini Nair, who will be talking to us about management of vasospasm in ICU, neuro ICU. Over to you, ma'am.
Good afternoon, all. Vasospasm is one problem which every neurointensivist has to deal with on almost a routine basis. We all agree upon the fact that securing an aneurysm is just beginning of the treatment. And we are far from done until we have tired over the likely period of vasospasm. My talk is going to revolve around which patient group to concentrate upon, how to prevent vasospasm, and once it is set in, how to treat it. About 20% of aneurysmal subarachnoid patients go on to develop symptomatic vasospasm. And It is of utmost importance, hence, to know which group should be concentrated upon to predict this complication. Radiologically, the modified Fisher grade helps to a great deal. And a very basic and easy to do bedside Doppler test is a transient hyperischemic response. From the onset of ictus itself, just a transient compression of the carotid vessel in the neck and looking for a hyper-responsive flow in the MCA tells you about the adequacy of cerebral autoregulation. And if the autoregulation is intact, the likely chance that you're going to develop a delayed complication like vasospasm is much less. Also, it is possible to evolve the vasospasm by a bedside tool like Doppler with its changing flow patterns and velocity. Like we heard in the previous talk, EEG is becoming an essential tool in ICU. And if you have a quantified continuous EEG bedside, appearance of these spreading depolarization help to predict vasospasm much ahead of the symptomatic manifestation. There has been a paradigm shift from treating the delayed complications to interfering with the pathophysiology to prevent early brain damage right from the time of ictus. And mostly it is done by trying to control or prevent raised ICP, making sure that there is adequate oxygenation and perfusion of the brain, and by reducing neuroinflammation. Of these, much attention has been paid to reducing the neuroinflammation, but many agents and many trials later, we still do not have a magic bullet for this. On the other hand, there is much progress to bedside monitoring tools, which are becoming more and more user-friendly and give you a real-time monitoring of the changing milieu of the brain. From very localized biochemical changes with microdialysis, cortical electrical activity, to a changing cerebral flow dynamics using a perfusion scan. Now, all these help you to detect the brain damage very early, at the earliest stage. To emphasize on the importance of detecting these changes at the earliest, this was a 64-year-old lady with a giant MCA aneurysm who was clipped. A few hours after the procedure, she woke up to a GCS of 14/15. Around 6 hours later, she gradually started to get more and more obtunded. A CT scan was done, and it showed features of raised ICP from an evolving edema. She underwent a decompressive craniectomy and was discharged without any deficit at all. Now, once the patient comes into the ICU, how intense should the monitoring be? One of my colleagues from Toronto, Manuel, came up with this color-coded, simple vasograde triaging system based upon the WFNS category that the patient falls into at presentation. So in the green zone are the patients who are low-grade subarachnoid hemorrhages. They are probably good to do and need just an overnight ICU stay to rule out any complications. And before they are sent to ward, transcranial Doppler. And thereafter, this Doppler may be repeated if they are symptomatic. In the intermediate zone are the people who require more intense monitoring. We need to stay back in the ICU for 2 to 3 days, requiring more intense monitoring of the fluid status and at least twice a day Doppler, and a very low threshold to take up for a DSA and related procedures if we see something suggestive of vasospasm. In the red zone are the poor grade subarachnoids who may need to stay back in the ICU for almost a fortnight to 3 weeks. And once they are being treated in the ICU, for every individual patient, there should be a protocolized approach. And that has to be titrated from patient to patient. We have come a very long way from HHH, and now we try to optimize the fluids to attain a euvolemic status rather than hypovolemia, or more precisely, to prevent a hypovolemia. The major change in outcome of these patients have come from how safe it has become about what we do in the ICU. There are a lot of bedside maneuvers which can be taken up to see that the fluid management is adequate. But most promising of them is a bedside ultrasound. And on ultrasound, if you see appearance of these lung rockets, it is suggestive that the lung is starting to get fluid overloaded and it is time to cap this rigorous or overzealous food administration. Maintaining a proper electrolyte balance is very essential. Now, these sodium is the most important. More than 50% of subarachnoid patients develop hyponatremia. And the usual target that we would want is around 140 milliequivalents per liter. So to make sure that the sodium is normal, we will do a urine spot sodium and rule out the depletional status. And once we know that there is a high urine spot sodium and there is diuresis associated with hyponatremia, it is wiser to consider cerebral salt wasting upfront and treat with fludrocortisone and continue with hydration rather than considering SIADH and curtailing fluids. Magnesium was thought to play a very important role in pathophysiology of subarachnoid, but after the MASH trial, its importance has slightly waned now. Nevertheless, it is very important that we do not let hypomagnesemia set in. So detecting vasospasm is much simpler if you have a low-grade vasospasm, where a low-grade subarachnoid hemorrhage, where a proper neurological exam is possible. So probably a subtle change in sensorium for an ACA vasospasm or a pronated drift would let you know that, yeah, there is a vasospasm setting in. The challenge lies in the high-grade subarachnoids who are more obtunded. Bedside Doppler is probably the tool that can help you. And there are well-established criteria to diagnose vasospasm and differentiate it from hyperemia. The sensitivity is best for the proximal MCA and starts waning as you're dealing with ACA and is the least for basilar and vertebral arteries. A point to remember always is when you're doing Doppler, especially after a patient has undergone a surgical clipping, you should look for vessels on both sides because the involvement of contralateral blood vessels is as common after the surgical treatment. Now, once the vasospasm has set in, the most common therapeutic measure that we would undertake is augmenting the blood pressure. And that's done usually with inotropes, though literature also recommends use of phenylephrine. If we are using an inodilator, it would be Milrinone. The two most important questions to answer in this respect is how high should you go and how low. Again, low-grade subarachnoids, neurological exam would help you and keep targeting the map higher and higher as long as your neurological deficit has reversed. But again, for high-grade subarachnoids with low GCS, what do? Most often, the targets are limited by appearance of cardiac complications. Now that bar has been raised and there are several instances of use of left ventricular assist device to tackle the cardiac complication transiently and continue with augmentation and making sure that the cerebral hemodynamics are maintained. So in these instances, again, multimodal targets would help you establish the target map. How do you titrate this medical management? Again, it would be multimodal monitoring that would help you. In this instance, a continuous EEG with use of composite alpha index as a parameter has been used to titrate Milrinone dose. The first instance, when the Milrinone has been tapered down, there is not much difference made to the alpha index. But with this second step down, the index has started dropping, suggesting that this new map target is probably not sufficient enough and it has to be reverted back. And as the doses are increased, there's again improvement in the index. So this helps in real-time titration of the map target and the medical management. Now, how does one know that you have hit the ceiling for medical management? Again, bedside Dopplers would help. And increasing flows and higher Lindegard ratios would suggest that probably it's time to go for an interventional therapy, most likely an intraarterial hemodipin or balloon angioplasty. So this was an instance of a left PCOM artery aneurysm which was clipped. And 3 days into the procedure, the patient developed a right pronated drift. Was taken up for the transcranial Doppler was also suggestive of vasospasm. Was taken up for a DSA, intraarterial hemodipin was administered, and the deficit recovered. So this was the pattern of flow on the first day when the intervention was taken up. On daily monitoring, 2 days into the intervention, the flows were much higher than the previous one. And this time when we took up for DSA, the vasospasm was much more severe. This just goes on to highlight how important it is to keep monitoring daily, especially in that window period when vasospasm is likely. So this is another bedside tool used for real-time monitoring. Here an encephalogram has been used and alpha-delta ratio is being monitored. So as the ratio is trending downwards, the patient is taken up for DSA. Intraarterial nimodipine has been injected. The ratios have reverted back. But then again, they start trending downwards. And the second DSA that is attempted shows bilateral involvement of ACA. And this time, not only is intraarterial nimodipine injected, but there is a catheter put in situ for continuous verapamil infusion. With that measure, the ratios have come up again and remain on the higher trend. So this goes to tell all the interventions have been done at subclinical level before manifestation of any deficit. And this goes a long way in determining the final outcome. So this is the algorithm we follow in our ICU. Once a patient with an aneurysmal subarachnoid hemorrhage comes into the ICU, in addition to early securing of the aneurysm, we would want to optimize the ICP by dealing with the hydrocephalus if it is there. And if there is an EBD inserted, it can always be titrated to monitor the ICP as well. One of the very important factors is concentrating on pain to optimize the ICP. To the extent that one of the latest editions of neurocritical care advocates a pterygopalatine fossa blocks to deal with pain in subarachnoid hemorrhage to optimize ICP. TCD should continuously be monitored and make sure that the other parameters like the electrolytes are kept optimal. And with the daily monitoring, if you encounter vasospasm, if it is mild, you go ahead with continuing optimizing the fluids and electrolytes. But if it is moderate or severe or symptomatic, then we move on to augmenting the blood pressure. With the augmentation of blood pressure, if there's no clinical improvement, move on to a radiological intervention. So summarizing, not much has changed over the decades as far as the treatment of vasospasm goes. But what has made a real change is the intensity of daily bedside monitoring that is available to us, which has made detecting early brain injury possible and probably reducing the pathophysiological changes that can come up with it, and real-time monitoring of evolution of vasospasm. And all these put together have made all the measures that we undertake more and more safer for our patients. So how would the future look like? With all these monitorings possible for us, the prevention and treatment of vasospasm will become more objective and more safer for our patients. Gadgets and monitors aside, what has already been proven is almost a 24% reduction in mortality for every 100 patients of subarachnoid hemorrhage admitted in high volume centers, provided that there is a team approach, and the team consisting of neurosurgeons, interventional radiologists, and the neurointensivists. The final outcome is determined by how good the team is. Thank you.
Thank you, Shalini. Any questions?
Yeah, Dr. Markland had posted a question too.
Sorry, yeah, Shalini, can you open the chat box?
Yes, yes, I've seen. Dr. Markland, yes, CT perfusion does play a very important role, especially when there is involvement of smaller blood vessels. So only the proximal vessels are what we can be monitoring with transcranial Doppler. And then as it becomes involvement of more distal, CT perfusion does have a very important role. And by far, it would be up to the intensivist to know or reckon the need for perfusion scans at the earliest.
Okay, so when I was a PG, the treatment of vasospasm was triple H. How many H's have survived?
Just one, sir. Only hypertension is what we deal with right now.
Any other questions? Suchanda?
I think we have Dr. Iptikar's talk now. It's, I think by mistake, Dr. Ashima's got uploaded. So we would like to invite Dr. Iftikhar Hussain to start his presentation. Sir, can you upload
Good
your...
afternoon, good afternoon, ma'am. Can you hear me?
Yeah, we can hear you. Okay. Could you share your slide?
Sure, thank you very much.
So let me introduce you, Dr. Iftikhar Hussain. He is from the EANS, like European Association of Neurological Surgeons, and he is a faculty at the Department of Neurosurgery at Turku University Hospital and University of Turku, Finland. And he has his, besides his neurosurgical degree, he also has an additional degree from the Cambridge University from UK on neurocritical care. So over to you, Dr. Iftikhar, for your talk. We all are waiting to hear you.
Good afternoon, everyone. At first, I would like to thank the NSI committee to organize such an educational webinar. And I would like to especially thank you also to give me the opportunity to talk on behalf of the Young Neurosurgical Committee of the Trauma Section. My name is Ifti Hussain. I'm a neurosurgical trainee from Turku University Hospital, Finland, and just also completed my neurocritical care fellowship in Cambridge. I'm going to talk today on the impact of intracranial pressure monitoring and multimodality monitoring. I have nothing to disclose. So as we know that ICP is a complex modality which contains combined information about cerebral compensatory and CBF regulation mechanisms. And we already know that elevated ICP is independently associated with increased risk of death and poor outcome. But ICP monitoring is mainly widely used in the management of patients with TBI. What about the other acute brain injury? And uncertainty remains about ICP monitoring. Do we know how do we use them? Whom do we use them on? And do they actually make a difference? Do we have any class 1 evidence? And what about running more randomized control trial? Is there any ethical issues? For example, here we see in the picture the triple bolt that we use in Cambridge. I will talk about it more in the coming slides. So about the current Brain Trauma Foundation guidelines, the recent version almost downgraded the use of ICP monitoring, though it permits ICP monitoring for the salvageable severe TBI, but the indications, types of monitoring device, and optimal duration of monitoring remains unclear. We have the only RCT best trip trial, as you know, for TBI management based on either ICP monitoring or clinical examination and imaging showed no benefit for ICP monitoring. And most studies of ICP monitoring have focused mainly on patients with TBI, as I mentioned earlier. What about elevated ICP in non-traumatic ABI? And does it correlate with poor outcome? Should we monitor ICP for the patients having hemorrhagic stroke? So do we have any solution for this? Current study done by the European Society of Intensive Care Medicine, Synapse ICU. I'm going to talk a little about it. So the aims of this study was to describe current ICP monitoring practices for patients with ABI at centers around the world, to assess variations in indications for ICP monitoring, and to evaluate treatment intensity in patients with and without ICP monitoring, and finally to investigate the association of ICP monitoring with long-term patient outcomes. About the methodology, it was a quite global study, prospective observational, 146 ICU in 42 countries, and it was an adult TBI study, and the patients having ABI, for example, hemorrhagic stroke and TBI, both were included in this study. And if we have a look about the GCS criteria here, eye-opening of the GCS, so 1 on admission to ICU or neuroworsening with no eye-opening in the first 48 hours were included. About the best motor score of the GCS, admission to ICU less than 6, or neuroworsening with motor score decreased to less than 6 in the first 48 hours was included. What about the endpoint of the outcomes, where 6 months mortality and 6-month Glasgow outcome scale extended, and Glasgow's outcome scale was used for unfavorable and favorable outcome classification, and secondary endpoints was hospital mortality and Gaussian score at discharge from ICU and hospital. If you have a look at the results published in Lancet Neurology in July this year, If we have a look at that, 2,395 patients were included in this study, 53.8% with TBI, 24.5% with ICH, and 21%, 1.7% with SAH. The median age was 55 years. TBI is not anymore a disease of young people, and 56% of all patients were ICP monitored. And if we have a look at here, the important point, 73% of the patients were in Europe, 14% America, 10% Asia, 2% in Africa, and 1% in Oceania. Most of the patients came from the European part, although it covered the other parts of the world. And considerable variability was recorded in the use of ICP monitoring across the centers. 6 months mortality was lower in patients who had ICP monitoring compared to who didn't have. And ICP monitoring was associated with significantly lower 6-month mortality in patients with at least one unreactive pupil and better neurological outcome at 6 months. And if we see about the therapy intensity level, median TIL was higher in patients with ICP monitoring. And this is an important point. In case of low and middle income countries, the 6 months mortality rate of all patients was similar in these two groups and no difference about the outcome. So the strength of this study was that this is a global approach, high variability, different centers, different pathologies, different treatment strategies, and different resources. And one important point come here about the outcome, that we need to develop the global approach and collaboration to develop better neurorehabilitation across the world, importantly lower and middle income countries. And this study could mimic a randomized trial. On the other hand, if we look here, the published study by Prof. Randy Chestnut, the best trip trial, it compared 2 treatment group strategies rather than a proper ICP study. On the other hand, in Synapse ICU, it reflected a real life scenario reflecting different variations. But one thing is important, that in this study also, we did not see any difference between the outcomes in the lower and middle income countries. And as I mentioned earlier, one of the important limitations was that it's observational study, low budget study, and have major confounders. So what have we learned from this study? The use of ICP monitoring and ICP management varies greatly across centers and countries. The use of ICP monitoring is more common in patients with severe acute brain injury with specific pre-injury characteristics and injury-related characteristics. Monitoring of ICP is associated with a more aggressive TIL, and higher TIL in the ICU might have a protective effect on 6 months mortality in more severe cases. We have discussed here about the ICP monitoring the study, sorry for that we used here mainly for invasive approach. For example, we use the triple bolt interparenchymal or transducing from the EVD, but we also have the ICP monitoring strategies which are non-invasive. We know that almost no center is clinically using this non-invasive ICP monitoring for decision making, but it could be suitable for A&D or triage. The promising methods are optic nerve sheath diameter, transcranial Doppler. My previous speaker discussed a lot about it very nicely, MR-ICP and OTIC method. If we have a look at the when it's that is a very nice study where the points about the optic nerve sheath diameter ultrasonography indicated that optic nerve ultrasonography can help to diagnose increased ICP, is suitable for triage, applicability and accessibility, especially ultrasound-based solution, however, unfit for continuous bedside monitoring. What about the transcranial Doppler? This is not a new concept, at first coming around 1982 for SAH, and currently the Cambridge group and other groups from the Italian studies came up with the conclusion that approach combining radial artery BP and cerebral blood flow volume waveform provides promising results. It's low cost, it is risk-free, portability, easy to perform, and repeatability, but it is highly user dependent. Probably the robotic technique could minimize the human error in future. And we know that CBFP could be affected by medications, hyperemia, and a group of patients are not suitable for this. What about the MR-ICP? The imaging method could sound like quite promising one because we can really image the brain, and this is a very good review could have a look and suggesting us as potentially useful as a screening tool for very high ICP, but are currently not reliable on its for own clinical management, not suitable for triage or not for continuous assessment. And we need to remember it's a costly and not available in most settings. Whatever the OTIC method, the tympanic membrane deconvolution method, the utility here is that it depended on a pattern cochlear aqueduct, but to a large degree subject to significant interpatient variability. It does not seem useful for clinical application. And coming about the topic of multimodality neuromonitoring, why do we need to do that? As neurosurgeons, our goal is to prevent secondary insults and maintain cerebral homeostasis. Monitoring is the aid to identify secondary insults in a timely manner, but we need to remember that we are just not chasing more numbers or simply inserting more fancy devices. The main goal is to seek targetable pathophysiologies. So what are the strategies we have? We'll have a look in coming slides. The ICP monitoring, we discussed already, cerebral oxygenation, cerebral autoregulation, cerebral blood flow, microdialysis, and the EEG monitoring. About the brain tissue PbTO2 monitoring, the BOOST T3 trial upcoming interesting results, and this is the CBIC algorithm, what would be later discussed with Prof. Mark Lund in his slides. But in summary, it's a gold standard for bedside cerebral oxygenation monitoring, focal continuous monitor of critically perfused tissue, low complication rate. It's invasive, utility depend on probe location, but we should remember without multimodal monitoring, cerebral hypoxemia could have been missed, which is strongly correlated with poor outcome. And regarding other methods for oxygenation, jugular venous oximetry and near infrared spectroscopy, but in case of jugular venous oximetry, we know that it has a high risk of hematoma and other complications. Regarding near infrared spectroscopy, quite promising one, but still ischemic thresholds are not defined and not recommended for routine clinical use. What about the cerebral autoregulation? The important points, recently the Cambridge group has reported the brain physics lab using the PRX to define the CPP opt, the optimal level, because we know above that it could be hyperemia stage and below that could be the ischemic changes. So identification of optimal CPP range is important, and interpretation of relationships between CBF, oxygen delivery and or demand, and cerebral metabolism is vital step. And it requires high frequency signal processing, and still we have insufficient data to support recommendation for routine clinical use. What about cerebral blood flow? We talked earlier about TCD. Another method could be thermal diffusion flowmetry. It could have the continuous measurement of absolute regional CBF, but concerns about reliability and limited clinical data. About cerebral microdialysis, it was reported a very nice methodological study in 2000 by Prof. Hutchinson, and this is coming in the recent studies there, which are giving important information. But why cerebral microdialysis? We know that following a severe traumatic brain injury, there are macrovascular and microvascular ischemia, which could initiate the mitochondrial dysfunction. And from here, we could measure the energy failure by lactate pyruvate ratio and by brain glucose measurement. So important thing is measurement of brain biochemistry, early detection of hypoxia or ischemia, monitor of ischemic and non-ischemic causes of cellular bioenergic distress, but still focal measure and thresholds for intervention, we don't know. About the EEG monitoring was nicely described by a previous colleague, and we know that there are two types, the scalp EEG and invasive EEG. Nowadays, we are continuously monitoring the EEG for the TBI patients who are vulnerable to have seizures. It's non-invasive, correlates with ischemic and metabolic changes. Assessment of seizure is possible, but it still cannot identify cortical spreading depolarization. We could have invasive EEG, putting a subdural electrodes, but overcomes drawback could be, but it is invasive and still it's expensive. So what about the normal range and treatment thresholds of all this? This is an important paper to read from the Cambridge group about the critical care management of TBI. And here we can see the threshold, but we need to remember that all of these things are coming from our observational studies about the intracranial pressure levels, PbTO2 level, lactate pyruvate ratio, and brain tissue glucose for the therapeutic approach for the management of TBI. To conclude, the multimodality monitoring, specifically the brain tissue oxygenation, PRX, and the microdialysis are a promising group of techniques for understanding the complex neurophysiology following TBI. We need to remember that in isolation, no monitoring tool is likely to change outcome. But when used as a part of a goal-directed therapeutic strategy, it could hypothetically influence outcome. And as before, Prof. Joseph mentioned that besides the critical care practitioners with the neurosurgical trainees and the neurosurgeons, we need to understand that these tools should be used in an integrated fashion, combining multimodality monitoring data with the clinical examination, systemic monitoring, neuroimaging, and additional specialized monitoring tools, for example, TCD, EEG, or upcoming the blood and CSF biomarkers. We need adequate RCD data to optimally guide the use of monitoring and enable informed, individualized, personalized medicine. And at the end of the day, we need to remember that our clinical skill is most important. And we should not forget that bedside nurse is the best continuous monitoring because she or he probably seeing the patient for more than 24 hours and observing the trend of changing of all these parameters. And finally, thank you everyone to listen to me. I'd be happy and will try to respond to your questions. Thank you very much.
Thank you, Dr. Iftikhar, for introducing us to the complexities of what's available and how little we still know how to use the modalities available to us. Are there any questions?
There's one question in the chat box here. First.
Yeah. Iftikhar, can you open the chat box or shall I read it out to you?
Yes, Prof.
Yeah. So Markland has asked, is there any use of microdialysis in your opinion to treat patients based on microdialysis level?
I think in my opinion, I believe, or I would like to believe that it's not only on the basis of microdialysis. We could have microdialysis as an adjunct to come to know that if there is any metabolic failure or energy crisis in the brain, but it should be the component of the whole circle, not only on microdialysis, but it could be an adjunct which could be useful to make a precise decision.
Professor Markland, you want to comment anything on microdialysis?
Yeah, sure. Thank you. Thank you. You did a great talk. We use clinically some microdialysis in subarachnoid hemorrhage really for clinical decision making. In TBI, we're getting there, maybe to treat the glucose levels. If it becomes critically low, we adjust the blood glucose levels. So that's probably the clinical use we have at this point. But I think we're aiming towards actually implementing it in clinical decision making more and more in our local guidelines. So was just curious to hear your experience on this.
Thank you, Prof.
There are no other questions. Yeah, sorry, I can't see who that is.
No other questions. You can close the session so that we can.
Yes. Okay. So thank you to all four speakers. That was an enjoyable and informative session. Suchanda, would you take over now?
Yeah. Thank you, sir. And I pass over this one to Professor Manas, sir, and he will take charge of the next session, the last session.
The last session, we have 4 interesting talks, and Professor Lokendra Singh will be chairing and asking the questions. I'll be introducing the speakers. And so the first talk is on by Professor Ashima Sharma, and she is a professor in Department of Emergency Medicine at Nizam's Hospital, Hyderabad. And she'll be speaking on how to resuscitate cardiac arrest in a neurosurgical ICU. And she is also faculty of ACLS and ATLS of ACLS courses at many places.
Thank you, sir. I hope I'm audible.
Yes, yes.
Yeah, thank you. Thank you so much. So the entire crux of the talk would be to make sure that at the time of an sudden cardiac arrest in a neurosurgical ICU, the efforts which are always seen to be more chaotic in any place for that reason, and diminishing as the time passes by within minutes of a cardiac arrest, become more protocolized. And hence I am here to speak on the protocols of CPR in neurosurgical ICU. Yes. The patients in neurosurgical ICU may not be showing the classical Levin's sign with the hand over the heart, but the protocols are universal. Wherever arrest happens, the American Heart Society and the European Heart Society of Cardiology have given us wonderful protocols which can be interventions which can be started as early as possible and would help in saving the life of the patients. The uniform applications of these universal protocols, and along with the concept of chain of survival, will decrease the incidence of mortality by 7 to 10% with each minute passing by after the cardiac arrest has happened. The first and foremost important is to prevent a cardiac arrest and recognize it early if it happens. Activation of emergency code, which is known as code blue in most of the hospitals, has to be done next. We have to begin CPR immediately, and we should not wait. The first person who identifies, most of the time it is a nurse which is present in the neurosurgical ICU, or should identify and should not wait for code team, and should begin CPR immediately. Use of defibrillators as soon as possible, one has to be found out. The continuum of care after achieving pulse and post-ROS care is very important. Recovery from cardiac arrest takes a long time, so ensuring rehabilitation right at the start is important. In our ICU, which I look after, a neurotrauma ICU, I would say, in my present place of work, I have seen that most of the neurosurgical cases which happen a cardiac arrest, which happen to have a sudden cardiac arrest, hypoxemia due to any cause, various causes can be the reason. So at that point of time, ensuring that if the patient is having an issue with the ventilator, to correct that and make sure that the highest feasible oxygen delivery, which is possible at that time, should be given to the patient. Other causes are like thrombosis, hypovolemia, especially hypovolemia in spinal surgeries. If most of the time the bleeding is occult into the retroperitoneum, we all know that there can be iliac arteries which could be sheared and somewhere where it is passing in front of the L4 vertebra. Well, these all are the causes which one has to look for at that time. We would be concising these topics under 4H and 4Ts in later part of my talk. Recognition of cardiac arrest is very important, as till we don't recognize, we would not be able to manage. What are the points? Before a cardiac arrest happens, the patient always gives you some premonitory symptoms, and that is when it is always better to catch that this was the patient who has a potential patient for cardiac arrest. He may throw convulsions, or there can be non-convulsive status epilepticus. There can be arrhythmia seen on the monitor. The blood pressures can be very low. There could have been an episode of sudden vomiting, or there can be a sudden hemorrhage in the wound side. At that point of time, if one is active and looks for, he may find cold peripheries, dilated pupils, or sometimes it is one side pupil which is dilated in the start of deterioration of the patient. The heart sounds can be absent or very feeble, but it is the carotid pulse which have to be seen. And if the carotid pulse is absent, it is a short sign that the patient is into cardiac arrest. The unconscious, a patient at that time can also be unconscious or suddenly unresponsive. The BP may be non-recordable. There will be absent ECG waveforms on the monitor, and there will be no spontaneous breathing, or the patient may be gasping. Well, I would like to bring to you two slides. One slide will have non-shockable rhythms, the other slide will have shockable rhythms. So this is very important when we are contemplating to revive a cardiac arrest patient. So as we can see in the ECG on the top, the line, the isoelectric line of ECG is almost flat. And this is something, this is what is called as asystole, which is a non-shockable rhythm. Well, down you can always see, you can see that the beautiful sinus rhythm complexes are coming. Every P wave is followed by a QRS complex. But when at the same time there is no carotid pulse, well, this is what is pulseless electrical activity, and it is also a non-shockable rhythm. In this slide, I have tried to put on 3 ECG strips, which is of shockable rhythms. The first shockable rhythm is a very fine ventricular fibrillation, which is something like a asystole, but it is not a straight line. There are still some bumps in the line, and if we can put gain on the monitor, that is increase the size of our QRS complexes, we would see this fine VF happening. A fine VF, if confused with asystole, may deter the application of defibrillation, and which will not be good for the patient. Hence, it should be always taken care of to be recognized early. The coarse VF is seen on the second ECG strip, and the ventricular tachycardia, which would be pulseless. What it means that there will be no carotid pulse. These are the shockable rhythms seen. Before I take you to the algorithm of cardiopulmonary resuscitation, I just want to bring to your notice that how to position your hands during chest compressions. So it's a beautiful infographic which is seen over here. Please make sure that you identify the middle of the sternum, where in between the nipples in men, or you can say the below the nipple, below the breast tissue in females, or in some places it is said 2 fingers above the xiphoesternum. Well, it all accounts for the same place. Please put your first hand, your left hand over the sternum, and then interlock above with your right hand in case you are a right-handed person. There should be absolutely no movement at the elbow. Elbows should be straight during chest compressions, so as to make sure that the pressure goes directly, is transmitted inside to the heart. The other photograph over here is about the application of defibrillator pads, which is BMJ has done a study on it, and has reported that most of the time, even this basic application of pads is at fault in various CPR sequences, and that is why the return of spontaneous circulation has been affected. So the right side pad is below the clavicle, and the left is in somewhere near the apex of the heart, or we can also say in the left lower ribs, in the mid anterior or the mid axillary line. Either way, it is better because it will pass through the electric current would pass through the axis of the heart. Starting with the CPR sequence, the moment a patient is identified to have a sudden cardiac arrest, the best part is first thing should be call for help. It is always a teamwork. Please call for help. Please make sure that you have people who could help you out. At the same time, if the patient is intubated, please increase the FiO2 of your ventilator or to 100%. If not, if he is not intubated, the CPR sequence itself means that there will be 30 chest compressions followed by 2 breaths to be given with the help of AMBU. So there has to be initially 2 people at least to take care of it. If there is 1 person in hospital arrest, there will be definitely at least 2 people, because nurses will be there to help the doctor present in the ICU, or vice versa. So the other person available should immediately get the defibrillator, which would be present in the ICU, and attach the monitor and the defibrillator. At the same time, once it is attached, it is important to understand whether the rhythm is shockable or not shockable. I've already shared the ECGs with you on that. Shockable rhythms require an early defibrillation. It requires a shock immediately. The shock can be 120 to 200 joules. It is biphasic. Thankfully, most of the defibrillators present now, manufactured now, are all biphasic defibrillators, so we need not worry about it. Make sure that if you give after first shock, whenever you give the next shock, it should at least be of the same joules as the first shock, or it can be increasing in joules. So the dose available is between 120 to 200. And we have to give an early defibrillation in case of a shockable rhythm. On the other hand, if it was a asystole or a PEA, then early epinephrine. Now, this is one change from the previous guidelines that at the start, first, before even initiation of CPR, chest compressions are being done with by your colleague. The early epinephrine in asystole has proven to save a lot of patients from malignant rhythms like asystole and pulseless electrical activity. Going back to the ventricular fibrillation or shockable rhythms pathway, I would say that what happens is most of the times once a patient is shocked, the doctor would like to now check whether the heart has come back, or immediately after application of shock. That is not a correct practice. The correct practice is to immediately start back the cardiac compressions for 2 minutes. For 2 minutes, you have, after giving shock, you have to do chest compressions, and then we have to check for the next pulse rhythm. So why I'm not saying pulse check over here is because the patient is in ICU and we have rhythm coming on the defib monitor. If the rhythm is still shockable, then we give a shock, and at the same time we give one epinephrine dose. 1 milligram of 1 in 1000 is given. It is always diluted in 10 ml, and whole 10 ml has to be given in an adult patient. Whole 10 ml has to be given. The dose is 1 milligram. I would repeat, 1 milligram in 1000, 1:1000 dilution. The next part slide says that if the rhythm up, again we restart the CPR for 2 minutes, and again if the rhythm is shockable, then the third shock is being given, and the third shock is followed by drugs which like amiodarone or lidocaine. So here the amiodarone is given as, first dose of amiodarone is given as 300 milligrams, or lidocaine if it is available. Lidocaine should be Xylocard, or I would say cardiac lidocaine, which does not have the preservative, not the one which is used for spinal anesthetic or epidural anesthetic. So here the dose is 1 to 1.5 milligram per kg. And at the same time, the team should start thinking of what are the reversible causes which can be reversed at this time to bring the patient back. So going back into, going back into the algorithm of a shockable rhythm is early defibrillation is important. Use of epinephrine after every even shock is important. So it is so easy to remember that E starts with even, and E stands for epinephrine. So after every even number of shock, please use epinephrine, and after every odd number of shock, use amiodarone. Now, amiodarone has an O, whereas odd has an O to start with. So that is how it is. It can be easily remembered. The other thing is that amiodarone can be only given for 2 doses. So the first dose will be given after the third shock, and the second dose, which is 150 milligram, will be given after the 5th shock. At the same time, on the algorithm of non-shockable rhythms, which is asystole and pulseless electrical activity, epinephrine was given right at the start. CPR was continued. Chest compressions were continued. 30:2. Now here, if the patient is on ventilator, there is no concept of 30:2 because the advanced airway is already in, and hence a continuous chest compressions have to be done, and ventilator can be put on 10 breaths per minute to deliver at least 500 mils of tidal volume at the rate of 10 breaths per minute at highest possible feasible oxygen, that is FiO2 of 1. Every 3 to 5 minutes, epinephrine 1 milligram, 1 into 1000, as I have already told, has to be given. And after 2 minutes of chest compression, rhythm is checked. Where if it still remains non-shockable, the same algorithm is continued. If this rhythm changes to a shockable rhythm, we start defibrillating our patient. Okay. So this is how code is run. And there are few things which are very important while you run a code. That is a high quality CPR. High quality CPR means that at least more than 80% of the time while code was running, chest compressions were being performed. That means that if there were 2 minutes, the patient could come back within 2 minutes, 5 cycles of 30:2, or 2 minutes of continuous chest compressions with ventilator taking care of the breathing part. 80% of time was spent in chest compression, which is called as chest compression fraction. How many compressions rates to be given? Well, 100 to 120 compressions per minute have been advised. Chest compression depth is about 5 centimeter in adults, or we can also say 1/3 of anterior posterior dimension if it is children and infants. I've purposefully tried to put my algorithm of adult CPR only over here, though I will be able to answer in case there is a question on it. Chest recoil is very important because that would be the time when the heart will get filled up with the blood coming back from peripheries. So please make sure you don't lean on the chest and give appropriate, adequate time for chest recoil. The ventilation I have already told you. This looks like a very fascinating for us, but the pit crew method. But what is most fascinating is this triangle of life. The triangle of life is when a patient, a victim of cardiac arrest, is surrounded by 3 very important people. The compressor in position 1 on the right side of him. The position 2 is taken by the person who takes care of defibrillator and the monitor, or AED in case of out of hospital cardiac arrest. And the position 3 is by the person who gives oxygen to the patient. That most of the times they are anesthesiologists like me who would be on the head end of the patient. There are other positions, the position of a team leader who would be assigning the roles to team members, making the treatment decisions, and also taking the feedback from everyone who are performing. It is very important to have a code recorder at this time, so that in full during the entire code which is running, what interventions were given, whether they were given on the right time, at least at the end of the code, whatever the outcome may be, it is very important to discuss them out so that next time it is much better and more disciplined and protocolized than the last time. If there is an availability, it is also important to have an IV, IO, or meds, a person who will help in all this in these parts. Very important is that the chest compressor can be tired within, most of the times get tired within.
Ashima, can you?
Yes, sir, this is the last slide. Sorry. Okay, sir. So it gets tired. So please make sure that he rotates clockwise with the person who is on position 2. Post-ROSC it is important. Just, sir, can I have 2 minutes, sir? I will just tell post-ROSC. I'm sorry.
It's better you run through the slides so that it is recorded.
Okay. Yes, sir.
Go run through the slides in the conclusion.
The ABC approach. Thank you, sir. The ABC approach of post-ROSC is very important, and targeted temperature control is very important. The 5H and 5Ts are to be thought of, as we were discussing at the time of algorithm. It is not very easy to, it requires a lot of intensive work to make sure that induced hypothermia is there. Well, how much it has, the TTM trial is out, the results are out, trial 2. How much it helps, we have yet to see. I would say that running a dexmedetomidine infusion at the end of it, if the patient is not responding still, and making sure that the temperatures are at least kept less than 36 degrees centigrade would help the patients. prognostication of patients, post-arrest investigations. Most important here would be to do a focus to see what was, rule out at least the cardiac cause. Every neurocritical care physician should know how to do a focus. And this is most common questions which is asked to all those who resuscitate patients, that how long we should keep on doing a code. So I would say that if this poor outcome is likely if at least two of these are there, that is no pupillary and cornea reflexive, that's more than 72 hours. Well, this is 72 hours prognostication, but even at the end, if the motor is less than equal to 3 and the neurospecific enolases are high, either at 48 hours or 72 hours, and there is CT or MRI where ADC coefficient values are high and gray-white matter differentiation is lost, yes, the code book should be, the neuroprognostication is not good. I wish you all happy resuscitation to all your patients, and I'm sorry to exceed the time. Maybe I forgot to time myself. Thank you.
Well, thank you, Dr. Ashima. It was a very elaborate and very detailed description of all the protocols. So I'm very sure it will be quite useful, particularly the way you described in detail, what not to do while doing even CPR. So I will not really take much of time. I just want to ask one, are there any questions from the audience, please? Any questions from the audience? Because I can't see there. Dr. Ashima, I'll ask just a small question, and please let's keep the answer a little bit, short. The guidelines of ACLS, do you think they all can be applied directly the way they're applied in other patients, in neurosurgery patients also, or you make some changes there?
Okay, so except for, I would say that if your patient is in no changes except for the fact that catching the patient early is very possible in neurosurgical case, or sometimes it may be very confusing as well, because your patient can be of a low GCS, and so the sudden unresponsiveness may not be found. So hypovolemia is not the cause most of the time with when it is brain surgeries. Mannitol is one drug which I'm always worried whenever I see it going and the pressures being low, especially when you know that blood-brain barrier would be inflamed and may not be active even in your other surgeries except for traumas. So this drug has been noted to cause, with his reflection coefficient of 0.9, is known to cause sudden arrest. Fast aptoin infusions can cause, phenytoin infusions. So I think so it is easy to prevent, difficult to treat, but the applications are the same.
Okay, thank you very much.
And I'm again sorry, I couldn't time myself. Maybe I get so involved in resuscitation. I'm sorry.
Yeah, at the end, as long as the patient survives, it's fine.
Thank you so much.
Thank you, Dr. Ashima. And the next talk is on the learned concept for the treatment of severe traumatic brain injury. And this is by Professor Markland, who is a professor and chairman of 2 departments in Sweden. And he's also the chair of trauma and critical care of EANS and member of the WFNS neurotrauma section. And is the founding vice president of the European Neurotrauma Organization, and is director of the Lubin Labs News Research Lab at Sweden. I'd like to thank him for collaborating with NSI, and Professor Lokendra Singh is the president of Neurological Society of India. And I'll request at the end of the session, both of you to give the concluding remarks also. With this, I'll request you to please deliver your lecture.
Thank you very much. First, I must really thank for the honor of being invited here, and particularly to you, Dr. Panigrahi, for making this happen. I should be honest and say I'm not actually this chair anymore. You're only allowed to sit as 4 years as the chair of the sections of ENS, so I actually had to step down in October 4. So, but I was the chair for 4 years, and I'm a neurotraumatologist by training. So I will address the Lund concept of the treatment of severe TBI. This is how it works in Sweden. We are approaching 11 million inhabitants. We have 6 departments and all have dedicated neuro ICUs. So here's basically where the all severe TBIs are being treated. There are around 100 neurosurgeons. And I was trained in Uppsala, and then I moved around 5 years ago to Lund. So I'm experienced with both different strategies. It's surprising that such a small country has such a diversity in how to treat severe TBI. That's the way it is. I came to Lund. I think it's a pretty famous neurosurgical department in a way. We had first Nils Lundberg, who was the father of ICP monitoring, at least continuously. And you see the old photo here of how it looked like in those days. Actually, Lars Lexell, the father of stereotaxic neurosurgery, was also a professor here quite some years ago. And then what I will address today, which still is quite famous, the Lund concept for the treatment of severe TBI. Our neuro ICU is rather small. We have 7 fully equipped neuro ICU beds for multimodality monitoring and ventilators. All multi-trauma patients are being treated for the first 24 hours in the general ICU. We have 4 broader, well-equipped intermediary beds without the ventilator support. We have at most around 60 severe TBI that's treated with multimodality monitoring. So in that sense, we're rather small. So I will talk about ICP lowering therapies in general, and then come into how we do it, basically, the Lund concept, both theory behind it and our practical management of it. Nothing to disclose. ICP monitoring was addressed by Dr. Hussain. We try to use the EVD, external ventricular drainage, as much as possible. It's a golden standard, but we should acknowledge the infection risk if it's being maintained for more than 7 to 10 days. We can also use it in the parenchyma, but typically we try to use a combination of these, the Spiegelberg monitor, which delivers both the interventricular pressure and the intraparenchymatous pressure. And it's good if you keep the drainage open for CSF drainage, you cannot really trust the intraventricular pressure. So that's our approach. And we know ICP should be treated. It has microvascular problems, a lot of issues for the brain if the ICP is increased. And the guidelines stated that treating ICP above 22 is recommended based on a retrospective study, although it's rather large, was still retrospective. It's level 2B recommendation. We have continued to maintain our threshold 20 millimeters of mercury. And in each of our patients with severe TBI, we use the brain tissue oxygenation and we use microdialysis in combination with the ICP. And textbook styles, we should be aware that temporal contusions or hematoma can cause herniation at rather low ICP readings. We're also aware that if you have infratentorial lesions, we may not be adequately monitored by a supratentorial ICP. So this is our basic setup. Why 20? Well, very well established. ICP more than 20, a much worse prognosis. There's meta-analysis here. It's also good to know if we can treat the ICP down to below 20, that's associated with a better prognosis, which means our efforts worthwhile. We go by the concept that ICP is more than a number. These patients with the rather seemingly normal-looking CT scan, she had B cells lymphoma, and she had papillary edema and headache. So for various reasons, she got an ICP monitor, and the ICP was more than 90 millimeters of mercury when she was awake and talking to us. So ICP is not the only problem within the brain. This is more than a number, should be taken into context. This rather big study as well, more than 4 million 1-minute recordings in moderate to severe, many of those were severe TBI patients. And the most recorded ICP was 8 to 9 millimeters of mercury, and ICP more than 19 was associated with the outcome. And actually unfavorable outcome was associated with lower numbers of ICP than 90 millimeters of mercury. So we take this with a number into the context of the whole picture of the patient. And of course, I personally believe that ICP dose, sort of area under the curve, is much more important than single elevated ICP levels. More the number in combination with the time that it is elevated, of course. But for treatment then, if ICP is increased, well, hyperventilation, We use it infrequently, only for briefly and moderately, 4 to 4.5 kilopascal, and mainly for emergency measures. The same with mannitol hypertonic saline. We use it for emergency use, not for continuous or prophylactic measurement. CSF drainage is very good, but you should use it cautiously if the midline shift is more than 5 millimeters. And of course, we discussed previously in this meeting sedation and analgesia with the metabolic suppression, including barbiturates. I'll come into the details of our protocols. But then, of course, one possibility is to reduce CPP with the aim of reducing edema and reducing the stress. And this is actually the main basics of the Lund concept. Other issues, of course, are in our toolbox. Hypothermia, I haven't used it much. It's very effective for ICP control, but it's very complicated as well. Of course, the surgical management and the fluid balance. We are surgeons, we should always think of the underlying cause of the increase in ICP. Is there anything to operate or to decompress? Of course, that's the basic. And I think we and many other departments use a stepwise escalation of care. We don't do decompressive craniectomy or barbiturates in everyone. We start with prophylactic measures, and as problems get worse and worse, we also escalate our therapies. They can become more complex and they become more dangerous in a way. And I also would argue that all departments should have a protocol. There's no single ICP lowering strategy, perhaps with the exception of decompressive craniectomy, that is shown to improve outcome. But if we have sort of this prevention of ICP rise, the active treatment and the aggressive treatment in some sort of stepwise fashion with first and second tier therapies, I think that's the best way to improve outcome. And we talk about ICP protocols, the Lund concept then. We'll actually introduced at a very small meeting, the Swedish Society of Anesthesiology in Lund. 30 years ago, they proposed a new framework for the treatment of severe TBI. And why was this necessary? Well, we should remember at this time, it was the Rosner concept that was the leading theory. And here the basic was that you should increase the mean arterial pressure and the CPP. Because if you have the cycle to the left here, because they argue that you have lower blood pressure, you would have vasodilation, increased cerebral blood volume, and then increased ICP. Vice versa, if you increase blood pressure, you would have the reverse cycle and reduction in ICP and a reduction in cerebral blood volume. It was like this. You should be maintained at above 70 millimeters of mercury, and you should use a lot of inotropic support to do this. And even started stating that the best result was a CPP approximately 112 millimeters of mercury, which is considered a very high CPP these days. At this time, these two very intelligent colleagues, Karl-Henrik Nordström was a neurosurgeon. They're both retired these days. And Per-Ola Grön, the anesthesiologist and physiologist. They came up with this new idea for the treatment of brain edema, and that will be the cause of raised ICP. And we should be aware that this is basically theoretical physiological principles to be able to control the brain volume and the brain perfusion. So the physiologic principles behind the vasogenic brain edema is first, if you have the normal brain to the left here, if you want detail, you can check out this review by Per-Ola Grön, one of the fathers of Lund concept. But in severe TBI, we have a disruption of the blood-brain barrier. That means if you have increased hydrostatic pressure, I mean high blood pressure, you will force fluid into the extracellular space here and increase the edema. The other important measure is the colloid osmotic pressure. If that's it is low, or at least not high enough, you will have also an increased movement of fluid and solutes from the bloodstream into the brain, causing brain edema. So how do we reduce and take care of these two? Well, first, the hydrostatic capillary pressure. We should then normalize, typically lowering, because in severe TBI, there's a hyperadrenergic state with a lot of catecholamines used. Typically, the blood pressure is raised. So that should be normalized. And the typical method is by using beta blockers and the alpha-2 agonist clonidine. The other two head elevation is used, but not so much the angiotensin 2 inhibition. The beta blockers and clonidine will lower or normalize the blood pressure, thereby reducing the hydrostatic capillary pressure. The oncotic pressure, well, we use a lot of isotonic albumin, and we readily transfuse the patients to have a high hemoglobin content. So this is the basic for the lung concept: antihypertensive treatment, stress reduction, use of albumin, and also in the concept is the avoidance of vasopressors for various theoretical reasons, such as norepinephrine. And when it started, it was basically forbidden to use norepinephrine. That's not the case anymore. This is a basic one. So we accept the CPP down to 50, hemoglobin, try to be as high as, not to go lower than 11 grams per liter. And we want high serum sodium content up to 155. And this is our lung protocol. So every severe TBI, as I mentioned, get the ICP, we try to get EVD, we get the brain tissue oxygenation, and we get microdialysis like this. So if we have problems, this is our guidelines. For surgery, if ICP is high, we can elevate the head of bed now to 30 degrees. We can do some CSF drainage if we don't have too much high midline shift. And we can increase sedation. And we very, very early come in with low dose barbiturates. If we have more problems, we can increase sodium levels even further, give higher barbiturates, even mannitol, but more for emergent reasons. And even we have in our protocols, perhaps not according to my view, steroids, but we very, very rarely use it, but still in the protocol. We can also address the low CPP. Of course, we stop the beta blockers and clonidine if CPP goes too low. And we consider albumin, we consider transfusion, reduction of sedation. And first, really low here, we go in with inotropic support. This is our local guidelines. One danger with the lung concept is too low CPP. So to secure that, we use brain tissue oxygenation and microdialysis for that matter, but particularly brain tissue oxygenation as an extra level of security. And also we make sure the transducer for MAP and the ICP are at the same level at the tragus, external auditory meatus. And this is one important concept. It wasn't like that when the lung concept was started. But because it matters if we have where the transducers are placed. Most studies do not even show how CBP was calculated. And depending on where the transducer are positioned, the levels can vary of the CBP between 60, which is the aim, or down to 43, depending on the level of the head elevation. This is one important measure. Dr. Hussain mentioned the CIVIC papers, good algorithm, and be aware that brain tissue hypoxia can occur even though these ICP and CBP are normal. And you have the different scenarios. And one of these is ICP is elevated and brain oxygenation is normal. We have various parts you can use here. What I sort of highlighted here, that was recommended mannitol. We don't use that so much for hypertonic saline, but also you should perform a MAP challenge to assess the cerebral autoregulation. But some patients do not respond well to the lung concept. Many do, but some don't. And one of the ways to test this is to perform a check of the autoregulatory status. I also like to emphasize the use of brain tissue oxygenation. The BOOST-2 study was mentioned previously. It seems to at least show a trend for improved outcome. And we're eager looking forward to all these new studies coming up on the use of brain tissue oxygenation here. I made a slide a few years back. 3 very neurotrauma oriented centers had quite some changes and differences in their treatments. Beta blockers, we use it a lot. Hyperventilation, not used here so much, only with problems. Head elevation, we don't use it so much as the other centers, for instance. And you see the difference. We are accept a much lower CBP than the other centers. I can also mention here that the wake-up test was used a lot in Uppsala, where my previous department, but not so much in Lund, and I think quite rarely in Cambridge. So one ICP lowering therapy for all? No, I don't think so. This is a good study from my previous department, basically comparing Edinburgh, which is more of the old concept, and the Uppsala concept was more like the Lund concept. Half of the patients would have done better really at the other department. So we need to assess the autoregulatory status in the management decision. So it basically reflects the ICP response to changes in blood pressure. I know we have pediatric talk coming after me, so it should be difficult and dangerous to extrapolate what we do in adults to pediatric TBI. But we have used the Lund concept now for many years, also for severe pediatric TBI, and we are writing this one up, which will be published hopefully soon. And we have excellent results using the Lund concept in severe pediatric TBIs as well. So Lund therapy is a theoretical concept based on the physiological principles of stress reduction and blood pressure, and then CBP lowering for ICP control. There's no single part of it. It's more of a concept framework than anything else, and nothing here has level 1 scientific evidence, as is with most of the protocols for TBI. It probably works best in pressure passive patients, so assessment of autoregulation should be included when we use it. But ICP control, in my experience, is very good with this, but we need multimodality monitoring for security and safety reasons. And it's also evolving. It was not the same as it was 25 years ago. We use norepinephrine these days. We use the autoregulatory status. We have changed the transducer levels, for instance, just in the recent years. So it's an evolving concept in many ways. But I would agree on this. It's still awaiting stronger scientific evidence before it can be recommended as a standard tool for everyone. But it has some good components to it. And some patients do fare very well using this area. That's by ending by recommending this book. We wrote it in the Scandinavian Nerve Trauma Committee. I think it has everything you need to know, basically, on severe TBI. I'd like to welcome you to Lund. We'll actually have a physical meeting in December 13 to 14. We have this Swedish tradition of the Lucia. Will be the ENS critical care update meeting. So I think there's many interesting things for all you interested there. So welcome there. You have the website there as well. And also more will be coming soon from the European Nerve Trauma Organizations. We have just basically started, and we have the website up and running pretty soon as well. So you'll probably hear much about the European Nerve Trauma Organization in the future. But this was my presentation on the Lund concept, and I will be very happy to take questions. Thank you.
Thank you, Professor. I think it was quite an interesting talk, and TBI still remains a big issue all over the world, and more so in India because the road traffic accidents are so much here. So I think it is definitely extremely useful. Are there any questions? There are no questions in the chat box. Any other speaker wants to ask a question? Manas, Muthu? So I think let's move forward.
Sure.
Thank you.
Yeah, means as Professor Markland explained that the monitoring in children is not similar. One cannot extrapolate the adult. Though he presented one slide that they tried that in children also, and it has worked well. But all of us know that the monitoring in adult and children are different. So the next talk is on how the multimodal monitoring in ICU differs in children from adults. And it will be given by Professor Deepak Gupta, who is a professor of neurosurgery at All India Institute of Medical Science, Delhi. And he is also adjunct professor in Indian Institute of Technology at Delhi. And he's a secretary of the Indian Pediatric Neurosurgery Society. I request Dr. Gupta to please deliver his lecture.
Thank you, Manas, and thank you, NSI, for this opportunity. Well, I think many of us with this paper published by Andrew Mas group, And we all understand that each of these tired therapies which we give to our patients for management of raised pressure, let it be simple intubation and elective ventilation of the patient, or CSF drainage, ICP monitoring, and hypothermia, and even barbiturate therapy. Each of these therapies, they do have certain risk and side effects associated with them. And management of each of them does require a dedicated and committed neurocritical care support. Without dedicated neurocritical support, it is almost impossible to give due care to our patients. Neurocritical care, I would say, is not that old in existence. I mean, I would say it's approximately just 4 decades old. Our colleagues in neurology are using these services for management of patients of stroke, patients of AIDPs, GBS, paraneoplastic. But we as neurosurgeons use neurocritical support mainly for prevention and treatment of various secondary brain injuries, maintenance, treatment of reperfusion injuries, and the key role of neurocritical care in our setup is for care of the injured, care of the TBI patients. And recently, there's a lot of interest which has come up in management of brain dead. The usefulness of neurocritical support team in keeping the organs alive and healthy before transplantation. If you talk about the neurocritical care in the children, I would say it's almost empiric treatment. It's mostly non-existent, and dedicated units are almost an exception. The various common neurological insults in children which are being treated in this ICUs are the insults secondary to cardiac arrest, CNS infections, inflammation, and stroke and thereof. And yes, a large population of our neuro ICUs is by the acute traumatic brain injured children. There's very limited data available from randomized controlled trial for management of acute brain injuries in the children. This was a young, I think 18 months old boy who presented to us with a large extradural hematoma of 40 cc within 4 hours of injury. And quite rightly, we did the evacuation of the EDH. And as a part of our institute policy, as the GCS was less than 8, so we did the ICP monitoring in this child. The ICP was high in this child initially, so we gave him some supportive treatment in hypertonic saline boluses and continuous therapy. But then it continued to remain high, so we inserted external ventricular drainage. And then we did a CT scan, which showed evidence of some patchy infarcts or arterial territory infarct on the right side. The CT angio per se was inconclusive. And so we had an EVD insertion done in this child. But later on, this child did require a decompressive connectomy and improved and had a reasonably decent outcome at 6 months follow-up period. This was another child, a 7-year-old girl who had a large posterior fossa hematoma with features of raised pressure. And she also required ICP monitoring, EVDs, posterior fossa decompression, evacuation of hematoma, and barbiturate therapy at the end. So these two patients tell us that majority of the cases in your neurointensive ICU, they require a permutation and combinations of ICP monitoring, external ventricular drainage, and various forms of therapies, medical therapies, and barbiturate therapy in large number of these patients. If you talk about what is the current status of randomized controlled trials or the research, it's an eye opener. We have got large number of randomized controlled trials available in the adult population. However, if you talk about the children, they are just handful or almost non-existent. The key reason being maybe probably limited experience of the investigators or a very small population size in this age group. So we really do not have any robust or randomized controlled trials on neurocritical care setups in these children. Now, we did a very interesting study on looking at the importance of providing kind of a neuro-intensive neurocritical support to our patients based on adherence to Brain Trauma Foundation guidelines. This study was called Chirag study, published in World Neurosurgery, I think way back in 2015, and wherein we showed that patients with the ICU care and ICP monitor, they had lower in-hospital mortality. And when the guideline adherence was increased from 65 to 75%, there was a 2-fold higher discharge survival in our group of patients. Similarly, later on, Monica Bevelala et al. From the Seattle group, they did it as an extension in the pediatric population. And they also identified few protective PICU indicators. And they also noted that if you adhere to the ICU guidelines, there is a definite and discrete improvement in the outcomes. So these two papers tell us very, very conclusively that a very dedicated, committed neurocritical setups, adherence to the guidelines does help you in improvement of outcome in your group of patients. And I think a previous speaker did touch upon cerebral microdialysis. So yes, there is a lot of research has been done, but primarily in the adults. In my center also, we have almost a decade of experience with adult cerebral microdialysis, but unfortunately, I have not done it in any pediatric age group. So we do have answers to many of the kind of biochemical changes, spreading depolarizations happening inside the brain in adult population. But to my knowledge, there is no pediatric cerebral microdialysis study which I am aware of as of now. In fact, at our center, we were able to distinguish these two subsets of patients, ischemia versus mitochondrial dysfunction, based on just pure cerebral microdialysis parameters also, and we could identify therapeutic window also in our group of patients. So I believe this acute brain injuries in the pediatric population is an entirely different gamut. It's a special subset group. The recognition of neurological deficits in children is, I would say, is pretty difficult. There is always a difficulty in decision making because we have by and large only level 3 evidence in pediatric acute brain injuries. Let it be TBI, strokes, or cardiac arrest. The developing brain responses, you talk about neuroinflammation, antioxidant mechanisms, they differ completely in children as compared to the adults. And of course, we do not have any specific goals, like age-specific goals of cerebral autoregulation management in children. Otherwise, like we do have some set of goals available in the adult population, we don't have it in the pediatric population, to my knowledge. And of course, the survival is a very poor measure of success of treatment for pediatric acute brain injuries. And we really do not know the response of neuroprotective interventions because it may require years to assess in this group of patients. There are discrete, unique biochemical, molecular, cellular, and physiological facets of aspects of TBI in this age group. By and large, it is presumed that very young children, they have got higher mortality, probably increased susceptibility of apoptosis to the developing brain or lack of myelination. It has been postulated. However, we were a part of ADAPT study of 1,000 children. We actually did not notice this finding. In fact, in our group, the young children less than 4 years of age had as good an outcome as the older counterparts. So we do not have limited history and examination in these children, and it's very difficult to assess the status in these children, especially more so those who are less than a month of age. Few conditions like battered baby syndrome, they remain undiagnosed, and even in the most busy and highly skilled neurocritical care setups, there's always a reluctance to start invasive procedures, be it insertion of a simple central venous pressure line or arterial line in a young boy, in young children. So yes, this I've already covered about the myelination issues. If you look at the kind of paintings in the 13th century, the children were being portrayed as the miniaturized adults on the left side, if you see. But if you look at the painting by Raffaello Senesio in 15th century, the children were actually portrayed as children. So I would say that child is definitely not a small adult. We had recently published a study of over 5,000 children, and wherein we noted that the severe head injury was noted in 25% of the cases. And the most interesting thing in this slide you will see is that the mortality statistics. The mortality in the severe TBI in our age group, we could bring it down to under 10%, which was a huge change. And this could happen, the overall mortality was 3% when we took the all population together. But in severe TBI, we had a mortality of under 10%. And this could happen only because of dedicated, committed neurocritical care, or pediatric neurocritical care in our setup. So these are the few unique injury patterns you see in this age group. This was a child with a battered baby syndrome who was electively ventilated and managed and made a good outcome. So to talk about the physiology and the anatomical differences, the children, as we all know, they've got very large and heavy heads, and their body to torso ratio is completely different as compared to the adults. They've got smaller blood volume. They're very high, at a very high risk of blood loss. target blood pressure and ventilator parameters are age dependent and strict adherence is required. The complication of intubations in the children are pretty high because of the small size of the trachea. The right side intubation or the lack of intubation of the airways is highly common in this age group. So it is at this place the role of dedicated and committed pediatric team comes into play because unless and until you know these parameters, it is very difficult to manage such children. One needs to watch only for tachycardia in the children because they may not have fall in the blood pressure. So tachycardia may be just the only indicator of blood shock in this blood loss in these children. How to position a child with the head injury is again very, very important. It is again the importance of knowing the body torso ratio and the size of the head. Not many people, I would say, are kind of keen or pro for doing ICP monitoring. This was a very interesting paper published in 2015 in Child Nervous System, because either the children, they improve very rapidly or they are quite moribund. And sometimes, in fact, in large group of patients, the CT scan is normal. So majority of the people say, why to resort to ICP monitoring? But we at our center are very pro for ICP monitoring. And this is one case I wanted to show it to you. This was a 7-year-old child who had a GCS of 8/15, had a fall from height, labor desperation. And if you look at the CT scan on the left side, it looks pretty decent and normal. Cisterns are seen, and there is no midline chip, no intraparenchymal hematoma. We inserted the ICP was high, and immediately we went in and we did a decompressive connectomy, and the child made an uneventful recovery and improved. However, 10 years down the line, I would say that it was probably an overkill, because when in retrospect, we looked at the ICP trend. ICP is not just a number, it's a trend we need to look at, because you need to see how the ICP is actually behaving like. This child had a behavioral pattern of something like a plateau waves, which is more of a vasogenic edema waves, and I think the incidence of this vasogenic edema is pretty high in this population. And so these children can be very well managed by conservative management alone. And this probably is one of the reasons at our center, there has been a significant shift from decompressive connectomy to more of a intensified medical management. We do decompressive in less than 10% of our cases currently. This was another child who had a large multiple skull-based fractures, interparenchymal hematomas, polytrauma, and we wanted to take him up for surgery. However, the child was unfit. He had coagulopathy, so we decided to offer him a barbiturate coma, and he responded well to the therapy. He had some medical issues and some retained CVP wire, for which he required another surgery. However, the child did well, and now he's resuming back to the normalcy at 2 years of age. So this is the protocol which we follow at our center. We classically give our patients phenobarbital at the doses I have mentioned. And yes, it requires very extensive and very committed presence of neurointensivist, be it a neuroanesthesia person or a neurosurgeon with expertise, because you require a very large number of surgical equipments while you are monitoring these cases. There are certain new kits on the block which have come up now of late in measurement of this, in assessment of these children. In the interest of time, I'll skip it. So these are the guidelines which we have developed at our center. We do routine ICP monitoring for 5 to 7 days and remove only if there is no ICP spike for more than 24 hours. And we keep our most of our cases sedated and paralyzed for at least 48 hours. And when it comes to taking off the therapy, one therapy should be taken off at a time, and we do not change more than one parameter at a time. I think rest of the things, the majority of the people can go through my slides and get it later on. So it is with this dedicated and committed care, we have been able to bring down the mortality in our group to under 10% over the last 6 to 7 years. We were a part of the ADAPT trial, and this ADAPT study was primarily, it was actually an observational cohort study. Basically, it was done to test the effectiveness of several aspects of care in the children. And these were the few aims. I'll just quickly wind up. So the two important messages which we have got from the ADAPT study was, one, the CSF diversion. Initially, we thought CSF diversion is associated with the improved outcome. However, what we noted was we failed to find a beneficial effect of invasive CSF diversion on outcome in children with severe TBI. Though we have an existing recommendation in the PTF guidelines of the external ventricular drainage being beneficial, However, if you look at our data of over 314 cases, there was no benefit. In fact, there were more harm with the external ventricular drainage in pediatric population. Second important information which we got from the ADAPT study was the 3% hypertonic saline boluses. It reduced ICP and increased the cerebral perfusion pressure. So actually, hypertonic saline it favored over the menthol, which only increased the cerebral perfusion pressure. So these are the protocols which we have at our place. I think in the interest of time, I'll skip my remaining slide. I just want to say that there are not many assessment tools available as compared to the adult which we have with us. The prognosticator tools in the pediatric population again are not many as compared to the adult counterparts. And if you look at the comparison of the adult versus pediatric guidelines, we do have various, at least 8 or 9 class 2 or the level 2 evidences for the adult PDF guidelines. However, if you talk about the pediatric age group, they're just a handful or other, I would say 3, that too level 2 evidences. And one of them is like hypertonic saline boluses is being useful in this population. Majority of the evidence or the guidelines in the 2019 edition in the children, they are level 3 because there are not enough studies available with us in the pediatric population. These are the few pathways I'll skip in the interest of time. So I'll just conclude with one statement that adult physiology cannot be extrapolated to pediatric brains. Pediatric neurocritical care is quite distinct subset of adult neurotrauma care, and one requires individualized management, and one needs to have a very high index of suspicion. The two important Pegasus and the Chirag study have shown that adherence to Brain Trauma Foundation guidelines, it can help in the improvement in the TBI care, and of course you require dedicated neurocritical care for that. CSF drainage is not useful to improve outcomes, and hypertonic saline is useful in the children. The last slide, I would say that, if you look at the COVID, everybody, all of us are talking about COVID over the last 2 years. We know that COVID infection is different in the adults and as compared to the COVID in the children. In our country, in India, we have been able to reach a 1 billion COVID vaccination mark as of now in the adults. However, we have not yet begun on the children. So I think there are a lot of differences in the children. The COVID respected the children versus adult boundary. And similarly, the neurotrauma and the neurocritical care also, we should respect this kind of segregation between the children and the adults. And I think there's a call for dedicated pediatric neurointensivists and the neurocritical care for improved outcomes. Thank you.
Yeah, Professor Lokender, you're there? Yes.
Yeah. Sorry. I think Dr. Deepak has put forward the whole case of difference between pediatric and adult group injury very eloquently and very in a very detailed manner. Obviously, it was not possible to cover all those slides, but I think we can all see the recorded version of this if one is interested. Are there any questions, please? Because, yeah, okay.
Can I ask one question? What I understood from Professor Markland's lecture is CSF drainage was very useful in his cases, but Deepak concluded that CSF drainage is not useful. Is it something with adult and children, or you also have found the similar experience in adults also?
Yeah, so if you ask me, Manas, honestly speaking, I still resort to CSF drainage in my practice. I just talked about, in fact, this paper we are analyzing currently, but this is just an observation which came up from the ADAPT study. And ADAPT study has got almost, it's a kind of a larger study you can think about, 1,000 children. So probably it's a special subset where the EBD drainage, the CSF drainage did not improve the outcomes. In adults, yes, it does improve outcome. And one thing I can recommend is that at the time of decompressive connectomy, one can insert a EVD and you can do the rest of the surgery better. So probably, yeah, to answer your question, in adult patients, the CSF drainage can have an edge as compared to the pediatric population.
Professor Markland, what is CS? Professor Markland.
Maybe you can comment. I think you're completely right there, because in children, typically they have sort of more brain and less ventricles, so there's less room for CSF drainage, and there's more diffuse injuries in children as well. So you have compression of the ventricular system. So a few cc's of CSF, and then the ventricles will collapse. So there's less room for that, basically. I've used barbiturate coma a lot in pediatric severe TBI. I saw you mention that as well. But what's your take on decompressive cranectomies in children now? Should we be more aggressive? They seem to fare pretty well from it. Or should we still be the very last year therapies on decompressive cranectomy?
I do it very less. At our center, in fact, we have published the largest series on decompressive cranectomy in pediatric population probably 15 years back. But if you ask me now, my threshold to decompressive cranectomy is very, very high. Only in patients with very obvious large structural lesions, I go for immediate DC. But large group of these patients with diffuse brain swellings, I manage them conservatively. Earlier on, these patients with the diffuse brain swellings and high ICPs, we were resorting to unilateral and bifrontal decompressives, but I have practically given up. And yes, you require a very dedicated neurocritical support team for barbiturate coma, because it has got its own share of problems. So if you have a team tuned to medical care, I think many decompressives, and because when we do decompressives, it is not the end of the story, it is the beginning of the story. The problems of cranioplasties, the problems of hydrocephalus, and they just keep on coming and keep on bothering these children. So I think one should have a very high threshold for decompressives in the pediatric population. This is what I have understood.
Okay, thank you. I think Dr. Hosseini has a question. Would you like to ask him, Dr. Hosseini?
Sure, thank you, Prof. We hear a lot about the role of cystinostomy in TBI. What is your opinion or experience, Prof. Gupta, if you could like to explain it?
Yeah, so I have read a lot about cystinostomy. I am not a very keen proponent. If given a choice, I actually believe in doing more of contusectomies. Patients with large hematomas, ICH, and temporal frontal contusions, I'm very radical in contusectomies. The reason being, contused brain is a dead brain, and it sucks in more water. No matter which part of the brain it is like, unless and until you take out that contusion, it is not going to be helpful. So if given a choice, it's very impossible to do a kind of a cystinostomy with a very tight brain and in the middle of the night. And we all must accept very humbly that most of the TBI surgeries are done by the residents who don't have enough experience with the uses of microscopes, with the drills and other things. So I would just put it in the kind of a safeguard list. Yeah, but if there's certain good patients, M5 patients, wherein if I have to just open up some cisterns, I can. But I believe more in contusectomies and very less in cystinostomies. Yes, but I do insert EVD all my patients. It's very easy to insert EVDs in adults, even in very tight brains, because the contralateral brain does get dilated. And so I insert EVD in all my patients, and it really helps me a lot.
Thank you.
Can I ask one question? I am Dr. Suresh Nair.
Sir.
Please.
Am I permitted to ask a question?
Yeah, Suresh, please.
Yeah, what a fantastic morning we had. I just want to ask Mark Lund only. The original Lund concept was to attack the brain water, that CSF, and also the brain blood. And today you addressed how to drive the brain water out. And you told about this hydrostatic pressure you reduce by giving beta blockers, clonidine, etc., and you increase the oncotic pressure also. Very nice. So, and also you told you can vent out the CSF, and you told to drive the blood inside the brain. You told that ventilation is temporary, hyperventilation will not help. But have you thought of some drugs? You know that intracranial blood is inside mostly 70% in the veins. So have you come across any drugs which will compress the intracranial sinuses, veins, at the same time will
still give good cerebral blood flow. Like, originally ergot was a promising drug. Something on that line, have you developed something, Professor Markland?
Excellent questions, very, very elaborate one. In the original Lund concept was dihydroergotamine, which could reduce some vasoconstriction in the cerebral vasculature to sort of empty the brain for more blood. So by that, reducing ICP. That had a lot of peripheral problems and extremity ischemia and so on. So that was abandoned. There was prostacycline also being used. It's still part of the Lund concept in some centers in Sweden. We haven't used it much, but that can improve microcirculation around, for instance, contusions. These are two drugs. I do think when we talk about drugs, I think we should target inflammation. So there are anti-inflammatory drugs, not corticosteroids, but anti-inflammatory drugs. And we have now ongoing studies on an anti-secretory factor, AF16, that's being tested, both in our neuro-ICU and actually in a big randomized trial in South Africa. So for pediatrics, so as well. So that sort of can reduce edema by influencing the ionic pumps, for instance, and by some unknown mechanisms. So inflammation and these ionic pumps could be targeted as part of the Lund concept to reduce brain edema. I don't know if that answered your questions or.
Yeah, thank you. Thank you very much. Thank you.
Yeah, Dr. Muthukumar had a question.
The question is for Deepak. Maybe missed it in your busy presentation, but I think somewhere you said that your threshold for decompressive craniotomy is more now. What made you change that?
Because
why did you raise your threshold for DC in young children?
Because when I started getting my children coming back with cranioplasty issues, with hydrocephalus, with endless problems, that was the time I said, is there any means by which we can avoid decompressive? That was number one. And number two, I started resorting to, because we had access to intraparenchymal ICP monitoring, we had access to bedside CT, we had access to all the advanced neuro monitoring tools with us. So then we started resorting to more and more intensified medical management in the ICUs. And by third to fifth day, we started getting very good results. So when children started improving with the medical management, so we said, why to do DCs? So that was the time we shifted our practice. And now we are getting more and more comfortable with medical management in pediatric population.
With equally good outcomes, I presume.
Much better.
So thank you, Dr. Deepak and Professor Markland for discussing on both adult and child neuromonitoring in the ICU. And now we have the last talk of the day by Dr. Abhishek Srivastava. He has done post-graduation in rehabilitation medicine and also has done a PhD in that. And he is the director of the Center for Rehabilitation at Kokilaben Hospital, Mumbai. He looks at the ability, not at the disability. What is the ability of the residual neurons at the end of all our onslaught and treatment, and how he can rehabilitate them. And this is the most important part of the seminar, because at the end, patients don't remember us, but they remember the rehab specialist only, because they are with them for a few weeks or months. Dr. Abhishek, please give your lecture, deliver your lecture.
Thank you, Dr. Panigrahi, for the kind introduction, and thank you, NSI, for the invitation. You rightly said we get the onslaught, and we live with them for months and years after that. Is my slide visible?
Yes.
Yeah. So we all see scans like this in the beginning. I show you in the end how they are at 1 year post-brain injury. So we all know this concept of axonal injury and cerebral contusions, and we should always remember that the balance of both will determine the long-term outcome of these patients. Also, we label them vegetative very, very early. We should know what is coma, vegetative, MCS, PVS, and conscious state. Why it's important? Because many patients are told at 2 months that you can't recover. But remember, chances of gaining consciousness at 1 year is 50% at 1 month, 35% at 3 months, and 20% at 6 months. So only label them at PVS at 1 year in TBI versus 6 months in stroke or 3 months in HIE. And these patients have multiple deficits. Our job in a rehab is to identify all the deficits in detail and treat them to prevent a disability to happen in long term. So can we change the brain? Was the whole concept. When I was studying medicine, I was told we can't change the brain. Don't waste your time. But now there are concepts. All of you are repurposing the brain somehow. We can start some drugs now very, very early, which can improve better long-term outcome. But what happens in first few months after stroke is very, very important. Brain recruit additional areas to perform new function. Other part of brain takes over function. This ability of brain to change in response to a stimulus is called as neuroplasticity. So what do we do in rehab is to trigger this plasticity by two means, by intensive training, called as experience-dependent plasticity, or new treatments like drugs, neural stimulation, or HPOT. Also, some more facts. Neuro recovery happens in two ways. Spontaneous recovery, first 3 to 6 months. We all know the resolution of local injury, but we can modify now this also by new interventions. Second is functional recovery. It's unlimited, primarily based on training. On rehab, no time limits for that. Same way, neurological rehab can be compensatory or remediation. If you can't walk, give a stick. It's compensation. We all know that. But can we remediate in function? Can we improve cognition, speech, language, solo mobility? Yes, we can, with the help of new interventions. First, to assess these patients in the ICU, you get a call in the ICU. You all know about GCS. You should also know about Rancho Orthopedic Scale, called as RLA scale. It's a good scale of cognitive function, good descriptive tool, help to plan rehab. Most of the patients in the ICU are in 1 to 4. So you get a call when patients mainly are in 3 and 4. You to plan interventions accordingly. Also, a new scale, very commonly used for 10 years, is a JFK Comorbid Recovery Scale revised form, which is 6 subsets of auditory function, visual function, motor function, oromotor, communication, arousal scale. This scale is very important to differentiate between vegetative state and memory conscious state. Remember, earlier they become MCS, more than becoming conscious at 6 months or 1 year time. GOS, we all know about that. Also, good scale is called a DRS scale, which can be used, which is specifically for TBI and can be used from coma to community to track the outcome of your interventions in long term. For interventions, we can do the 6-7 things. First, remove obstacles for the obstacles for recovery, done in the ICU, prevent antenatal complications, sensory stimulation. We'll see one of them in short. A full team is required. We have neurosurgeons here, intensivists here, neurologists here, our rehab physicians, we have nurses, physical therapists, occupational therapists, speech pathologists, psychologists, social workers, nutritionists, orthotists, all require a patient-focused multi-disciplinary team to help the outcome. The main concept of rehab is to focus on 4 major issues. To provide continuity of the medical function, there are 2 which need to be managed. Training for sensory motor function, training for cognitive, communicative, and social deficits, and 4th, psychosocial issues. So the big prescription for rehab, which includes medication, botulinum toxin, pain blocks, corrective surgeries, castings, and whatever therapy is possible. We call this 6-6-6 concept. These patients, when they are out of ventilation, should get intensive therapy. 4 to 6 hours per day, 6 days a week for 6 weeks, even when they are on tracheostomy or in VS or MCS state. You have to bombard the brain to maximize the outcome of your interventions. So we all know some complications happen in the acute stage. Most commonly, multiple ones are there. We all see them every day, but some need special mention. One is PSH. All these patients have intermittent episodes of central fever or tachycardia, tachypnea, dystonia, posturing, which interferes with rehab. The commonly used drugs are propranolol if you have central fever and tachycardia, clonidine if you have more of central hypertension, and bromocriptine if you have more of dystonia and posturing. There's now algorithm available how to treat and PSH and identify PSH, being shown in this slide. Aspiration very commonly seen. Always remember, simple strategies help. We all know that. Thromboembolism, commonly seen. Always remember, 3 things can mimic the acute thrombus in the leg. One is heterotopic ossification around the knee joint, a CRPS is a local injury in the limb, or cellulitis. So always diagnose it properly. It can be a HO or CRPS of cellulitis also. Pressure ulcer care, proper positioning is very, very important. We all know that. Always remember, most of us use these overlays and replacement mattresses. These are pressure reducing devices. Patients still need to be turned every 2 hours. If you're using specialized beds, then turning is not required. But at 95% centers, we're using the first two, still patient need to be turned every 2 hours on that. Shoulder pain, because subluxation is very, very common in these patients. They also have spasticity, rotator cuff involvement, capsulitis, CRPS. You don't use it as braces, it will cause more spasticity. Just put a abductor roll here. You can use electrical stimulation, you can give botulinum toxin, you can give a supraspinatus nerve block. All these things are required to reduce pain in these patients. Abnormal tone, seen most of patients with severe TBI. We know it is deceleration or decorticate. Always remember, avoid pharmacotherapy, and will cause more sedation. Use more physical measures, casting, orthosis, give botulinum toxin, use phenol blocks. These are cost-effective means to reduce spasticity and posturing in these patients, then giving medication which cause much more sedation. Ossification very commonly missed in these patients. It's formation of nominal bone around the joints. It's quite high. People have fractures, more than 2 weeks of coma, many large joints. Most common sites are hip and knee. Triple phase bone scan is standard diagnostic tool. You can use indomethacin for 2 weeks, followed by donate for at least 3 months. If it interferes with the function, you will require surgical DING operation, followed by a single shot of radiotherapy of 8 gray to prevent the recurrence. Bladder we commonly miss in these patients in the ICU. Always remember, if you have a suprapontine involvement only, the reduce overactivity, just remove the catheter, check PVR. If it's okay, you can manage them accordingly. But if they have a pontine or ICI involvement, they can have a DSD. Better to keep a catheter, do a UDS when they're out of the ICU. Then how to make them better? People ask me, relatives ask us, what should I do as a family? It's called as multimodal sensory stimulation. We have auditory, visual, olfactory, gustatory, tactile, vestibular. What sensory inputs are there? So Cochrane review was done long back, which says doesn't help much. Now the new study of Megadal have shown that if you do short burst of multimodal stimulation 5 times a day, 20 minutes, it's much better than doing it twice in a day. So small burst of activity, feedback to the brain is much better than giving it all together once or twice in a day. Pharmacotherapy, always remember, we should not use some drugs because which can affect brain function. Very commonly used drugs in the ICU are phenytoin, clonidine, prazosin, haloperidol. Actually reduce the outcome in long term. Vitamin drug, don't use them, try to avoid if possible. What can be given to improve arousal? The 3 drugs commonly used. Amantadine was published in NEJM 2012 in patients with VS and MCS who got 4 weeks of amantadine in that stage, and they have shown that better DRS scores versus placebo, and you can see more patients moved from VS MCS to moderate disability versus placebo. So it's a good drug to start 100 mg OD-TDS in all patients with VS and MCS. Z drugs, all relatives will ask you, can we start dormitory work? There are some case reports to show that it will help one to be able to wake up from coma, but a longer study have shown not much effects. Even methylphenidate in the last trial, meta-analysis has not shown much results. The only drug which is commonly being used is amantadine right now. HBOT is coming up in a big way in reducing swelling in the brain, especially in the acute subacute stage. For TBI, it's a monoplace chamber which we use. Cochrane review says that you need to treat 7 patients to avoid 1 death with HBOT and TBI. And GCS scores improved by 2.68 points. Now 15 become 12 is important, 8 become 5 is also important. So always remember, it helps. Now, there are some recommendations coming in now in severe TBI in HBOT versus conventional treatment. One of our studies under review right now is 51 patients of which 43 underwent decompression surgeries who were given HBOT 44 plus minus 21 days. They were out of the ICU. Started at that time. The GCS, the GOS, and CRS scales have significantly changed, significantly improved. And you can see here, more than 56% of patients were in GOS or more than 3, which means they were at least in MCS or were able to be conscious but a significant disability. But in severely impaired patients, very good outcome in long term. Tracheostomy has changed significantly. We follow a standardized protocol. So If you have a person with tracheostomy, first do a simple diet. Give a colored fluid called the diet test. You give colored fluid, suction. If it's not coming into the suction, which means he can swallow his saliva, you can just put a speaking valve, a pacemaker speaking valve. A person can speak the tracheostomy and also eat the tracheostomy. And then you can do a fluoroscopy. All of us have X-ray fluoroscopy units. Do a VFSS study. It's a very simple study. You give thin liquid, thick liquid, and some paste and see where it's going. So this is a fluoroscopy. This is your laryngeal inlet. If it goes straight into the esophagus, if it stays there, this is esophagus, this is the airways. It goes straight to the esophagus, comes in front, aspirating. Do this test. You can decannulate most of the patients if you follow this protocol. Also, device called vital stim, which is commonly used now to strengthen the muscles. When patient with posterior fossa involvement with a lot of dysphagia, you even start with tracheostomy and can decannulate most of the patients. Even post-decannulate patients, we improve follow with follow therapy combined vital stim. Music therapy, you all low-cost intervention. It's a big way to support neuroplasticity in the brain. Like this guy, brain injury, very restless and aggressive, but a simple one raga, he calms down and he starts communicating. It should be used with trained caregivers or trained musical therapists, most of our ICUs. One of our small studies which we're doing, we have shown that if you add music therapy with conventional training, people have better GS as well as CRS scales when they are recovering post-therapy. Early mobilization, very important. Guidelines are available now when not to mobilize, when to sit out only, when to mobilize, stand and walk, even in the ICUs. Always remember, early verticality in the ICU is very, very important. As early you can make them stand, they will feel better. And now, if you have postural drop, we always have drug. You can also have something called as a Erigo device, where there's a FES system with a tilt table. So you can start standing very, very early in the ICU. And if any person can stand on a tilt table, even with a tracheostomy or a portable ventilation, can be made to walk as early as possible. These are robotic systems, so robotic treadmill with a body weight support. A person can be made, so this is a treadmill with a robot which can make a person walk. Any person with GCS 8+, even on a tracheostomy, who can stand on a tilt table, can be made to walk very, very early. Early stepping helps significantly to improve these patients. We have two machines called as Locomet in our hospital, and we tried very, very early. In stroke, a lot of evidence has come now, but in TBI, evidence still lacking. One of our studies, 18% of about 21% of patients have improved their walking ability as compared to people who are not given robotic assist training. It's a good way to start early mobilization, followed by early ambulation in these patients with TBI. Just to show some simple case example, this lady with a bad left-side involvement, you can see in the functional MRI study, this is at 6 months. With intensive training and long-term rehab, we're able to promote the neuroplasticity. It's early motor reactive of function. This lady at 6 months is independent. Another boy, FDG PET scan of a brain, you can see still there's nothing much in the left brain. FDG PET, see the CT above. This is at 8 months post TBI, 6 to 8 months post TBI. 3 years is independent. At 6 years, growing up and becoming more independent. So we can summarize to say that you can reperfuse the brain in first few hours. We will do that. We know that the cells have to come down in first few days. Brain child training itself in first few weeks. That finishes by first 3 months. We say nothing happened after 3. But always remember, if you start intensive training in first few weeks, get something new that's called as training induced reorganization. That goes on for a few months up to a year. And that's how people recover. So don't label them PVS at this few weeks and first 3 months. Always remember, PVS and TBI is 1 year, not 3 months and 6 months. So just to summarize, we should prevent, recognize, and treat medical complications. The patient can do rehab. Multimodal sensory stimulation is a low-cost intervention and is more effective done multiple times in a daily, 5 times daily, 20 minutes. Should give trial of amantadine in all patients with GS and MCS, if not contraindicated. Proper tracheostomy care and decan protocol should be started because many patients are sent home with tracheostomies. And then you give the cost of care significantly in long term. We should decannulate for a protocol. It reduces the cost of care for these people. HBOT, if common intensive neuro rehab, evidence is increasing right now. Music therapy, low-cost intervention taught to the family helps. Early mobilization, early training on robotic assisted training can get a better mobility outcome in long term. So just to summarize, we were told initially in rehab only compensation strategies. If you can't walk, give a stick. If you can't talk, see sign language. If you can't eat, go to tube. What it led to, further learn non-use. What Dr. Manas wrote in the beginning, you're targeting only on patient disabilities. They have abilities, but they never use them. So current focus on rehab to treat the impairment, treat cognition, speech, language, swallow, mobility, pain, genital trouble, all with the help of multidisciplinary team, can actually prevent a disability to happen. That's the motto of the hour. Thank you very much.
Thank you, Dr. Abhishek. Very nice talk and very different than what we do. So it was really eye-opener. This hyperbaric oxygen therapy, because you have included it as a part of acute rehabilitation.
Yeah.
So what do you mean by acute? I mean, how early you start? A patient is still in ICU, or when he's shifted to ward, or when he's discharged?
No, we start the day patient is off ventilation. After 24 hours, we assess them again. They don't require 24 hours of ventilation. We did them for the HBOT very, very early.
Now, how you do monitoring, and because these patients can always deteriorate, because they are very soon after.
So we have a trained physician who sits in the HBOT room only, and he's a HBOT trained physician now for last 8 years. So in the first few trials, he's always there.
So you have a different setup for HBOT. It's not in the ICU setup.
No, they come out to the ICU and they get the HBOT. They go back in the HBOT in the room. The separate physician who sits there to monitor these patients.
How long? What is the duration like?
So there are protocols. The brain protocol is for 2 ATA 60 minutes.
Okay. Any questions from other people? Yeah, Manas.
Yeah. Do you have a rehab person posted in the ICU 24 hours a day, like 8 hours round the clock?
We have from 8 to 8.
No, but if we think of rehab, I mean, they need a 24 hours rehabilitation. As you told, 5 times a day is better than 2 times a day. 2 times 50 minutes is less effective than 20 into 5. But so to be effective, is it not recommended that one has 24 hours rehab in ICU?
At present, our policy is for it's always better, but people also.
What I'm telling, what will be the ideal thing? That's what I'm asking.
The patient is sleeping.
Leave us out the logistics.
No. 8 to 8 is 12 hours. That one, all of the patients are also awake. They also need rest. So nighttime, we don't do anything with those patients. Basically, daytime.
But night, all the ventilated patients and all those, the chest physio.
They will need some chest care. For that, therapists are available.
And DVT prophylaxis, it doesn't help.
Pardon?
The DVT exercises in the night to prevent DVT.
We all follow mechanical means now, putting a float-on pump or a dead stockings along with that.
Okay. One of the other common question asked is like the trained reorganization. How many years it can happen?
So there are some different concepts. If you see motor versus non-motor. So motor functions, whichever muscles have some movement, that will in first 6 months can come up to 2 years. Versus non-motor, cognition, speech, language improves up to years. We have patients who got global aphasics at 3 months, 6 months. They'll at 1 year, 2 years, they start improving. At 5 years, 6 years, still improving. So cognitive function, speech, and language will improve up to long term versus motor function, which will not change much beyond 6 months. But most of the time, what happens? People have motor power, but because of significant tone abnormalities, they're not able to use that power. So if you treat spasticity, rigidity in a much more effective way with medication, botulinum toxin, it should be published. People who were more than 6 months post-stroke and TBI, up to 10 years post-injury and strokes, When they were trained for 6 weeks, 1/3 learned to walk because they didn't get rehab in the acute stage, and they have all secondary complications possible, which are not making them fall. So if you treat the complications, they have some inherent ability. And if you then use technology, you can get mobility back. At least the supervised mobility indoor is still possible.
Yeah, Professor Markland had a question.
Yes, thank you for a very nice presentation. I was just curious about the HBO treatment. Maybe you said that, but when do you think the time window is? When should you start after TBI, for instance? You know,
We should start whenever
you have a window of efficacy, or
So the current guidelines say that you should start as early as possible, and we start the day patient is 24 hours off ventilation, because our machine, we don't have a ventilation assisted system. They're 24 hours off ventilation. Then we see them on the next day. If they can manage 1 hour without suction and their basic human parameters are okay, they are taken in the machine. There are also newer machines now which you can take patients with the ventilation also. But our machine, we only can take patients who are at least 24 hours off ventilation, which might be day 7, day 14, day 21, depending upon that.
Yeah, if there are any other questions, before you conclude, have vote of thanks, I'd like a few concluding remarks from Professor Markland, Professor Muthukumar, and Professor Lokendra Singh.
We should start. Should I start? Okay. Well, thank you for organizing all this. I think it's been a fantastic day. It was an excellent balance between research and clinical practice. And I must say, I'm really impressed with both the level of presentation, and also the possibilities of neurocritical care, both care and research in India that you have shown today. I think it was excellent. I understand there's a lot of both problems in terms of the number of cases in India, but also endless opportunity to really move the field forwards. As we discussed today, there are many issues we just simply don't know so much about. So the only way forward is to collaborate and to do more studies on the topic. Even though I'm not the chair of ENS anymore, I will still continue to be involved with the ENS trauma section. So I will be very happy to continue the collaboration with NSI, and also when we really get going with the European Neurotrauma Organization, that could also be a good possibility to extend collaborations with you and everyone involved, because it's really needed, the collaborations between centers and regions of the world. So. But I also need to say that even though we really try to refine our critical care, which we should, we need that to improve outcome. I think the last presentation was also really important. We do need excellent and continuous rehab to really improve the outcome of our patients. So that should not be forgotten. Surgery, acute, everything, but rehab is also extremely important in improving TBI outcome. Sorry. So after all, thanks a lot. I'm honored to be part of this, and on behalf of myself, the ENS, Dr. Hussain, we're happy to be invited here. So thanks a lot.
Thank you. Dr. Muthukumar.
Oh, first of all, I should thank the Board of Education of NSI, led by Manas and his team, for arranging this wonderful program. The topics covered were wide-ranging. All the speakers spoke very well, and there are a lot of take-home messages, and I certainly learned a lot. And on behalf of NSI, it's my duty to thank EANS and the faculty from EANS for participating and actively discussing several topics. And I think all the participants should have enjoyed this session. So I think the recording is also available for those who missed out. They should be available in our website as well as in the NSI YouTube channel. Thanks to one and all.
Yeah, thank you, Manas. I think it was a wonderful topic, as suggested by Muthu. It is not, the routine topic. So I think we need to really such topics which are exciting and new topics. Otherwise, all the time we talk about aneurysms and meningiomas and all those things. So these are very exciting topics. As Muthu said, everybody talked. It was a 360-degree coverage of all ICU-related issues in every respect. And I think there's a lot to take from this whole session. And I think 3 months training, as we were discussing, for the neurosurgeons, I don't know how much useful it will be. Probably it will enable them to talk logically with the intensivist. Probably it will enable that only, because half-hearted 3 months training will not make them an intensivist, but they will understand how to talk with the intensivist and how to discuss at the common platform. This is what it will do. I don't see in the near future, at least, that any neurosurgeon will convert oneself totally into neurointensivist, leaving the surgery. I don't see that, because neurosurgery remains very, very exciting branch, and with a lot of stimulations and tantalizations. So it does, but probably maybe in future, when the neurological intensive care and neurosurgical intensive care will start bifurcating the way science progresses, maybe that day will come. But certainly 3 months training, I think it will be very, very helpful, very useful for the residents to understand the nuances, so to talk logically and discuss logically with the intensive care specialists. And thank you very much for giving me this opportunity to address. Thank you.
Professor Suresh Nair is there. He always gives a good feedback of all the sessions.
I echo the words of Muthukumar and Lokendra Singh, and I really enjoyed the talk, all the talks. And thanks Manas and Muthukumar for including the talk which I wanted was status epilepticus. That was my suggestion. And what a talk he gave. And I loved all the talks. I learned a lot actually. And thanks that you could get Mark Glenn for this session, and it was very informative, so many things, and we should thank him for joining this webinar. Thank you, Mark. Thank you very much.
Yeah, Dr. Anand, Dr. Ashima, are you there? If you're there, you can have your videos on for a group picture. I can take a screenshot. Yes, Anand, you are there?
Okay.
Anand is left. I'll take a screenshot and send to all of you. Yeah. I'd like to thank Dr. Suchanda, who has helped me in organizing. Both of us have planned the program, and then I'm sure all of you would have realized that she has done active part in doing, conducting in a lucid way. Then I have to thank Ifti, Dr. Ifti, who has been in contact for the past few months to be in touch with Professor Markland. It took almost 6 months for us to organize this program, to find the right person. There are a lot of people who actually suggested good speakers. I'd like to thank all the speakers who spent this Sunday. Only we have present Dr. Abhishek, Dr. Gupta, and Dr. Ashima, and Dr. Anand. All have left. I'm sure they'll see this. I'll be sending them thanking letter. But it was very good for myself also, because all the time listening to meningiomas, aneurysms, and then but then this is a different topic which we need to learn, and we practice, and then we have to learn. And Dr. Ashima, like doing CPR every 5 years, we need to have a SALS training. It is not mandatory in India, but that is why I had included that topic, so that we don't forget how to do CPR. I'm sure we have not done CPR for many years, and if we have problems, we see in a patient in front of us, we cannot do it unless we have a continuing medical education. I'd like to thank NSI, Professor Lokendra Muthukumar, for accepting the concept and going ahead with the idea, and Professor Markland and Dr. Ifti for coordinating from ENS side. And Professor Suresh Nair is always there in the back, giving positive criticism to improve all the time. Before I conclude, I'd like to thank INTAS, Mr. Jagrup, and Mr. Vishal. Jagrup, you are there?
Sir, I think Jagrup sir is not there, but I am there, sir. Vishal.
Okay, you can put on your video. So they looked after the logistics of the program. And Dr. Suchanda, you want to give any concluding remark?
I think it was very informative. There are a lot of, only it makes you realize that you have learned so many things. The learning will never stop, and every day you deal with this, and there are so many things which I realized today that we are actually not doing correctly. So I think we have to do a little more studying and learning, as I suggested, that we all need training in neurocritical care, no doubt about that, before we manage our patients effectively. So that's all, and thanks all the speakers and everyone for a wonderful speech.
Thanks everyone. Have a good weekend, and happy Karwa Chauth for people who have the festival. Initially, we planned to have it in the evening to so that it is convenient for the European people. But then I realized that it's a big festival in North India in the afternoon today. So then I insisted to have it in the morning.
Manas, cricket match. India is playing Pakistan. So hopefully it will be icing on the cake if we can win. And wish Indian cricket team a good day today. Thank you.
Yeah,
And
I wish the India wins today.
Yeah.
Means we support India today. All the ENS members, NSI members support India. I'm sure if you'll.
Yeah,
you're from
I'm
Pakistan.
a
I don't
supporter
know.
of India.
Okay.
Thank you. Thank you very much. Bye.
Bye. Thank you and bye. Namaste.
Rohit, please stop the meeting.
Thank you, Vishal, for.
Thank you, sir.
Thank
It was
you.
a pleasure.
Okay. And can you let me know this thing, no, the attendance, how many people attended and all that?
Sir, I will send you the entire details. How many people have registered? Okay.
How
the
many
names
registered and how many attended? That you can send me in WhatsApp or email.
Okay, sir. I will send it, sir. Yeah.
Thank you.